Once again, welcome you all to the City of Joy.
A very good morning to all. Hope you all have enjoyed our yesterday's session that has started with Accessible Mental Health Care for All by Dr. Shomik Parnopal and continued by one after another enlightening sessions, Human Rights and Mental Health by Dr. Ramachandra, integration along with our short oral communication that is presented by our valued participants that added well to the amount of everyone's knowledge.
Now, we can dive into our promising schedule for this day. So please have a glance at today's program schedule, and that begins with our first session on legal aspects in mental health care and role of nurses. We are honored to invite Dr. Debashree Mukherjee, Dean Department of Law, SNU, our first speaker of the day, to come on the stage and share her valuable insight. Ma'am, please. I also invite on stage Professor Dipanita Sengupta, Acting Principal, Government College of Nursing, Purbo Bardhaman Medical College and Hospital, as chairperson for this session. Madam has more than 20 years of experience in the field of nursing and has been guided many research projects of postgraduate nursing students also.
Thank you so much, ma'am. The stage is yours.
Good morning. Good morning to Madam Redema and all the dignitaries of the Ispn member and the participant and the organizer. This is a lovely day. This is the second day of 23rd National Conference of Ispn. Now, the session, second day, first session will start. I will tell the session will be started with Dr. Debashree Mukherjee, Dean, Department of Law, SNU, our first speaker of the day, to come on the stage and share her valuable insight on legal aspect in mental health care and role of the nurses. And she has over 22 years of teaching experience and 6 years of practicing experience before the Honorable High Court at Kolkata and the West Bengal State Administrative Tribunal. Madam has been the recipient of gold medal of both postgraduate and undergraduate level, and she has published around 27 articles in edited volume and various law journals, and has edited 12 books on various aspects of law. Her research interest areas include environmental law, human rights, constitutional law, and arbitration law. Now we will be enriched by the speech of the Madam Joycey Mukherjee. Thank you, Madam. Please, you start.
Hello. Yes. A very good morning to one and all. At the onset, I would like to thank the organizers of the 23rd Ispn National Conference, which is being held today at our esteemed institution, Sister Nivedita University. And I take this privilege to thank the organizers for giving me the opportunity to interact with one of the most respectable professions of our country. You, as a fraternity, are always very important for the nation to survive. And before I start my deliberation, I would like to personally thank each one of you for the commendable efforts that you put towards protecting the health of every human being that is there on this earth. So without further wait, Let me first share with you the manner in which I shall be deliberating on the legal aspects of the Mental Health Care Act and the role of the nurses. I shall first try to give you a glimpse of the state of mental health, both at the international level, at the global level, as well as at the Indian national level. And thereafter, I shall be bringing forth before you what are the challenges that are being faced in the access to mental health care in our country. And it is only after, in this backdrop, that I shall be trying to discuss with you the provisions of the Mental Health Care Act. And as I delve into the provisions of the Mental Health Care Act and discuss them with you, please note that being a person from the legal fraternity, this entire deliberation will not only be putting a focus on the kind of treatment or health care that is supposed to be given by you as a nurse in this profession, as a caregiver, as a service provider, but I shall also be trying to throw light on certain things that you should be doing to also protect your dignity and your position in the profession. So I shall be basically having this discussion from two perspectives, one from the side of the person who is suffering from a mental illness, and one from the side of the nurse or the service provider, how that person also in these challenging times should also be taking certain measures so that the professional experience at the end of the day becomes a really gainful one. So first, let me share with you the present state of the mental health condition across the world. And we start off with these statistics. As per the National Mental Health Survey conducted in 2016 by NIMHANS across 12 states of the country, what has actually been reported is approximately 150 million Indians are in need of intervention to support their mental health. And please note the year, it was in 2016. Post this, we had the pandemic, and there is not much to be discussed because everybody who is present in this hall and outside, everybody is aware that the pandemic has taken its toll on every single human being on this earth. So the pandemic gave an even bitter blow, and we have seen reports, we have seen discussions and deliberations in different forums where it has been highlighted that mental health issues have been part of every individual's life in most cases. Every family to a certain extent has been the sufferers of anxiety, depression, cause of concern, and the most important stakeholders who have been largely affected by this constitute the adolescents and the geriatric population. The adolescents, because of the shift in the kind of the role that they are facing from the child to becoming an adult, and with the change in the hormonal balance and imbalance, that has also affected their growing years. Coupled with it, their sense of right, their sense of activism also seems to be made more vocal and more visible in these years of growth. And hence, the adolescents today are in always a state of mental stress, I would say, which they need to balance by themselves, and as family members and as health providers, we also need to support them in this initiative of theirs. Coming to the case of the geriatric population, that is the senior citizens of the nation. Today's speedy life has at many times created roadblocks in their development, and what we observe is they are sometimes left lonely, sometimes left alone, sometimes left uncared for, and even though we have legislations that actually try to uphold the rights of these senior citizens, what we find is in most occasions they are not aware of these legislations, forget the rights that are given to them in these legislations. So a proper evaluation of their situation in terms of mental stress is that they are in a state of instability, which is necessarily a precondition which manifests itself through various conditions of mental illness. I come to the year 2022, and as per an international NGO Children's Hope Chest's report of 2022, 970 million people around the world struggle with some mental illness, and what has been projected is that the future is even bleaker, as 1 in every 4 people will be affected with mental illness at some point in their lives. So these discussions are happening at the right time. And it is not that we should stop only at the level of discussions. This is a foremost orientation that we should have in our minds, that we need to take care of our own mental health and also look at the mental health of the people around us and ensure that their health is simultaneously protected along with ours. Coming to the look at the different mental issues and their impacts worldwide, these are statistical figures, and 2023 onwards, they are definitely on the rise. Depression affects over 300 million people worldwide, regardless of culture, age, gender, religion, race, or economic status. More than 75% of people in low and middle income countries receive no treatment of depression. I will come and try to discuss on this more as I delve into the provisions of the Act. Suicide is the 4th leading cause of death among people aged between 15 and 29 years. Please mark my words. The census report, the current census report says that India's major group of population belongs to the age of 29 years. 284 million people suffer from an anxiety disorder worldwide, with women being affected more than men. In the first year of COVID-19, global prevalence of anxiety increased by a massive 25%. And one of the world's most developed countries, the United States of America, has the highest global death rate from mental health issues and drug abuse. So, I am not standing here to scare you. I am not standing here to tell you that we are on the brink of death. I am only trying to manifest before you that we are addressing an issue which is of grave concern, and it is time that we join hands. And when I say we, I do not only mean people of the health fraternity, I mean people in general belonging to whichever fraternity he or she is, belonging to any nation that may be, belonging to any race, religion for that matter, to join hands and address this issue so that we can reduce the numbers, if not able to totally mitigate it. What is the Indian scenario with respect to mental health issues? Let me now go across this. In India, the mental health issues are prevalent just like in the global framework, and it cuts across age groups, socioeconomic backgrounds, and geographical regions, impacting individuals from all walks of life. Yes, we do understand that, again, as per the census report, 40% of Indian population is below the literacy levels. So lack of education is definitely one of the causes that aggravates mental health, because whenever we fall sick, we consider ourselves falling sick when there is some physical uneasiness that we are facing. When we are in a state of anxiety that it is beyond our control, when we are getting angry for every drop of a hat, we do not consider these as health ailments and that they should be given attention to. So yes, these are areas of concerns which we need to address. And estimates suggest that nearly 15% of the Indian population grapples with some form of mental health issues. So you can consider this is quite a big number, considering the population that we have of 140 billion people. The consequences of these mental health challenges reverberate throughout the society, and they have individual implications. They have implications from the standpoint of the family, societal implications, and also a nation as a whole suffers because of it. Moreover, the mental health problems substantially affect the overall functioning of communities and the nation. Why community? Because an individual is part of a family is part of a community, and because of the isolation and because of the information gap, because of the communication gap that remains between the the person with the mental illness and the family as well as the community, it actually reaches us to a position where early intervention is not possible. Of course, now that we have started to acknowledge mental health as an area of concern, we need to work towards addressing the issue. And of course, being a part of a developing nation, the financial burden, the economic burdens associated with mental health problems cannot be overlooked. Yes, there is a need of technology, there is a need of imbibing of upgraded technology, equipments, resources, human resources for that matter, and that is scarcely available in our country. If we look for a comparison between the number of people who are falling ill and the encompassing of the areas where they are falling ill, beginning from the urban to the rural to the remotest parts of the country, we still do not have a proper mechanism by way of which we can address the issues of these people all around the country. Beyond the economic aspect, they also have far-reaching social implications because of the lack in communication. What happens is there is no proper addressing of the issues of mental health. It results not only in various health ailments, but it also does not allow these people to communicate with one another. There is a stigma associated with mental health, as a result of which people find it very difficult to communicate and pass on their conditions to others so that they can seek help from them. So timely help is not there, as a result of which there is a multiplication of the various manifestations of the issues pertaining to mental health. And the final blow perhaps is dealt with the cultural beliefs and traditional practices, because these actually hinder any kind of proper developments in the field of mental health, and as a result of which what happens is there are various kinds of practices that get developed in the community, which instead of helping in the positive addressing of the issue results in negative practices being followed and also results in more deeper issues to be tackled. So considering this situation, what we need to now understand in totality is what are the actual challenges to the access to mental health care in India. The first challenge that I talk of is the shortage of mental health care professionals. Yes, let me tell you that today the subject psychology or psychiatry and the distinction between these two subjects are to a certain extent being known by the people in the urban belt. But even today, in most households, people do not very clearly understand the distinction between the subject psychology and psychiatry. And the moment there is a discourse on there is some issue related to the mental health which needs to be looked at, the person is not behaving as he should do, he is becoming super impulsive, the immediate reaction that we get is, am I going mad? Is he mad? Does he need to go to a psychiatrist to look into it? These kinds of answers basically makes us realize that what is the temperament that still the society is left with. We have to first educate ourselves that there is a difference between these two subjects. The people of this country need to be made first understood that there is a distinction between mental illness and mental retardedness. Unless and until we know the distinction, we understand this distinction, it will not be possible for us, howsoever fruitfully we try as service providers. I am here stepping into your shoes and saying I, but so far whatever steps you may be taking to initiate a process whereby you address the issues, it will recuperate again and again, and we will be facing the same problems again and again. Inadequate infrastructure and resources. Today, there is a shift. There is a shift from the understanding that there is a sense of compassionateness that needs to be imbibed into the system when we are talking about the treatment and care of the mental health of the individuals. And therefore, what is more important is to establish more outpatient clinics to ensure that they are fully equipped. There is no dearth of equipments and the resources. It is also important that community-based centers, clinics be developed, which actually try to address this issue at a very grassroots level. The lack of awareness and pervasive stigma that I was talking about, it not only creates a communication gap, but it also creates a gap in the understanding and the respectability towards the right of equality that all people across the globe have. The moment we come across an information that there is a person who is suffering from a mental illness, immediately the first reaction is seclude the person, segregate the person, confine the person, instead of trying to address it in a holistic manner. This attitude, this negative attitude of ours that is there in the society has to be taken note of and has to be taken care of. We should understand that at the end of the day, they are also human beings like me and you, and they also need to be respected. Primary healthcare system does not fully integrate mental health care as we do the physical healthcare system, and that is something which is necessary to a very large extent. As I go forward with my deliberation on this, I will try to emphasize on it more. And another very important area is gender exclusion. Now, when I talk of gender exclusion, I emphasize on women, but today we also have a third gender that is coming up, and they also have serious mental trauma issues, right? What stands visible before us for many, many years is women because of their lack of decision-making power in the rural and the remotest parts of the country, and because of their familial obligations, and because of the lack of employment or education opportunities in those parts of the country, and because of the position of inferiority with which they are educated. They do not pay focus to their own health issues, and their health issues are also not focused by the family. Of course, the urban sector definitely has a different story to narrate in many parts of India, but we have to ensure that this exclusion of the third gender and of women needs to be attended to wholeheartedly. What are the international legal interventions? I shall first talk about what are the initiatives that have been taken at the international level, only to make you understand that in India, when did we actually start to pay more focus on mental health, and what have we actually done so far in terms of a legal regime, so far as creating a mental health regime to look into the mental health issues of these people. The first thing that the international legal scenario has made us understand is there must be an approach of respect towards both the patient and the service provider. This is where I started my discussion, that it is not only the person with mental illness that is important. Yes, it is for him or it is surrounding him that all laws have been made. But at the same time, we also need to look into the issues that the service providers face. And if the issues related to the mental health of the people who are suffering has to be catered to, and equal importance and focus also needs to be given to the issues faced by the service providers. So beginning from 1945, when the United Nations was first established, the United Nations has made concerted efforts to address the issues of health, if not mental health, from its very beginning. And I would refer to two very important years, that is 1948 and 1966. In 1948, the Universal Declaration of Human Rights, or the UDHR in short, was given to the world, and this is nothing but a document which talks of non-binding human rights. There is a list of 30 such rights, one of which is the right to health. The right to mental health is not specifically stated, but we take it that it is inclusive in this definition. And Article 2, I would like to emphasize what it says of the UDHR. It says that every person is entitled to the promotion and protection of his fundamental human rights and fundamental freedoms, irrespective of gender, caste, religion, race, sex, place of birth, or other status. I would like to focus on this terminology, or other status, and I would like to here include the person with mental illness. That a person with mental illness has also been included as inclusive into this definition, and his rights and his fundamental freedoms cannot be compromised with. Coming to the year 1966, this was the year wherein, for the smooth implementation of the Universal Declaration of Human Rights, two other international documents were laid down. One, which is known as the International Covenant on Civil and Political Rights, and the other, which is known as the International Covenant on Economic, Social, and Cultural Rights. So summing up, I can say that all the 30 rights that are included in the UDHR, for their smooth implementation, two separate international covenants had been made, and the right to health is part and parcel of the International Covenant on Social, Economic, and Cultural Rights. And being an adherent and being somebody India being a nation which is a member of the United Nations and which has signed the Universal Declaration of Human Rights, it is the incumbent duty of India as a nation to take steps towards promotion of mental health. Coming to the year 1991, United Nations Principles for the Protection of Persons with Mental Illness and the Improvement of Mental Health Care. Again, the United Nations takes another initiative where the United Nations lays down cardinal principles whereby health care of the mentally ill patients need to be paid more focus upon. And in 1996, the WHO raised down 10 cardinal principles of mental health care, which includes within it the right to liberty of the person with mental illness. I stress upon this point because this is the space from which all the rights that we will be discussing under the Mental Health Care Act will stem from. In 2005, the WHO has come out with a resource book on mental health, human rights, and legislation, which is a very important book and which actually gives you detailed explanations on different mental health issues that are being faced in different parts of the globe. And you as service providers can very well take help from the various kinds of accomplishments or the kind of initiatives that have been taken by service providers across the globe to deal with different mental health issues. 2006, a very important year from our discussion, with respect to our discussion on the Mental Health Care Act of 2017, because it gave us the Convention on the Rights on Persons with Disabilities, and it was in 2007 that India signed this document, and this convention became effective from the year 2008. You might be thinking why I am stressing on the years. I'm stressing on the years only to make you understand how important did we as a nation consider the scope of mental health, the concerns of mental health. Coming to the national interventions, since we have signed and ratified the UN CRPD, it is now our prerogative. So since the year 2007, it was our prerogative to make a law so that we can look into the issues which is much more needed for the promotion of the rights of the mentally ill patients, and the nation needs to do something about it. So what did we do? We brought in a healthcare bill. Please look at the years. That will tell you that where are we positioned. I don't want to comment to make you understand where we are, but you as a nation, as an educated nation, needs to know about it. So 2007 we signed, 2013, we drafted a bill. And in 2017, we had this act after 134 official amendments. So yes, the positive side of it is, once we made the draft bill, we became serious about it. There was a lot of deliberations on it. We tried to make it more patient-friendly. We tried to ensure that, yes, the concerns of mental health be taken note of and be addressed in a very great manner. And that is the reason perhaps there are 134 official amendments. But you should also keep in mind that there are various bureaucratic challenges also which were a part of these amendments. So in 2017, this law was enacted, but we brought it into force in 2018. So there is a gap. We were not active in the manner that once the legislation was passed, we came out with a notification and we understood that we were already very late about it, and even then we took a year to bring it. Now, what are the objectives of this legislation? This is important because as I take you through the provisions of this legislation, you need to understand that all the provisions that will be discussed, the objectives of this legislation talks about two objectives which are supposed to be the purpose for making this legislation. The first is looking into the healthcare needs of these persons who are suffering with mental illness, providing them with a proper arrangement of care and support. And the second is protection, promotion, and fulfillment of the rights of the persons with mental illness and connected and incidental areas therewith. Now, this last part, connected and or incidental therewith, is perhaps where you fall. Perhaps where your issues also needs to be taken note of. So, this legislation from the objectives becomes very clearly understood that it is a pro-patient legislation. It basically tries to highlight and portray the various kinds of issues that a person with mental illness faces, and that as service providers, what is to be done under the law. Because towards the end, I will also discuss that if you do not perform your obligations, what are the penalties associated with it. So I cannot say that this is a legislation which is trying to talk about both the service providers, look into the issues of the service providers as well as the patients, but it has been drafted from a human rights perspective of the person who is suffering from mental illness. We should not forget that every human being has human rights. So what is the main intention of this legislation? The main intention of this legislation is to ensure mental wellness. What is the ultimate aim? To ensure mental wellness, not to come out only of mental illnesses, but create an ambient atmosphere of mental wellness, social justice, and equality. There are various authorities that the Act talks about who will play leading roles, from the appropriate government to the Central Mental Health Authority, the State Mental Health Authority, the Mental Health Review Board, and they actually have been provided with proper composition and definition, and their functions have been appropriately defined under the law. I will not get into it because that is not the subject matter of my discourse today. So let me now take you through the law to make you understand where should you pay more emphasis upon, what are the areas which should be of most concern to you, not only from being patient-oriented or patient-centric, but also from the standpoint where you should also see that your profession, your position in the profession is secured. So there has to be a correct understanding and interpretation of the terms mental illness and mental health care. Both these two terms have been defined in the Act, and I first take you to the first definition of what is mental illness. So before we, legally, you must be having your own medical, parameters for ascertaining the mental illness, whether a person is mentally ill or not. But since I am having this discourse from the legal perspective, I will be emphasizing on these points. If you look at the definition that the law states, it says that it is a substantial disorder of thinking, mood, perception, orientation, or memory that grossly impairs. I am stressing on few words. What is mental illness as per the Act is, there has to be a substantial disorder. And what would be considered as a substantial disorder is that when this disorder is reflected in the fact that it leads to gross impairment of your judgment, behavior, and your capability to recognize reality. So my simple question is that if I am in the early stages of mental illness, where maybe there is no great, reality check that can be done, that whether I am mentally ill or not. On one hand, the law says early intervention is necessary. But if we look at the definition does not actually, I think the definition needs to be re-looked into. And this needs to be differentiated from mental retardation. The point that I made a little while ago, the definition does say it. It says that mental illness does not include mental retardation, which is a condition of arrested or incomplete development of the mind, specially characterized by subnormality of intelligence. Now let me take you to the next definition, mental health care. It includes an analysis and diagnosis of a person's mental condition and treatment, as well as care and rehabilitation of such person for his mental illness or suspected mental illness. So maybe the second definition of mental health care is better than the definition of mental illness, because if we go to the last part, suspected mental illness, that somewhere gives us the idea that early intervention also needs to be made into this area, and it basically talks of issues pertaining to mental health which are in the early stages of intervention. Caregiver, a person who resides with a person with mental illness and is responsible. I don't take you through the definitions of a psychiatric nurse and all, because all that you know. What are the essential qualifications you know. I am more trying to legally abreast you with points of concern which you have in your profession. So a caregiver means a person who resides with a person with mental illness and is responsible for providing care to that person, which includes a relative or any other person who performs this function, either free or with remuneration. Now you, as a person from the nursing fraternity, are very much working in hand to hand with these caregivers. So please understand that your role does not stop in only performing your duty as a nursing professional, but your duty also gets extended to work in a collaborative spirit with the caregivers and create an atmosphere where the issues pertaining to the mental illness of the person are addressed. Now, here I come to a very, very important point, the definition of informed consent. Let me first take you to the definition of consent that the law says. It says, consent is said to be free when it is not influenced by any external influences, which include force, fraud, undue influence, misrepresentation, or mistake. Now, let me take you to the definition of informed consent. It says, consent given for a specific intervention without any force, undue influence, fraud, threat, mistake, or misrepresentation. Now, each of these connotations that you find here, force, it means we are talking of physical force or some kind of a mental force that is being put upon the patient or his nominated representative or on his family. This will not be regarded as an informed consent if there is the slightest evidence of this force being applied. Second, undue influence. In law, the term undue influence basically means that this is an external influence which can be applied only when there is a fiduciary relationship in place. And what is meant by the term fiduciary relationship is a relationship of trust and confidence. Undue influence to be exercised can be exercised only when first there is the establishment of a fiduciary relationship. And please remember that considering the nature of functions that you do, you are always in a fiduciary relationship with the patient, with the person who is mentally ill, as well as his family or his nominated relationship. So chances or possibilities of such kinds of, if I use the word allegation or if I use the word evidences, are very normal, and you have to ensure that you can avoid such bad points. Fraud and misrepresentation, I would try to take it together, because misrepresentation means you know something which is not correct and you try to share it. So what you are sharing is not intentional, but without an intention to cause some kind of a negative imprint, you are sharing that information. That is misrepresentation. And fraud is with an intention to deceive. So again, as a nurse, as a person of the nursing fraternity, you have to keep in mind that you have to be abreast with the appropriate treatment that is to be provided to this person. You have to educate yourself on the upgradation in the technology or in the equipments or in the resources that are available. And you saying, I did not know, will not help. You still remain covered. So, when you are taking the consent of the person who is suffering from a mental illness, please ensure that this consent that you are taking is in writing. And please ensure that you should basically take the initiative not only to hand over paper and take these kinds of signatures and be happy and satisfied with it. Because there are many such patients who do not know how to read or write. They will give you a thumb impression. They will say later on that it was not mentioned to me. So it is your duty as a service provider to ensure that adequate information in the language that is understood by the patient or his nominated representative or by his family member is actually shared. And the risks and the benefits that are associated with the treatment and with the rehabilitation and with the practices should be made understood to the person and his kith and kin in the explicit possible way. The shift in the mental health care has now been from custodial care to a rehabilitative care, and it is more community oriented. So let's understand the definition of least restrictive alternative or least restrictive environment. It means providing an option for treatment or providing for an environment of treatment or providing for a setting of treatment which meets the person's treatment needs and imposes the least restriction on the person's right. So as I told you, this is a right-centric legislation of the person with mental illness. So you have to ensure that an environment of treatment should not lead to his remaining in custody. He should not be made to felt that way. The first approach is community-based practices, and that is what has to be given first point to 2. And only then, when that does not suffice, that you should shift to the treatment where you bring the patient to a clinic or to a hospital and pass on the medical treatment that is associated to his particular case. So what are the salient features for consideration? There is a need to determine mental illness, and this determination of mental illness has to be done on the basis not of parameters which are anyway negatively impacted by race, color, gender, sex, political considerations or economic considerations, past mental history should also not be taken into consideration while determining the mental illness during the next time. Of course, you should also not aggravate the condition to an extent where there you do not maintain a distinction between mental illness and mental retardedness. Capacity to make mental health care and treatment decisions. This capacity should be lying with the person who is suffering from the mental illness, and what is required to be given by him is informed consent that I have actually discussed with you. He should be giving an informed consent on the kind of treatment that he wants to be given to or what he does not approve of, right? Considerations related to advance directive. Now this term advance directive has not been appropriately defined under this Act, because it says merely in the section where definitions are placed that advance directive refers to an advance directive as mentioned in section 5. And there it has been mentioned that what are the do's and don'ts related to an advance directive. So we can take it after reading the provision that it is a directive that is given by the patient to the service provider. And it is given at a stage when he is not into the position where mental illness has to be looked into, where he is in a state where treatment, care and rehabilitation exercises would have to be undertaken for him. He is to give this advance directive much earlier. And it is in this advance directive where he gives in writing few points. The first being, it is he who should lay down that what kind of treatment would he like to have and what is it that he does not approve of. And if he wants, he will also be mentioning that if the illness aggravates, then who will be acting as his nominated representative, right? So the considerations related to advance directive has to be made understood to the person who is with mental illness, but at which stage? At a stage when he is in the stage of early intervention, not when he is not in a position to understand or does not have the rationality to understand what he is saying and what he, that it has impacted upon him to a large extent. The procedure for making an advance directive should protect the rights of the PMI, and hence the person with mental illness or PMI must be made aware of his rights, so that when he fills up this advance directive, he is aware what he is doing and he is aware what are his rights. Now let me get into the question of what exactly are his rights. The law is very particular. Sections 18 to 28, if you go through the legislation, it is available on any search engine. It gives us a list of rights that the person with mental illness has. It begins from access to mental health care, to community services, to a right to information, to a right to receive medical aid, to a right to having a nominated representative, to a right to access to medical records. So maintaining these medical records is your duty. Please ensure that proper papers are maintained by you and the right intervention at the right time is undertaken by you, and properly it should be documented. This is something that you should always keep in consideration. Other rights that have been mentioned in this block includes that they have a right to access to information, and they have a right not to allow their records to be brought before the media without their permission. So please take into consideration that today, in the days of social media that we are in, there is the right of confidentiality of the PMI that is necessary to be respected and protected. What, therefore, is the liability of a medical health profession in relation to the advance directives? I shall talk of the liability, and I shall also talk of when there is no liability. Liability arises when the advance directive is not observed by the service provider. So, a treatment that is designed in consonance with people from the medical fraternity, being the doctors and the psychiatrists, that should keep in mind that this advance directive should be tried to be respected. Of course, there are emergency situations which also have been mentioned in the law where different decision making can be done in aggravated cases. This is where your liability lies. So, working in accordance with the advance directive, if not done, there can be a question mark raised. Now, let me tell you, when you have no liability, if there are any unforeseen consequences that happen as a result of observance of this advance directive, then you are not liable. This has been expressly stated in the law. The law is very clear. There is a categorical mention of this. There is also another situation when you are not liable, and that is when the advance directive is not handed over to you, when you do not receive a copy of the advance directive. So these are, in certain ways, also trying to protect you in the performance of your obligations. I am not trying to tell that these are rat holes from where you should escape. I am only trying to point out that you as a person also have your human rights, and you should ensure that we adopt a balanced, concerted approach in the performance of your duties. There is a distinction between the terms legal representative and nominated representative. The law talks about a nominated representative. The law highlights who a nominated representative is. A nominated representative does not always mean that the person has to be a successor to the person who is suffering from mental illness or has to be only a family member. If the person does not mention the name of a nominated representative can be anyone outside the family. It can be a relative, it can be a caregiver, it can be even the director of the Department of Social Welfare in particular cases. So there is a distinction which is necessary to be made between these two terminologies, that legal representative and nominated representative, and who can be a nominated representative. You can also be appointed as a nominated representative for a person who is mentally ill. So please do not try to forego your responsibilities in that sense. And so what do we come down to? All persons with mental illness shall have the capacity to make mental health care or treatment decisions. So they are the first persons who are taking the decisions on the kind of treatment that they want. And this may vary at different levels based on the support from their nominated representatives to make decisions. Sometimes there are situations when they are not in a position to take rational decision making, and then with the help of the nominated representatives, your role becomes much more significant and important. So what are the duties of the nominated representative? The duties of the nominated representative include maintaining a proper liaison with the mental health service providers. All formalities related to admission, discharge, rehabilitation have to be undertaken by the nominated representative. It is the duty of the nominated representative to ensure that the rights of this person with mental illness are protected, promoted, and safeguarded. So he, as a representative of the person with mental illness, also has the right to bring in a complaint when he finds that the person is not being attended to appropriately. He can be a person who is ensuring that the right to legal aid of the person with mental illness is being secured. Please do not remain under the idea that the person with mental illness does not think rationally, so he is not going to take any legal steps. The law has secured him with the appointment of a nominated representative, and a nominated representative always has the right to take decisions. What he only needs to establish before the law is that the best interest of the person with mental illness has been taken note of. That is the only thing that he needs to provide for. Admission of person with mental illness as independent patient in mental health, that has been provided for in the Act. So here we are talking of involuntary admission, that is a situation, and voluntary admission or independent admission when the person seeks admission to an institution of mental health care. And involuntary admission means when he is not in a position and he requires the support and the services. So this is a point of consideration that has to be taken note of. And all cases of admissions should be independent admission. So the thrust is more on voluntary admission rather than on involuntary admission. So see, the law is trying to focus more upon voluntary initiatives by the person with mental illness or his nominated representative, but the law is giving a secondary approach towards involuntary situations. But yes, restraint and seclusion. These are something to be avoided. Solitary confinement, this is not allowed to be undertaken under any situation. And punishment for contravention of the provisions of the Act. Now this is very important. When it is proved that the person with mental illness has not been acted with or acted upon with appropriate provisions of the law, then the first punishment says can be an imprisonment up to 6 months or fine up to rupees 10,000 or both. And if it is a repeated complaint that comes, then the fine gets extended and the punishment of imprisonment also gets added upon, and it can extend up to 2 years of imprisonment or fine ranging between 50,000 to 5 lakhs or both. So the law is very critical and very clear that provisions cannot be misused, provisions cannot be ignored, provisions have to be followed appropriately. So what is the role of the nurse? Keep yourself reminded of the shift from custodial care to community-based care. Try to engage yourself in interventions where you can address campaigns or you can be part of certain initiatives where awareness campaigns are being undertaken. Address the issues of the patient or of the person at a very immediate level. Generate awareness and a sense of compassionate empathy and understanding is something that is required to be developed. Arrange for the right treatment at the right time using psychosocial support. Now this is more important to be discussed in the rural settings where the access to mental health care does not reach the lower sections of the society. So community involvement as and when that is to be undertaken has to be done with utmost care. Respect the connotations of dignity, autonomy, and privacy of the patient, of the person. Participate in capacity building initiatives. That means training, upgrading your knowledge system. These are something that has to be undertaken by you. So as and when, be on a lookout that whenever such initiatives are being rolled by the government, you should take the initiative to upgrade yourself. And strengthen the referral systems, because that is one way in which you can address the problem at a grassroots level. You have to ensure that there is a proper referral system. Try to ensure or build a system where there is a connection with community self-help groups, or try to share the lived-in experiences of people who were suffering from mental illness and now they are leading a healthy life, because they are the greatest motivators for persons who are with mental illness. That shadow of stigma, that shadow of insecurity, which prevents a person from coming before the public eye, that will be taken care of if you involve them. Also, you should involve, whenever there is a awareness campaign, try to involve the community leaders because they are the largest influencers of the rural population. Be a part of the collaborative approaches. So what are the suggested best practices? Sensitization of the masses, emphasize upon mental wellness, involve individuals with lived experiences, take peer support and support from self-help groups, mobilize efforts to integrate mental health care into mainstream healthcare. Even today, if you go to the rural sections of the country, you will find that physical health is what is given more focus upon. Mental health care through counseling, or that this needs to be discussed by them, or that there is some kind of a support system available to those people, they are not yet aware of it. So that has to be undertaken. And thank you for giving me a patient hearing. I truly hope that I am on time.
Thank you so much, ma'am. That was really informative. And hall is open now, so anyone has any doubt, you have. Okay. Microphone, please.
Madam Mukherjee, that was a scholarly presentation. So, very scholarly and throwing light on very appropriate issues.
Thank you so much.
I would like to just highlight upon what you have already said. That is, patient liberty is well taken care of in 2017 Mental Health Care Act. But sometimes in some of the forums, I have seen the medical fraternity cribbing about it. I'm using the word deliberately. So, when I had gone through mental health care, I joined mental health care in 1974, gone through from 1912 University Act to the present Mental
Law.
Health Care Act. There has been a sea change in the attitude of the caregivers, public, as well as the care receivers. So I think we need to take, in the light of this act, we should take a sportive view as mental health care professionals. Sportive view, I am telling, it's no more restrictive. It gives a lot of independence to the patients. So we need to go with the changing times and change our mindsets in the care of mentally ill. Number two, I would like to emphasize upon mental illness and mental retardation. Recently, there was a discussion, why can't mentally ill to be included under, the Disabilities Act. So, I was arguing, mental retardation, yes, it is a permanent disability, and it should come under Mental Health, Act. Not only that, if we say mentally ill or permanently disabled, I would not agree with it. Because there has been people who have totally recovered, come back to their profession, got their promotions and reached the highest levels. So, it's a debatable question that mental illness should come under Disabilities Act. Then number three, I would like to say caregiver. We should go by the dictum of the patient when it comes to caregivers. We have seen in the clinical areas, ex-caregiver or ex-family members has gone, visited, and gone back to the home, and this patient has committed suicide. Because it has that much effect on the patient's psyche, XYZ family members. And we have also seen the patients are being used as scapegoats. Pathology is elsewhere with somebody else in the family, but patient is used as a scapegoat. So that scapegoatism has been going on, and if patient feels that XYZ's visit is prohibited, we have to go by that. Then the third thing I would like to emphasize upon is advance directive. We have to have 100% respect for advance directive. And I'm so happy you have brought out the gender issues, because even in general health care, transgenders are being focused now, in the jobs, in the care, in the airports, bus stops, everywhere, their needs are being addressed now. I'm so happy you have brought out that issue also. Thank you very much.
Thank you, ma'am.
Thank you, madam. 1 minute, 1 minute. To add on to, what madam said, we need some clarity from you. If at all you said the advance directive lacks some clarification, or it needs some strengthening, what would be your advice as a legal expert? Where
See-
it should be addressed, because we are going to have some deliberations in the future.
Yes. If I go by the provisions of the law, then it says that if there is any need for a review or for any amendment or for the cancellation of whatever is there in the advance directive, then it has to be referred to the Mental Health Review Board. And the Mental Health Review Board will be giving a hearing to all the stakeholders involved, and thereby it will pass its necessary orders which have to be abided by. So if there is any point in the advance directive which requires a clarification, it has to be referred to the Mental Health Review Board. And of course, considering the constitution of the Mental Health Review Board as the Act provides for, it is not only consisting of people from the judicial or the quasi-judicial fraternity. It includes stakeholders from the medical fraternity also. It includes people from, it includes even the person with mental illness. His opinion in certain cases would be taken. The nominated representatives' views will also be taken. So it is basically a very comprehensive decision making which is expected to be from the Mental Health Board, and therefore clarity on the advance directive can actually be sought in that way.
Number two, ma'am, suppose if a client, when he is in normal mental status, says that if there is a second episode for me, I should be treated in that way, but he has not written it, or he has not submitted to the review board, or given it to the medical officer concerned, can that be taken as advance directive? Can that be taken in the future?
The law is very clear. The law specifically in express language mentions that the advance directive has to be in writing.
The clarification here, why I am asking.
Yeah, I have understood your point. There are many
Nurses and medical
situations.
professionals have the privileged communication.
Yes.
So, should that be considered? Because some patients,
See, I'll tell you something. The first is, I am talking of a situation that the advance directive is coming into play when he is expressing his
Yes,
mind, and it is becoming operative or applicable when he is not in a state to basically further his mental state or position. So that is where the advance directive would come in place. And there are provisions in the law which also talks about emergency situations where decisions in the best interest of the PMI can actually be taken. So as a service provider, you definitely can use, if you are able to establish that it is in the best interest of the person with mental illness, the same can all definitely be established.
when he was in the normal status, he has written it in his own diary.
Yes.
Can that be taken? Because he has not informed anybody.
Here, let me tell you, sir, whenever we are talking of advance directives, the law says that it has to be written by him. Whether it is in the diary or not, and if it later comes out, these are specific cases which has to be taken on case-to-case basis as the evidence. Because there are also possibilities that the evidence is being tampered with or being tutored. So I think this has to be dealt with in a very case-to-case basis, and dependent on the situations, the decisions should have to be taken.
Thank you, madam.
Excuse me, ma'am.
Disability because some of the patients do
Now?
not use the provisions given by government because disability has some provisions.
Yes.
So those could not be given to our patients, and that is the reason we wanted that few cases which are certified by psychiatrist and one more medical officer, if these two people certify, then they can use the provisions given by government for disability, such as free travel, traveling with one more person. Free. Those things were becoming difficult. They were becoming difficult. Because of this Disability Act, they become easier. And disability word has to be kept. Because when we say specially abled, when we say those things, then those acts have to be changed. And that's why till today we are using disability, because then they will have access to provisions.
I
mean,
will
that
just
was
add.
the practical aspect.
Yes, I will just add to what you say and mention that what we need to understand is, as Madam has stated, we need to uplift our mindset. Coinages are merely, we use them as jargons. What is necessary is our mindset needs to be more compassionate and more empathy oriented towards them. Yes, absolutely.
Yeah, ma'am, I have a question. Excellent presentation, first of all. And I just wanted to know when you talked about the restraining and seclusion. So restraining, in some cases, kind of, when the patient is harmful to himself and to others, we do restrain him. So what is your take on that? What does the law say about it?
See, this is a law which says that seclusion is something to be avoided, and there is something known as solitary confinement. Now, why the law says this or emphasizes this perhaps is, earlier when the mental asylums had come into being for the first time, the approach was not therapeutic. The approach was more, trying to seclude them, confine them so that they do not cause harm. Today, the approach is community oriented in the sense, don't try to seclude them, try to provide them with an ambient atmosphere so that they don't feel that I am, suffering from something which I should not be able to communicate with the others. But at the same time, madam, as you have pointed out, we also need to understand the medical requirements and the safety of the service providers.
Right.
The law does not say that uplift the right to life of a person with mental illness to the extent that the right to life of the service provider is compromised upon. We have to take a very rational approach, a practical approach, and we have to act with prudence and precision. That is something which has to be looked into.
So the same thing goes for the
Yes,
restraining too?
definitely.
Because we do
De-
physically
yes,
restrain
see,
them at times.
if he is in a position where there is a possibility that he might cause harm to himself or to some other person, or somebody might get harmed, or as we were talking about decriminalization of suicide that has been spoken of, there can be a possibility that he is not rational, he is attempting a suicide. Okay, decriminalization has happened of the provision, but the intention is to provide him with the best possible care so that he recuperates from this position. So I think there has to be a balanced approach in ensuring that rights of both are given equal importance.
Thank you, ma'am.
Thank you. Yes. The mic.
One needs to be in a lucid interval or to be in touch with reality before he makes his advance directive. So one will have to certify that he is in a lucid interval, right? That's what I understood.
Not only in a lucid interval, what I wanted to say, this is one case. The other is at the advanced stages. There is an early detection necessary so that he is still in that rational state where he can issue or, he can write down this advance directive. So that is the reason the Act emphasizes upon early detection.
So until and unless he's been certified that he can write an advance directive by psychiatrist, it is not valid.
It is not valid, and that is where the terminology nominated representative would come into more focus, and therefore the duties of the nominated representative has to be given more importance to. A nominated representative can also be somebody who is a medical service provider. Right, as I have pointed out to you. So in a situation where you did not have that, the approach to the approach can be that a medical personnel, somebody from the medical field, can basically act as a nominated representative and ensure that all the rights of this person are being provided for.
Another question, ma'am. Earlier, there was a reception order, needed for admission of patients to the hospital. What about now?
See, as of now, we go by the law in the sense that, voluntary admission and the involuntary admission, the situations have to be monitored actually, and then only the decisions have to be taken on it.
Okay, thank you, ma'am.
Thank you. Somebody behind.
We are running out of the time. Yes, sir.
Ma'am, good morning. I have a question. I faced a challenge in a ward. In that case, there is a written documentation in normal condition. And she faces a family problem, and due to some problem, she suspect on her husband and nominated her in-laws. After 3.5 years, when she became patient and admitted, and there is a legal fighting between two parties. So in that case, there is no certification, only written in the diary, how that case is to be managed by the healthcare provider or psychiatrist.
See, you have to first understand that what is the intention of a mental health service provider, to ensure that the right to mental health of that person is protected and promoted. If we go by the objectives of the legislation, these are the objectives that the law talks about. So in a situation, you have to understand that it is the right to mental health that is paramount. So you have to take the decisions accordingly, initiate a process, as Madam has pointed out, involving the medical personnel, the psychiatrist, and try to come out with some alternative arrangement whereby the right to mental health of that person is protected. You cannot be somebody who acts as a conciliator to resolve the dispute between the two disputing parties. And that is not your goal. That is not your aim. You are somebody who is there to uphold the mental health. Right?
Okay, thank you.
Thank
ma'am.
you so much.
Thank you so much. Now, may I request Madam Deepanita Sengupta ma'am, please kindly felicitate our madam.
We are requesting Payal Jana to kindly come on stage.
Thank you, madam. Madam nicely instilled an insight into the role of nurses in the implementation of Mental Health Care Act 2017, because it is a national burden. As according to the survey by Niemans, National Mental Health Survey, it is in prevalence that 13.7% as a whole person with mentally illness with disability, which would mean that 150 million of Indian are now with mental illness. So, this discussion is very much beneficial for our professional, and this type of disclosure is very much relevant, and this will be beneficial for us. Thank you, madam. And
Actually, for the time being, I forgot, ma'am, that you are not in our domain.
actually, I want to show my regard to the Madam Rejima and the Niemans team member, and my regards to the organizer, my regards for being honored me as a chairperson of this beautiful session, and my best wishes to the participant. Thank you all.
Thank you, ma'am. Payal, please accompany ma'am for felicitation of Dr. Debushree Mukherjee.
Please give a round of applause, please. Thank you so much, madam. Now I am requesting Ms. Shoma Das to kindly felicitate Madam Deepanita Sengupta. Ms. Aditi Bose, please accompany Ms. Shoma Das.
Thank you, madam. Thank you.
So let us move forward into our next session. Now I have the honor of inviting Dr. Naveen Kumar Sharma, Assistant Professor, College of Nursing, AIMS, Patna, for the next session on stigma reduction, raising awareness about mental health challenges and issues. I would like to invite Dr. Chandrima Maiti, Professor, College of Nursing, Murshidabad Medical College, as chairperson for this session. Madam Chandrina Maiti has done her master's and PhD in mental health nursing from West Bengal University of Health Sciences. She has more than 33 years of experience both in clinical and teaching field. She is also a state trainer of infection control program, quality assurance, skill development of staff nurses working in various mental hospitals of West Bengal. Ma'am, we are very blessed to have you here, sir. So, over to you, ma'am.
So good morning to all, and thank to everyone for inviting me to chair the session. And now the session is stigma reduction, raising awareness about mental health challenges and issue. And our speaker, Naveen Kumar Sharma, Dr. Naveen Kumar Sharma, Assistant Professor, Department of Nursing, AIMS, Patna. And Dr. Sharma has huge experience, and he is the national trainer for infection control and hepatitis control. And he has many publications both in the national and international journal. And he has the eminent personality as an editorial board member for many peer-reviewed journal. Thank you, sir. Podium is ready and everyone is waiting for your presentation. All the best, sir.
Thank you, ma'am. Good morning, one and all. So, to cover up the time, I will just try to make it short. It's a very non-topic stigma. When Dr. RK asked me to take this topic, I thought it's a very simple topic, and stigma everybody knows. From our BSc time, like we can say from our childhood, we are reading about the stigma. So I said, so it's a very common topic and we can cover it very soon. But when I started preparing it, the number of slides are increasing one by one, and it's went, when I calculated the PPT size has become 50 MB. I thought it will go for 1 GB, it seems. Okay. So stigma reduction and awareness, rise of awareness. What are the challenges and issues we have? Mostly I concentrated on Indian aspects, then going to international, because internationally nowadays there are different things we have. If we'll go for some literature, we find that Asian countries are having specific concentration for the stigma than the Western countries. They are not that much stigmatized as Asian countries that we have. So we'll start with that. If we'll say introduction wise, I am very concise with that. As we are number one in population in the world, we are crossed almost 140 billion. The WHO says in 2015 that 1 in 5 Indians suffering from the depression in lifetime. So we can say roughly 200 million people are suffering from that alone in a depression worldwide. Due to this stigma associated, due to the stigma associated with the mental illness, a lack of awareness and limited access to the professional help, only 10 to 12% are sufferers are getting with the help that they required from this. It was almost 3 decades study which says that the number of mental illnesses are rising continuously. It's crossed almost ended in million. So what is a mental health? If we'll say it's a recognized by the Lancet Journal and WHO's that there are some of the significant barriers to the positive change, like the number one is, which we have here, is stigma is the number one cause for the positive change in a mental health. In a top leading cause of disease, burden is in mental illness, which we have here, and 10 sufferers of every is mental illness, as more than 20% are experienced with the emergencies, and estimated we can say depression, anxiety, and post-traumatic disorders continuously. So United Nations Conventions on the Right of the Person with Disabilities that says that discriminations based on the person's physical or mental disabilities is a violation of their basic human rights. So we should not discriminate them, that it makes the stigmatize the people. It was NHS study which is done in UK on youth, that the age is almost 11 to 24 years, and they find that the maximum 70% of respondents were less likely to talk about their mental illnesses. That was the stigma that they have with the mental illnesses. So let's understand about the stigma, what it is a stigma is. The person Guffman, first time in 1963, he defined the stigma in his literatures, and later after many years also he continuously amended it, and finally one which is latest 2009 defined as, it is nothing but assigning a person some phenomenon which leads to negative representation and the discretion of individual phenomena. That's caused the stigma. So we have various different definitions, like we can say, namely knowledge, problems of knowledge, that is called the ignorance, the problems of prejudice which cause attitude, and the problems of behavior which is a discrimination in people. So in Indian literature, one is, it refers to the devaluing and the shaming of the person because of his mental illnesses. If we say the stigma in India, it is the term mental health is serve as Indian culture, and there is deviation is called the normal. So I read somewhere some people were saying that if somebody is not behaving like you, is said as abnormal. This person does not behave like me. This person does not talk like me. This person does not mingle like me. Person is said as a abnormal. So in Asian countries, as I said, Asian countries are having different view towards the stigma than the any other things. So person tends to live a traditional life which result from the exclusion from the people, and the families are not very much open to discuss this in a public, as previous speaker said yesterday also. What are the factors which is affecting the stigma? There are various factors. As per the literatures, one is cultural and contextual value system, one is social economic conditions, knowledge difference among the population that we have, then rural and urban things, where the people are staying, and individual, that the person's own prejudice that always carry. There are some of the types of stigmas are there. Like one, self-stigma, which is known as internalized So one is systemic. It is a, can you reduce the bars? Okay. So systemic, it's a systemic things when we can say the systemic existence, when the public and the stereotypes are embodied in the laws, institute and organization that influence the society. We say there's a systemic stigma. If we'll say that systemic stigma, public stigma affect the individual or the small population. But if we'll say is a systemic stigma, it's affect the large population to the more extent. So that's a classification, we can say the public and systemic. What is the root causes of stigma? We have various causes of stigma, but we can concise into three aspects. One is misconception and the stereotyping the things. That's a misunderstanding about the mental illnesses. And one is the biggest cause of root causes stigma is media portraits. How the media is influencing or how the media is representing it. Like we just had a recent is Sushant Singh Rajput, the suicide case of that, how they did. So they made a one story. We can have one movie on that also now. So that much big story is made. What is the truth? We don't know still. And the another thing which is very common from the long time it's running up, it's in a culture and the social factors. There are cultural factors, there is social factors, acceptance by the people that always accompanying that. Another part is how the stigma impact the person, how the system, it impact the person. That we seen in the yesterday's slides also by the professor, that public stigma and the self-stigma. Public stigma is impacting the public and self-stigma is impacting the self. So how the person's impacted by this stigma, because he is not going to approach the health services which is available, underutilizing the things. So that was the things which we saw yesterday, we can skip today. So that's the impact, it's a negative perception, barrier to the seeking help and the impact on a person's well-being. There are impact on not only the person and the society, we have the impact of stigma on the personal and the healthcare professionals which is also working in a mental health sectors. Like we have the workplace stigma. That's a stigma in the workplace leads to the discrimination and reducing the opportunities and negative impact on your career development. This person is not mentally healthy, how he will work as other people. So you have the stigma among yourself, in the peers or we can say in the colleagues. Then we have a stigma affecting the family and the social relations that always, in India, even if one person is having mental illnesses, other people and family member does not say that. Because maybe the younger sister or younger brother, they may not get the proposals for marriage because the elder brother and sister is having mental illnesses. They say that he is also having, maybe all family is mad. Pura ghar pagal hai. So that may be the one stigma that is attached to the family and social relation. Healthcare disparities as we have, that depends. The people or the healthcare providers, they also think that why this mentally ill person need a help. If somebody is having fever, okay, we have to immediately take care, otherwise the temperature may rise. But mental illness, what is there? Kal bhi wahi tha, aaj bhi wahi hai, tomorrow that will be the same. So there is no need to take care of that. That will be auto-generated things, it will resolve by its own. So that will be the one. So to know more about the stigma, there is one very good study is done by Leave, Love and Laugh Foundation, which is found by Deepika Padukone episodes. And it is one of the NGO which is aimed to create the awareness of mental illness and reduce the stigma which is associated to the especially mental illnesses which she faced. She came up openly and she expressed about the mental illnesses, especially her depression, and the people more awareness. So she started the foundation. She did research, we can say the survey type, how Indian perceives the mental health. It is national survey which is reported in 2018. And this survey took 5 months and which include the 3,556 respondents from that. So we have some of the their results. We go through some major findings and go fast. So one part was support, judgment and fear. In that maximum 47% of respondents are having the judgment against the mental illnesses. Then about the attitude, what the people think about or their attitude towards the people. So if you'll see the third one, red is 60%, which says that mentally unhealthy people should have their own group, healthy people need not be contaminated by them. So it looks like contamination. Okay, if you will be with them, so you will become like the same. कोयले की खान में जाओगे तो काले हो जाओगे. Okay, so it's just like that. If you will be with the thief, you will also become a thief. If you are mentally ill, you will also become mentally ill. Okay, so it's growing things like contaminations. So 60% people think like that. There's a 3,000 people of survey. We have social inclusion. How many people should be included? Here, people are positive. Okay, people says that 68% said we should have the responsibility to take care of them, but they are not. So neighboring company and they have the lower 57% are people are to their neighbor that says हाँ उनका ध्यान रखना चाहिए, but not to that much that we have. So what people feeling about the sufferers? who is suffering with that. Here the major part, if we'll say the brackets, 14% is always be fearful, 28% hate the people or sometimes or always, 43 feels angry sometimes or always. That if the last part, this admissions that general people, publics are feeling towards the people with mental illness, that also again cause the stigma among the society, and that's grows on. So what are the challenges? Now comes to the main topic of today's discussion is what are the challenges and issues we have to the stigma reduction. So one is lack of awareness and understanding. People does not aware about the mental health or the illnesses or about the treatment modalities. So lack of or limited awareness in a people. Even educated people also says. Then another is social stigma and the discrimination. As something happens, they start discriminating the people. Okay, that person is away from the remaining people. He is different from the us. So stigmatization is always there. Institutional stigma that we discussed, just the healthcare system. We have a stigma which is self, or we can say it's an internalized stigma. The person self stigmatize himself, and results is he is away from the getting help. Then cultural and social norms also affect the stigmas things, and medical media is always, and the languages. Which type of language we are using for the people. So language modification is always, that's the representation or the your talk with the people is always having the importance on the stigmatizing things. Another is what are the barriers or issues which we have in a awareness, how we can spread the awareness in that. One is same as usual, we have 5 points here, 4 is always important, 5th depend on that. One is lack of awareness about the mental health, that's all one awareness we can say, or co-occurrence we can say. Then social stigma is always attached to that. You could control your mental illness if you only tried that, nobody else, you have to try yourself. That's a very interesting findings I got as one study in 2023, cost. It's evaluated based on the cost that how they are spending on that. It's a 2,115 rupees is spent every month on the healthcare by the household, each one household if the person is having mental illness. And this add up the 18.1% in a monthly expenditure of the each family. So this burden is among the poor people as there is a expenditures increasing. According to the National Sample Survey in 2017 and 18, the average cost of hospitalization for psychiatric and neurological disorders, 26,843 rupees cost almost to that, and 7,235 care for the public hospital. In a private, it goes beyond that, 41,000. And if we'll say the last one is, this is comparable to cross associated with the any cardiovascular disorders, same as mental illness, but people are not aware about that. So we have a limited options. Limited option is like people are not aware, so they are not utilizing exactly what is required. So they have a limited resources. Nowadays we have the telemanas as increasing, and these resources are grown up now. So the last one is eliminating these challenges and getting the help. The person is just call away the phone call. They can call up to the telemanas and they can get the help as they required before. So what to do? What is the solution of these barriers, these issues, how we can solve? So WHO started one comprehensive mental health action plan, which was in 2013 and 2013 to 30, which yesterday we saw is extended. So here we adopted the various interventions to reduce the stigma and discrimination and protecting the human rights and the people who is having mental illnesses. So there are some of the, we can say the talk we can have, like tips to talk about the mental health. We can start the conversation, listen and reflect that what we are listening from the person. Be patient, be yourself, ask how you can help the people. That's always important. You should be very open up towards that. Not like healthcare workers, but when we talk in a general people, we should be always encouraging people to talk up, to have the conversations, to have the talk or dialogues for the more and more open up communication for the reducing the stigma. There is some of the mental health stigma addresses which is done by the promotion, educating and awareness. We can have the understanding, promotion, the understanding in a people. People should understand what stigma is and how it's impact the people. We should have the media literacy. That's always important, and that is lacking in India, which I personally feel media literacy is not there. In the last slide, we will see that some of the initiatives of media literacies. There should be a community engagement. The youth, the people, the community people should be included in mental health services or the stigma reduction or the awareness. Grassroots level intervention should be given to increase the awareness in this. There are recommendations which is given by the Lancet Commissions on the ending the stigma on mental health. There are various people who work together like healthcare, social care workers, employers, policy makers, media organizations, and the people who is having their live experience of the mental health conditions. They all work together to make harmonic relations, to make a network for the stigma reduction and awareness. We have the every intercoordinations, the empowerment and the resilience, that is healthcare, behavioral science, policies making, prevention, law enforcement, criminal justice, education, first respondent, faith healers, that's businesses, all should have their role in prevention and reduction of the stigma. Another part is, as we just discussed in a last session, is advocacy and policy intervention is always important. We should have a legislative support. We have now. In 2017, it's become more easy. Same, we have the mental health parities laws which should be implemented, and the anti-stigma campaigning should be more emphasized and given a more attention to the current practices that we are having to reduce the stigma into the maximum level and increase the awareness which we have. How we can empower the mental health? This is about the other peoples that we can have, but when we talk about ourselves, how we can empower our remaining or the healthcare professionals, the enforcers in that. We can do it in 3 ways, like we can have a training and education. We see in all the hospitals and all, people are nurses, many people are working in a psychiatric ward, they are BScs, but the person is working in ICU, they said, oh, okay, fine, I just work for a 1 month rotation, I'll go back to the ICU or somewhere else. They won't bother about that. Even if you'll go and ask, what is the Mental Health Act care or the 2017 bill or act, people says that I don't know. Okay, they are just there to give medications or the things. So that is a routinely which we can say, but we can empower it to all the nurses, train them, educate them about the mental health illnesses, stigma reduction, and that all the things. We should have some client-centered approaches. The approaches which should be given to the client center, we are giving. I'm not saying that we are not, but we should emphasize more in, and we should develop a support network for all the health nurses. So another part comes to the community services, that a collaborative community efforts can be like peer support programs can be initiated, where the peers are supporting to each other's. Youth are included in a health initiatives that we initiated for the further part, and we should have a cooperative partnership among all the associations. The most important, as we have one barrier, is cultural and the social stigma. So cultural sensitivity and inclusivity should be there. There we can have the cultural competencies like promoting cultural sensitivity approach towards the mental health care and addressing about its practices. There should be a language and communication, encouraging inclusive language and communication which cover up the somewhere stigma, and the intersectional approaches where we have the collaboration with the various different sections. So, and one is mental health literacy, that we just saw that. For mental health literacy, we can have the education initiatives that could be implemented about the mental health programs in schools. We can have workshops, we can have a community settings. Okay, there we should work for the literacy of mental health. That should be from anywhere. You can start from the community, you can start from the community, schools, community homes, the services, the healthcare settings, even PHCs. It should be from the grassroots level, and promoting the help seeking. We should encourage the people to seek help. Okay, how and what they think about that, and this only comes when the person is away from stigma. Then only the person will start seeking the help. Then destigmatization conversation is always important. You should convince the persons to get help from the people, not have the stigma labeled on that. Next, there is a stigma reduction and mental health awareness can be done. It's the same like challenges in addressing the stigma. Then paradigm of the mental health awareness, language and perception that we just saw, and the recommended some of the strategies can be done. And one of the important is holistic approaches that we should work for the each and every corner of things. One which I just said is about the media. So this is the one of the Australian commissions on the safety and quality in healthcare. They started one program that is name is Stigma Watch. Since Stigma Watch program, which was established in 1997 to promote the responsible reporting of the mental illnesses and suicide in Australia media. That should be there in India also, I feel. They monitor and respond the reports of inaccuracy or inappropriate stigma media portrayed by the media, medical illness and the suicide. So that's a very good initiation which is taken by the SEN in Australia. There are some of the organizations which work towards the destigmatization and the mental illnesses in India is like just we said Live, Love and Laugh, Mind Foundations, the Banyan and the Scarf, Sangh, Asra, Anjali which we have in Bangalore only, and the Manas Foundations. They many more are there. I had just few names here for the organization which is working for the stigma reduction and the awareness more for the mental illnesses. So what is the take home message for the last slide? Stigma and awareness both are two separate issues, but they are interlinked to each other. So it need to be addressed in parallel in order to tackle the burden of mental illness in India. If individuals continue to view the mental illness with the apprehensions and resistance, it will remain difficult for the people with mental health concern to seek the support they require due to the fear of being labeled or judged by the people. So that's about the mental illnesses, stigma and the challenges and issues. Thank you. Thank you so much. I would like to express my thanks to respected Redamma ma'am, RK sirs, Dr. Bala and Dr. Sandhya ma'am for the giving me opportunity to stand here in front of you and talk on the particular topic, and the organizing team of SNU for giving a very nice hospitality, and we are enjoying the Kolkata. Thank you.
Thank you, sir. Please sit down.
Hello. Hello. Thank you so much, sir. The hall is now open for discussion. If you have any queries, you can ask.
Thank you so much, ma'am. It's really encouraging. Thank you.
Good morning, sir. I have a question.
Yes, please.
Sir, what are the awareness program are being taken for recurrence of mental illness? Because that's a big factor, and there is lots of influencing factors which increases the risk for recurrence. Whenever a patient, even a patient came for seek help to a doctor, so to a psychiatrist, they get admitted. When they return after discharge, the stigma gets higher than previous. All the neighbors and other people used to say that, "Are wo to pagla garod theke esche." Right? So what are the awareness program is being initiated for recurrence of mental health?
There are various
Mental illness, I mean,
yeah,
sorry.
there are various awareness program that we have through the various NGOs. They are working for that. Even government initiation is also there, and even for the mental health professionals nowadays, we are also encouraged to be have that in a community, and the people are working towards the national mental health program. They also integrated with that to reduce the stigma. But as I said in a PPT is that uh, people are always labeled with that. Once you are with the mental illnesses, you went to a shop and came back from that shop as from that it's okay, this person is, if you'll go to once, even for 1 hour, if you'll go to the, people are not visiting to police station because they are having fear that if I'll go to police station, people say that isne kuch kiya hoga, somebody did, that's why he went to police station. It's the same thing like a mental illness is also there. Okay, people does not कहते हैं ना, people does not likes to talk to police people because they think that इनकी दोस्ती और दुश्मनी दोनों बुरी है. Same like a psychiatrist also. If you'll go to psychiatrist, it's labeled that he is a mentally ill.
Right.
Even we went for, he is our friend, we went to meet him after 10 years, but they think, क्यों गया था? What happened? Why you went? People are not, sometimes we feel depressed, but we are not that much open up. Okay, we will go and discuss once or counsel or talk to our people. We are not doing that. It's a stigma. So once it's labeled, it's labeled. People are working towards that. So we are trying. Dr. R.K. may enlighten it more.
Thank you very much, Naveen. It was indeed a great presentation. I can share a couple of practical experience in this regard, where we are all nursing schools or colleges. When we were in Belgaum, we have adopted 3 villages. And all the village, like how we had the family card, I had attached the mental health survey card also in that. That really helped. All the 3 villages put together, 15,800 families were there. So we have covered all of them, population. We have covered all of them. We had data. So we started working with them. We started educating the community. That really helped. That's number 1. We are attached to some primary health center or some sub-health centers where really we can do wonders. It's not that always mental health care or education should happen in the hospital. So please adopt that model. Wherever you are attached, take up that village and start working. That really helped a lot. Second, recently we have initiated 2 projects. It's almost 2-year-old. One project is called Educating the Teachers in the School. We adopt a model called teachers, parents, and children, all of them. So we educate the teachers, that is multiplied into many, because when the teacher is educated, she takes care of the whole children under her custody. And then we started screening the school children and educated and interacted with the parents. This approach helped a lot. The third project is sensitizing the volunteers. Volunteers of any kind, Rotary volunteers, youth club, Mahila clubs, farmers club. That is one project we are adopting, and that helps a lot in spreading the information. That definitely reduces the stigma, because now today's youth is more educated, and they are oriented with all the technology. So when we educate them, they also look and verify. So that is multiplied a lot. So maybe this approach, it is a cost-effective approach, does not require a lot of money for doing these projects. Kindly start doing it in our own area. So that will really help. Thank you.
Most of the readmissions are due to drug non-compliance. Please ensure compliance of the drug intake.
So, thank you, Dr. Sharma, for your informative, energetic, and lively presentation. And we say, from the first day of first session to till now, everyone and every speaker talked about the stigma, as because it increases the mental health burden. And from this context, Dr. Sharma covered all the aspects of the stigma and its challenges. And one common language used by our young generation, the psycho. And they are how frequently and how smartly they utter this term. And many bullyings are also reported in today's different types of media, no? And in our community also, they are pagol. And in Bengali, pa means the leg. And we are telling our leg are not the round. It is, and so such type of language always hurting the everyone, evaluating the human being and respecting and rejecting and excluding the people having the mental illness from the home, school, working place, so membership of a club and entry into a area, etc. No, so as a mental health professional, we have to go miles after mile, years after year, with the side by the side of the patient, because changing the attitude and perception of the people towards the mental illness is not a matter of job, it is a time-consuming matter. So, as a mental health professional, we have to raise our voice, and without, there is no health without the mental health, and mental health is our right. So, as a mental health professional, everyone engaging ourselves, and we encourage our students to do research, to intervention research, to reduce the stigma also. So, to stop research, protest and find, and be ensured your mentally ill people enjoy their mental health right. Thank you, sir, and thank you, audience.
Thank you, madam, and thank you, sir, for your enlightening speech. So now I will request Madam Chandrima Maiti kindly felicitate sir, Dr. Naveen Kumar Sharma. Ms. Rituparna, please, Sengupta, please kindly accompany ma'am. Madam, please. I will request Paulomi Mukhopadhyay, please come and felicitate Madam Maiti.
Thank you so much, ma'am. Thank you so much, ma'am. Thank you so much, sir, for this session. So now, before moving towards our next session, we will take a small tea break. So the tea is served outside, you can have. And also there is a short oral communication going on, so you can also attend that one while having your tea break. Thank you.
এটা বললি না অন করে হ্যাঁ।
And do we have internet connection here?
Internet connection, yes, sir.
Yeah. Can I check?
Yeah, okay.
I need some interactive activities there.
Okay, sir, you can check it. If any problem, then we will ask them to
tea break time, no? I will check.
Yeah.
Let's open
I
one.
think it is open.
Yeah, just a second.
Sir, valedictory session.
We have given details to ma'am actually. Just now we have written and given to
Oh.
Madhavi ma'am.
Okay. Previous day you have asked me, no? So that is why I have prepared.
This one now we discussed because sir is not coming.
Okay, sir went out.
No, he is not coming for this, I feel.
Okay. So I will talk with Madhavi ma'am, no?
Madhavi ma'am, yeah. Let me just check this and yes sir, yes sir.
So, actually, that's the reason we should never say it's a 1 hour presentation. Say that we will say to all it is 45 minutes presentation.
I have
Because
asked her.
introducing them and winding up will take one all put.
Yes. I asked her personally that to wind up within 45 minutes.
For all the speakers will tell.
Yeah.
Next speaker also can tell to ma'am.
Okay.
And just we finish 40 minutes, then we'll have discussion. So Mark ma'am is going to present. Next is
Pink
ma'am only, no?
color, sir.
It's already saved on the desktop.
So we are allowing 45 minutes for speech, ma'am, because to wind up and
Yeah, good. Make it as short as possible.
No, ma'am, not that, because so much query is coming. So for discussion we are going late.
So this one, I'll have to go fast then. Mine is social media and where is that file?
Ma'am's PPT is there, social media addiction.
Social media and mental health. Give it in the morning.
Then it might be here. ফোল্ডারে করে তো কোথায় করে রেখেছো? Yes, sir. কেটে দেবো। Please everyone join. We are going to start our next session. Hello? Hello? So welcome back to our next session. Please join with us in giving a warm welcome to our next speaker, Dr. Usha Marath, Principal, Lisi College of Nursing, Ernakulam, Kerala. Ma'am, please continue. Come on the dais and continue with our journey of learning through the session Social Media and Mental Health. I request Dr. M. Vijayarani, Assistant Professor, ESIC College of Nursing, Bangalore, to take the stage and chair the session. Madam M. Vijayarani has 20 years of experience where she has contributed as an author in various books. She was awarded with R.N. Murthy Award and received gold medal too. She has various recognition in her academic career. She has published total 34 articles in different national as well as international journals. She is also a life member of TNAI and Ispn. Over to you, ma'am.
Hello, hello.
Good morning, one and all present here. I'm very delighted to be a part of this. I'm here to introduce ma'am, Dr. Usha Marath, Principal, Lizzie College of Nursing, Ernakulam, Kerala, to continue our journey of learning through the session on social media and mental health. In fact, it is a topic of interest of mine. Dr. Usha is currently working as a professor principal at Lizzie College of Nursing, Lizzie Hospital, Ernakulam, Kerala. Madam has pursued PhD in psychiatric nursing from Rajiv Gandhi University of Health Sciences, and she is a life member of TNAI, NRSI, Indian Society of Psychiatric Nurses, and Kerala Nurses and Midwifery Council. Her areas of research interest are nursing leadership, simulation in nursing, OSCE in nursing education, educational standards, spirituality in nursing. We are very happy to have you here, ma'am. The stage is yours.
At the very outset, I thank the organizers, Redama ma'am, and the ISPN members for giving me this opportunity to speak on social media and mental health. I can just see right now standing over here, a lot of you going through what is on your phone. So that's social media. So what it's going to do with your mental health, because we know we cannot be out of communication or be alone for even a moment. So we try to be connected all the time. And that's what media, social media particularly, is doing. So we had an enormous shift which has taken place with the development of internet, because earlier time when we were going back to the days of the black and white TV, which used to have the Doordarshan music being played, and we were all adhered to that TV scene, not the present generation, I mean. But from there we have traveled a lot. A lot has happened, a lot is happening, and a lot has to happen again. We have the Web 1, Web 2, Web 3, and now the AI coming into the scene, and it is going to make a drastic change. So this change which is happening in the environment will be affecting us in all the way. And let us see what it's going to do with our mental health. So going by the definition, I think this is this wire if it is getting touched. So social media, if you look into the definition of social media, you can see that so if we go to the definition of social media, we can see that, so we go by the definition of social media, we can see that it is any activities, practices, and behaviors among communities who gather online and share knowledge and feedback through a web-based platform to create and transmit the content in any form. It can be in text or pictures or videos or audios. So it is being sent. Two words which is getting used over here is social media and social network. So social network is just those sites which are available, including the social media platforms, which will help you to interact with people and conversation. So the Digital India initiative by the government was indeed a stepping stone into the internet making its way towards the rural population too. And we can see that India's digital population has reached to along approximately 692 million users with a penetration of 48.7, almost going up to 50% of the population being covered by internet. So we can see that the active internet use among the population of 12 years and more is around 595 million, which is about a rise of 20%, which is there. And among these users, those who are using social media comes to around 467 million, and 67.5% of internet users, regardless of the age, has at least one social networking platform which they use. And the count of mobile users, if we see, it is approximately 77% of the total population which is having mobile use. And the time spent on the social media on a global level, it is around 145 minutes per day on an average, which is being spent. And if you look into the Indian setting, it is coming to the global level of 141.6 minutes per day. And the 99% use the tablet or a smartphone for contact to social media, while 78% do so exclusively with the use of phones. So you can see that's a big population which is having social media access through phones. And the demographics of social media use in India shows that people in the age group of 13 to 44 years, you can see there is a maximum usage of social media among them, and that too among the males. It is more compared to the females. The key reasons why they go about using the social media is mainly the reason is keeping in touch with each other. That's the most commonest reason which is being given, followed by other reasons like reading news stories, finding content, just to engage themselves in their spare time, etc. The key accounts which they are following are the foremost importance is given to the people they know. They follow the accounts of the people whom they know, followed by entertainments and memes and TV shows and channels, actors and performance, influencers, etc., which is being getting posted. The most used platforms among the social media, that's definitely what we expected, with WhatsApp in the first category, followed by Instagram, Facebook, Telegram, FB messengers, which comes down, lower down in the rank. And this is among the population 16 to 64 years of old. Now, what is mental health as defined by WHO? Mental health includes all subjective well-being, perceived self-efficacy, autonomy, competence, intergenerational dependence, self-actualization of one's emotional and intellectual potentials. So it is the well-being and how it is being connected. It is connected with the internet use. If you see, you can see why we are coming to this discussion today, because 70% of Indian population is young and have recently got access to the portable computing device with very little social media literacy. That is the main reason why we have lots of issues coming up. The high speed availability of data at a very reasonable cost is again one of the reasons why social media is becoming more popular, and it is affecting the mental health of a person because it is affecting the behavior, it affects the affective behavior, the cognitive and the psychomotor activities of a person is getting affected by social media, which is contributing to mental health. The positive, I'll be first highlighting some of the positive impact which social media has made on the mental health, and then go on to look into the negative aspects. This is one of our study which was done by Iyengar et al. Into 2022, and it is a qualitative study which has been done by the person, and the study has looked into the benefits based on content, connectivity, and modes of expression of social media has been utilized, and 5 themes have been emerged from the study, and these 5 themes are looking into the various aspects of positive. They are positive relationship and social capital, the self-concept, coping, happiness, and other relevant aspects of mental health like positivity, personal growth, and psychological well-being. A concept mapping method was used, and that has been displayed how social media builds the positive relationship and social capital by means of connection, by means of expression and content. By means of connection, by connecting with family, for example, they get a better, they have a better family relationship, which is help enhancing the positive relationship, meeting like-minded people on the platform, that too being non-judgmental in the group, and getting empathy from others also build up the relationship. Feeling a global presence in the group is empowering themselves, and that also leads to better relationship. That's the way by which the concept map has come down. The posts on Instagram medias with likes being, you get lot of likes on that particular post. It boosts the person's self-confidence and self-esteem, and thus brings up a social capital. So this is, in a way, coming to a conclusion that social media, or the content and the connection and the expression which you make on social media, helps you to build on positive relationship and social capital. Similarly, social media, by connecting with the in the social media, the person's self-concept is enhanced. It also helps in expression of by outlet of expression. You tend to have a body positivity being obtained by self-presentation. You are able to, particularly those people, some people are not able to do a face-to-face presentation of self in a better way, but on the platform they are able to present themselves, and that helps in their self-presentation, and that body positivity is obtained, and their self-esteem and concepts gets enhanced. So these are a few of the ways by which the pathway builds the self-concept. This is about for the coping. The social media helps in the coping of the process. For example, in the outlet of expression, particularly by voicing their frustrations or sometimes voicing their anger or in the group itself, posting some that helps to to ventilate their feelings in the group, and they being not getting criticized because of that expression, because that helps in a coping way. Similarly, old photos and old memories, when it comes onto the media, it helps to relive those pleasant memories. And that is one way by which a person feels a little bit relieved from the stresses of life. Feeling happy through social media, again, outlet of expression, content, and connections. We can see three ways by which it is there. Content-wise, by looking at the various videos or funny memes which is being coming onto the social media. It is like an entertainment and helps you to feel happy. You enjoy some of the videos or clippings which are coming over there. Some of the things will be motivational at times, and they may be motivating you to do things. So seeing friends' achievement, for example, you follow some of your friends and you see their achievements, and it helps you to know that they are doing well in different parts of the area. So other areas of positivity which is told about is personal growth, positivity, and psychological well-being through this expression. We have already seen that the personal growth of a person by seeing to others' achievement. Some people who are successful in their life, we see their achievement, we may be sometimes getting motivated to perform better and look at avenues. Sometimes we even seek out to them to see whether opportunities are available for you to go ahead. So you may be setting your goals likewise, and you're motivated to work better to go ahead. So that is just one example of that. So mental health benefits, if we look into typically, which is associated with us, we have seen that video games can be a very important source for to be manipulated, particularly used as a health education material or as a therapy. Health education material, particularly in learning about and overcoming the stigmas, or gameplays may sometimes help you to come up with messages which may tell you about the intensity of their symptoms, which can be used by therapists to likewise plan ahead. So some of the games and some of the messages which are coming in the games can be used likewise. That's one of the study which has been done and has told that it can be utilized in that case. It can be used for screening, particularly mental health screening can be done using the social media. And you can be, just now, when they were talking about the stigma, they have done a study to realize what is the level of stigma, and such studies can be done through media, which can target to a very large population. Rather, when we do it on a face-to-face basis, we have limitation in coverage of population. But when we go through social media, it can be, a number of people can be, we can reach out to them, and that can be taken. Similarly, health education, which is can be done in form of webinars and to educate people. Suicide is a very important and drastic conditions which is happening in the society. Helplines to prevent suicide and media approaches may be utilized so that early detection, and persons who want to seek help, particularly they don't know where to approach. So if sources are available, then such things can be prevented. Other area which can be utilized is for getting connected. That's what everyone tells. Social media is one way by which we can keep ourselves connected, a feeling of connectedness. This feeling of connectedness is very important because it most of the time, particularly for those who are mentally ill, it is not that only healthy people need to be using social media, but those who are having problem also can approach the people. They can have their own groups which can be helping just like a self-help group. They will be helping each other, and they will be able to ventilate their problems and be non-judgmental in being approached to, and that can help in decreasing the depressive symptom, particularly mitigate their post-traumatic stress disorders, and overall improve the mental health of the person. Anyone seeking help also, because we know nowadays, as it is being told from the very first class onwards, the stigma of the illness is a very big problem, even in the educated people, even among doctors also, when I see, there are people who are having problem, they have issues in the house, and I know that they are being treated with issue, but when they will never come up openly saying that I am having that and I was treated with an illness like that. So they're all there. Whether there is an online resource, online help is there, particularly for counseling, which requires a lot of sessions to be planned, which may disrupt their normal routine. So in that case, some available media sources are available which can give them timely help, because particularly for suicide, if the person is being able to get the help at the right time, maybe that person may not have attempted to the suicide. The emotional effects on the teens when using social media, this is a beneficial effect which the teens talk about, because they are always, we know nowadays that in schools also the phone is a must for them, and parents, particularly parents, find it very difficult to keep them away from phones. So it is seen that they feel, 25% feel less lonely, 20% feel more confident, 16% feel less depressed, 21% feel more popular, 18% feel better about themselves when they're using their phones and on social media, and 12% are less anxious when they are using their social media. So this is a thing which shows that social media is one thing which is going to be there, but how it is going to affect the mental health, positive way, it is definitely having a positive implication, but with positives, there are lots of negatives which is coming in. So let us look into some of the unhealthy uses of social media. Because of excessive use, they feel that they're easily distracted and they don't have, they're not able to concentrate on things. Attention span, concentration span, etc. is very less. The most crucial thing which we see is about one-to-one relationship. The one-to-one relationship which was there, there was a strong bond which was there. That bond, even though social media helps in connectedness, there is still something false that is there, and hence the bond is not that strong. So there is likes, and when there is too dislike coming from that person, the person may be sometimes blocked. So that is what is happening. So there is less in communication skills, both written and verbal. We find that people are always using all short forms. Social media, if you look into, we don't have the full forms of writing things. It is all short forms. So nowadays, even on an answer paper, you may find students using these short forms nowadays. So it is that they fail to have a good communication skills being developed, both in person as well as written. Then of course, the real world, the reality at times get distorted, because in the media, everyone will project what is good for them. What is good is happening in us, we will be projecting that only on the media. Nobody projects what is happening to, if something bad has happened to me, I'm not going to put that into the media saying that such and such thing has happened to me. I'll be putting only good things. So nobody knows what is happening really in my life and how things are. So it does give a distorted picture to them. Everything is always fine. We know that in the process of life, everything is not fine. There are ups and downs. So when there is a down, what is happening? Nobody knows. Everyone knows how people celebrate their victories. So this is a vicious cycle. Once you are onto the social media, you don't want to be the FOMO, that is fear of missing out. You don't want to miss out anything on the social media, so you get addicted to the social, go on checking. When you're not checking the phone for some time, you come back and check. At that time, you see that you have missed so many things. That makes you feel anxious. So you again go on, and that vicious cycle of checking the phone goes on, missing so many things which is happening in your real life. The negative effect can start from the very young age. Those children who are given the phone, because nowadays I can see that parents give the phone to just children when they're eating. Tom and Jerry, all those cartoon or something is being put on the phone and therefore is given to the children. The children are sitting and looking at the phone. Mother is putting something in the mouth and the child is just swallowing it. The child is not bothered about what the child is eating also, because whatever is being put in the mouth is getting swallowed. If you just take out the phone, immediately the child will stop eating and the child will not eat. So that is what is going to happen. Similarly, the parents are busy with something, you give the phone to them, the child will be sitting with there playing with that phone. So it is not only that, even very small children who are not able to handle the social media, who will not able to hold the phone also, it may be kept somewhere and the child is looking at it. So this has shown that there is a brain development is getting affected because of that. And there might be worsening of attention and concentration abilities, and learning problems are seen in children because of impairment which may take place in the brain development of the child. So how does social media make you feel? 54% said that social media creates an overwhelming pressure to succeed, particularly when you see other people in your area succeeding in life better than you, you also have that pressure to succeed. So coming under that pressure is stressful. 46% said that comparing their social life on social media made them feel inadequate. So this inadequate feeling and feeling of pressure definitely is not a good sign, because that's going to cause a lot of stress in the person to perform, and that is going to affect. So negative effect of social media on youth and teenagers. They are not able to study, lack of interest in studies, increased demand for money, particularly for recharging or buying a new device which is having more features, or even for video games and playing. I had in the newspaper in Kerala, one news was reported in which the ATM card of the mother was used by the teenager, and the mother was not aware of, and around 3 to 4 lakhs of rupees was just taken off from the account for gaming. So that was when the mother realized that when she checked, 3 to 4 lakhs rupee transaction has taken place, and then only she realized that her child was using it for gaming purpose. So such a thing was reported. Similarly, harassment, women harassment over bullying type of a thing which can take place through social media. Influence of wrong personality. Influencers, we have lots of influencers on the media, and some of the influencers may have a positive effect, but a number of them may create a negative impact on the personalities of the adolescents who are in the growing age, who identify with role models and try to become what the role models are. So there is an increased cases of crime. Particularly this has happened mainly for money purpose. That's one thing which is there. Then also for some of the time it is groupism or activitism which may be there, and they may be becoming target to some groups which may be asking them to perform some crimes or something like that. Social media use and loneliness. So this is a study in which it was told that it was found that people who are using more social media are subjected to more loneliness. But this has been refuted by some persons, saying that it is not the hours that the person uses social media which is more important. It is how they use it, or for what purpose they're using it, that makes them feel lonelier. If the person is going to a social media to find relationship is the main reason why they want to use a social media, then they may feel more lonely than for any other reasons. So that is what this particular study has tried to say. Then there is a false sense of connection. This is another thing which has been reported in studies, which says that social media creates an illusion of closeness and false intimacy, which leads to a feeling of loneliness and confusion about real friendship. On social media or a group, you may have so many people who may try to comment on you, but when there is a real problem in life, when they have, I don't think so, such groups or such people are of any importance. So that's one which has been supported in literature, saying that there is a chance, there is a false connection which is coming through in social media. Loneliness and social isolations are a health risk, which shows that up to 50% there is an increase in developing dementia, 25% increase in risk of early death, and 30% increase in risk of stroke and cardiovascular diseases because of feeling of loneliness and social isolation which is taking place. The most important thing which social media has brought about is this FOMO, that is fear of missing out. This is a concept which is making everyone to check. We also sitting over here, I can see many people right now sitting at the back, just one sound of notification and our eyes goes to the phone, what message has come to, or what is that notification of, what are they? So it is, and every time we may say sometimes that it is my work. At times we'll be saying, when we're sitting over there, we'll say that it is something related to my work, but it may not be. And okay, it may be work. We'll look into the work, and then the next one will be something private that we are checking. So social media, even in assemblies, we have seen the people on the media. So that is what it is. Such a serious areas where discussion takes place also, we get taken up, carried away. So we can think about the younger generation who is here, who has little bit inhibitions being placed on themselves. So the social media and FOMO is like a vicious circle. Anxiety is created when they are not using social media, or when they find that they have missed so many things on the social media, they feel anxious. In order to avoid or decrease that anxiety, they tend to again get adhered to the use of social media, and that becomes a vicious cycle. Three interesting FOMO statistics and facts which we should know is, which social media creates the most FOMO? It's Facebook. We have saying that 72% have said Facebook, 14 in Instagram, and then Twitter and Pinterest coming likewise. And among this, which is the post which is creating most among the millennial FOMO? It is about travels, which place you have visited, where they have gone, how they are enjoying themselves. That's the thing which is taking. And then events and parties is 56%, and food is for 29%. What does FOMO make people feel? That's the last question. You can see it is envy, 39%, jealousy, 30%, sadness and disappointment, 21%. So ultimately, we are seeing others enjoying everything, and we feel, oh my God, I'm not able to do it. So envy and jealousy and all those things are coming up. So there definitely these negative factors piling in ourselves are not going to create a good mental health. We will have a problem there. So 56% of the population is afraid of missing out on any of the events. But the real fact is that we all want to pull out of this. We want a break, we want a vacation. At times we'll say, okay, I'm going to be out of Facebook. I'm going to be out of Facebook or Instagram. And they may sometimes even delete their account. But how long? So at times my daughter, actually, she was saying that I'm going to delete my account. I said, okay, it's good. You delete your account for some time. And she deleted the account. After 2 days, I'm seeing the account is again active. So that is a duration that she could only stay without that account. So I told only that is your maximum time that you can be out of your account. Why don't you think about pulling it to a week at least? So that's what it says, that 52% have either taken or considered taking a vacation from one or more social accounts in the past year. 24% plan to stop or take a break from at least one account this year. Because we know that we have not just one account. Social media, how many of us have only one account? Good, that's good. More than 3? More than 3. So I have Facebook, WhatsApp, Insta. So it's already 3. So we have more than 3 accounts or so. Adolescents and the younger generation have 7 or to 10 accounts they will be having, Snapchat and all those things. And I can see every time wherever they are, they're making their status updated by going on a Snapchat and saying that they are at present here doing this. So that's what is happening. So FOMO has adverse effects on mental health. on students studying, sleep, and productivity. These are the main areas which they may have. And important thing which we have to now think about is going from FOMO to JOMO. Joy of missing out. So from fear of missing out, go to joy of missing out, so that you can focus on what you have, you can do something that makes you happy, you can connect with the real world, express gratitude and to others and yourself also, and thank others. So go from FOMO to JOMO. So another important area where of concern of social media, which has been very much talked about, and literature also supports it. There are lots of studies saying that social media, excessive social media usage causes anxiety and depression. That is one important area which has been very much talked about. So definitely there are statistics to prove that it does affect the affective area of ours, and there are people with depression, and statistics does prove that people do have this. And this depression and sometimes goes into suicide also. So the suicide rates, if you look into, are very high. Suicide is the second leading cause of death among people in the age of 10 to 34 years. And nearly 50% who are diagnosed with depression and anxiety disorders may actually be thinking of, contemplating of doing a suicide. And depression is maybe treatable, but only 35% of the adults receive treatment. So there are many people who don't come forward, even though we have lots and lots of treatment. People are maybe saying, but now with Deepika Padukone coming out so openly with her depressive episode, things are a little bit changing, because depression is becoming a little bit more acceptable to, because she has a disorder and she's living with it, and there is not much disabilities, or there is not much problems being seen in her life, because she has so many hit movies coming up. So definitely people think that even though you have depression, you can have hit movies, then we can have a hit life also. So we can go ahead like that. So the numbers projected in India, if you look into, the suicide rate is 14.04 per lakh population in 2019, and it is almost coming up to the rank globally. The emotional drain which is happening, 45% is feeling worried or uncomfortable when they are not able to access their social media. 66% of the people have difficulty sleeping after using social media. 60% of the people feel that the need to switch off from the social phones, and 25% of people have relationship difficulties through social media. This is a very common thing which I see. Even in a house, when you go, you can see that the communication between the family members is minimum. All of them will be sitting with their phone. Sometimes the TV may also be on, and they'll be sitting in front of the TV, but all will have their own phones. They'll be with the phones. The children may be upstairs, the parent is down, they'll be communicating with the child upstairs through, please come down on the WhatsApp. So lunch is ready or dinner is ready, please come down. It's again going to be a communication like that. They're not trying to have a direct communication. So that's what is happening. So social media, and this is one important thing which I would like to talk on, social media and its effect on self-harm, particularly non-suicidal self-injury, which may not be leading to a death, but this is a common thing which is nowadays coming up. Its rate is around 14% and 21% among young and youth and young adults. This is mainly because of, it may be because of depression or some emotionally unstable personality disorders, or body image problems which is coming up. All these are getting highlighted through social media. The frequency with which people go about doing this, various forms of non-suicidal self-harm behaviors, like cutting themselves, scratching severe scratchings on their bodies, banging their heads, self-punching, self-biting, self-burning, with cigarette butts or something on their bodies. These are all some of the self-destructive behaviors and frequencies which has been shown. And we can see that it is slightly more in females than in males, with an average onset of age is 11 to 15 years. And it is associated with increased sensitivity to interpersonal stress and difficulties in emotional regulation. That is the most important thing which we are seeing, with 80% of people who self-injure being diagnosed with some form of mental disorders or mental illness. And self-injury isn't just they're trying to die, but sometimes the self-injury which they do may lead to the loss of life. So that's why we need to address it, because there is some underlying mental problem that the person is having which need to be addressed over here. Another very important and very common thing which we find out is sleep deprivation or sleep problems, which is associated with social media use. Data from 814 adults between the age group of 15 to 59 years shows that 2/3 of the patients reported poor sleep quality, and it's mainly because of blue light, which is the significance of the blue light of the device, which is causing impairment in the melatonin with production, which impairs the sleep. And you can see that 95% of individuals who are surveyed reported using the electronic devices at least an hour before going to bed, and 16 to 15% in the age group of 19 to 64 years are sleeping less than 6 hours. 95% are sleeping with their phone on the bed. In between at night, 50% who get up check up their phones, whether something is there on the phone or not, when they check in between when they get up. 10% of people are woken up in sleep by some, whether it may be a call or notifications or something on the phone which is disrupting the sleep, and 25% of people don't silence their phone when they're going to bed. So this is what is talking about sleep. Definitely the sleep is getting impaired. The next one is the cyberbullying which we have. You all know what is bullying. We have had enough, and some of us might have had bullying directly in our school days. Right from the school days onwards it starts, so it can happen anywhere. Now it has started on the cyber online also. So we have lots of cyberbullying happening on the platform. We say that there is connection and the likes which we get, but equally there might be bullying which is happening, which can affect the physical, emotional, mental, and psychological effects on the person. And we can see that what the victims feel and how they are affected by the recent images of cyberbullying which is happening. They have said that 65% feel annoyed, 64% feel angry, 55% humiliated, 40% depressed, and 32% are afraid of their safety. Even they are afraid to go out because they feel that someone may do something to them. How they are negatively affected: self-esteem is decreased, mental health is impaired, and physical well-being is also under problem for them. Body image is another area which is to be addressed by social media, because we know that people, particularly females, I will not confine this to female alone, because males are also having body issues and it can affect them also. But social media use for only 30 minutes a day can negatively affect how women view their bodies. That's what it says. So it says that nearly 80% of young girls report fears of being fat, because unrealistic pictures are being posted, lot of photoshopping, what editing is done for the pictures, and the pictures are posted. So the measures, weight measures, or the body measures which they are giving in the photo is very unrealistic. But that is not the thing which the persons, particularly young children, when they see these photos, it becomes their role model. So they try to be into that, and for that they will adopt any method. And that is dangerous. That is what happens. They visualize it in that form, they try to adopt it, and that is what is causing. 87% females and 65% male, it was found that had body image problem because of social media. 63% of women identify their weight as the biggest factor that determines how they feel about themselves. Young women are exposed to 400 to 800 media images per day. So it's a very big thing that has an effect on the persons. And we can see that there is a trend nowadays that social media can have a negative effect. Unrealistic body standards are getting adopted by them. Comparison and competition is done with others. Cyberbullying, those who are posting photos which are a little bit out of this or on a higher side, they get bullied for being fat. That's what they say, you look so fat. Worsening of body image disorders. If they have a problem of body image, that gets worsened. And the research suggests that it can lead to mental illness, issues, and disordered eating. That is what it culminates to. They go into anorexia nervosa or bulimia most of the time, which makes them to go into another list of problems which they have. The positive effect of body image, it's mainly when it is viewed in a positive way. It can lead to body positivity. When social media is used in a healthy way, it can be a platform for promoting body positivity, where people share images of their body as they are. And if they are getting appreciated for that, they develop a body positivity, and there is a promotion of self-love and acceptance, which creates a positive body image for the person. Health and fitness inspiration also comes through this particular sites to maintain the concerned body images. Eating disorders are also a sequelae of events which can happen as a result of body image problems. Low self-esteem and social media use is also a thing which is getting connected, because we know that there might be chances that the persons may be bullied on, which may make the person to lose their self-confidence, and that can lead to low self-esteem in those individuals. Another important area which we have to highlight is about the social media addiction, which we talk about. It is just similar to the other forms of addiction of drug or tobacco or anything of that sort. It says that use of social media to modify your mood or to improve your mood. You say that you're using a social media for that. So slowly you see that it becomes a vicious cycle and you cannot break it out, and you tend to use social media more and more. And thus, just like drug addiction, you get addicted to social media too. A very important area, another one which is coming right now, is revenge porn. You can see that a form of sexual assault involving the posting and distribution of sexually explicit and nude photos of the individual without consent. That's what is happening in the revenge porn. 1 in 10 ex-partners have threatened to post explicit photos of their exes on the media. 60% of those who threaten to post the photos are eventually will post the photos, and 90% of the revenge porn victims are women. 93% of victims said that they have suffered emotional distress and images when the images are being exposed, and many of them even have committed suicide. We have read it in newspapers that because of their images being circulated in the social media, they have committed suicide. Many of the cases of women have committed suicide. I had read a few cases in which they have been doing it recently in the newspaper. 49% of the victims said that they have been harassed or stalked online after their pictures were exposed. So this is also an area which is of danger, because many people, we share so many photos and images and all those things on the media, and media literacy, so social media literacy is very less among the public. So it can be sometimes used dangerous in this way, which can lead to a lot of problems. We have Indian laws and cybercrime protection factors are there, but still it will not improve the mental health of a person, even when the incident has already happened. Perceived impact of social media on mental illness, those who are mentally ill, when they use social media, how is it going to impact them? You can see that this is how has social media increased or decreased you can say the number of mentally ill and the stigma of mental illness. These are the two things which are being studied in this. You can see that the number of mentally ill, it has increased by 43%, and stigma of mental illness, it has increased by 30%. So you can see the impact social media can have here also. Just like it has been told, social media is a very good site area to use because it reaches a lot of population at a short period of time. So it can be used positively by, for awareness and identifying screening of mentally ill. So modifying social media will help you to improve your mental health, and it is to reduce the time online, because that has been repeatedly told that by getting addicted to social media, once one's mental health doesn't improve, it has shown that it tends to decrease. And change your focus for the purpose why you're using the social media. It should be with a definite purpose that you use, and after that you just go off. Don't be on the media for too long. Spend more time with offline friends. Online friends and groups are good, but to have a face-to-face interaction and to have more of online friends will be better. Express gratitude, and that too, not online gratitude. It is better to have a face-to-face and gratitude, and be more connected offline, so that you will have a stronger group and so to be created. But again, that's going to be a challenge with AI coming in, which will replace all these and bringing in more advanced factors. We'll have to think about, still researchers have to be done to come up with the exact factor and how it is going to contribute and what can be done for this, but definitely this is a thing which we can exploit. I won't say that we'll be able to ask people to stop using it, or to even decreasing will be little difficult, but still we may be able to bring up devices which will promote them to come to that area, or give warnings to them, because on screen we can see IT industry people, there will be a small pop-up coming up after some time to asking them to blink their eyes, to look at that particular distance out of the, to see that their eye health is maintained, because they'll be looking onto the screen for such a long time. So such things they are bringing up on this, so something like that we can also develop on the social medias, which can help them to, a reminder to see that they are being using the media for too long, to take them off from that. So that may be the way, because social media, just like hypertension, hyperlipidemia, these are also going to be a silent killer of your mental health. So taking part of it, or taking good, giving attention to it will definitely help us. Otherwise, just like the hypertension and diabetes, it will finally claim our life. Thank you.
Thank you, ma'am, for your wonderful presentation. Madam has covered all the content in a vast way, and it was very comprehensive, and we had an opportunity to check into the latest statistics, and the impact which is creating throughout the place. One thing I would like to add here, not only the adolescents, because adolescents are having the means most attraction towards the social media nowadays. They are not alone. Along with that, now equally, if you see, elderly people are also getting addicted to social media more because of loneliness, isolation, and as a part of post-retirement, this one, and emptiness syndrome. So equally, everyone are getting affected by the social media. And coming to the teens, they are at a very, very higher risk. Why? Because means for entering the social media, we say that it is minimum 18 years. If you sign up to Facebook, Facebook will ask your date of birth. You have to give 18, then only we will be able to enter into it. Whereas when it comes to Instagram, it is 13 years. And if you give 13 years, the default settings automatically will allow you to take up the certain settings which will be very safe for the children. But our children will not be aware of all those things. So they will be entering, and most of the children, those who are on Instagram, as per many studies, they do possess an account without the awareness of the parents who do not know what is social media is. And after entering to the social media, it is up to them and to decide whom to follow, like Madam was mentioning about social influencers and many things which are happening in the dark in the Instagrams. like cyberbullying, so threatening them with their photos or asking them to post something over that. So all these things are happening inside because parents will not aware that the children are having the social media account. And one more thing is, studies have shown that teenagers or adolescents are not using their own name for keeping the Instagram accounts, and they don't include any of the relatives into their circle. And every name is means fake name, whatever they give. And these are all the tricks they are applying into the social media. And one more thing is that Madam has nicely explained about all the points, impact of teens over, means impact of social media app over the children, like body image disturbance, so which will like unrealistic comparison with the photos which are generated from the applications, which set a high standard among the children. So through that, the children will try to compare themselves with the unrealistic thing, and they go into the depression, anxiety, eating disorder also is possible. And at the end, body dysmorphic syndrome also, many studies have reported body dysmorphic syndrome, and many people go into the deliberate self-harm also. So being in dark, parents or other people who are not aware of this, we are at a risk of losing the life of the children. So have a check on the social media usage of the children, and most of them will not use download the applications. As per the studies, it is given they don't download the applications, online they use, and they have, as Madam told, multiple accounts are also present. And one more danger is that they have an option of disappearing messages. So in the disappearing messages, if you activate what was the conversation which happened, the people cannot reveal. So these are all the risks of social media on the teenagers. So it is our responsibility to create awareness among the children. And one more thing, Madam has revenge porn. So this is also another one important issue which is happening. So between two people, when a conversation happens, that is hidden with them only. So we do not know what is happening. So rather than regretting after it, so as a responsible citizen, as well as a responsible person in the mental health care, we need to create a lot of awareness about the social media usages among the in the schools and teenagers, everybody. And one more thing is that reaching out of help. So reaching out of the help, though the adolescents and other people have these issues, so there should be a space for them to express this one in a non-judgmental way. So home is the place. So if anything happens, we have to accommodate them and help them to come out. For this, we have to create the children with resilience who will be able to decide what is right or wrong and to overcome the problems. This is about teenagers I wanted to tell. And next one is legal suit. So like when we see from our history, in 1860 itself, we have certain laws and rules which are applicable for the social media, which included magazines and other things. Like 124A deals with the sedition, and 153A, if anybody spread any enmity, so under that section they can be taken up. And 295A, insult any religion. If anybody has done, they can be, the same thing is applicable to social media also nowadays. And recently in 2000, they have got a Information Communication Act and guidelines has been given. This is from India, even from other countries like Australia, America, everyone has given the social media guidelines for their own states and countries. So according to India, if we see, we have 69(9) and 64A. So these two sections are there. So in that, if a person, when they are threatened or bullied, or if they are getting any Madam's presentation was excellent, and it was comprehensively presented, and it's my area of interest, so I was so impressed to sit and listen. And most of the points I wrote and kept, Madam already explained in so much of detail. So I'm very happy, ma'am, for your enlightening us with your knowledge. Thank you, ma'am.
Thank you. So thank you, ma'am. Due to shortage of time, we could not allow the hall to open. So now I will request Ms. Shayoni, please, Shayoni Ghosh, Shayoni Shingo, please come and accompany ma'am. Ma'am, please felicitate our madam, Dr. Usha Marath. Thank you, ma'am. Now may I request Miss Ma'am, please. May I request Madam Abhishekta Dev kindly felicitate our ma'am, Dr. Vijaya Rani, and Madam Tania, please accompany with her. Thank you, ma'am.
Now, hello. Now we will move into our next session. That is our 9th session. So we are very fortunate to have Dr. G. Balamurugan, Assistant Professor of Nursing, Telemanas, Nimhans. Sir will be speaking on innovation in mental health care delivery, reaching the unreached, including telemental health interventions. This session will be chaired by Dr. Sunita S. Masi, Associate Professor, Central Institute of Psychiatry, Ranchi, Jharkhand. Madam has been teaching the next generation nurses for over 20 years in the field of mental health nursing. She has more than 12 publications in various national and international journals. She is also a chairperson and resource person for various national and regional conferences, seminars, CNE, and TOTs. We are very blessed to have you, ma'am and sir. Over to you.
Very good afternoon to all. Very good afternoon to all. I know that it is time shooting and that everybody feel hungry also. So I request Balamurugan to please do it as soon as possible. Thank you for that organizing team and that patron and that Radhakrishnan sir and that all the executive member of ISPN and that SNU. They giving an opportunity to chair this session. I invite that Dr. Balamurugan is a joint secretary of ISPN India. Sir has is editor of Indian Journal of Psychiatric Nursing and was also associate editor of Rajiv Gandhi University Health Science, Journal Nursing Science, and he is author of that, also published more than 55 research articles in national and international journals. He is a life member of TNI, World Federation of Mental Health, ISPN, and International Stress Management Association, and many more. So thank you, sir.
Hello, check. Hello. Hello, check. Very good afternoon to all. Am I audible? Yes, I think previously Madam warned us, don't use mobile. Correct, no, ma'am? Yeah. So for next 20 minutes, we don't need to use our mobile. Just keep safe in your bags and pockets. Yes? Yeah. And shall we do one small game? All of you, ready? For that, mobile is hazardous. Don't use mobile. Okay. Okay. Yeah, very simple one. When I say one, just you clap once. When I say two, you have to clap twice. All of you ready? So your hand will be free without mobiles. Yes? Yeah. All of you ready? Yes. One. But I need one sound only. Shall we try? Yes? Yeah. One. Much better. One. One. Very good. One. Two. 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 One. Two. One. Yes. Very nice. Very nice. Very nice. Yeah. Okay. So hopefully we may not delay for lunch. By 12:30 or 1:30 we'll try to complete it. And we need more discussion. So I will take another 10 to 15 minutes to present what's happening in the innovations in mental health delivery. Mainly our experience we are going to share here. And we need more questions from all of you so that we'll be able to discuss and deliberate and we learn from each other. So your experience is most important for us to make a better service. So the outline of the presentation is going to be like this. So we're going to see why we need innovations and what are the innovations we are doing it. Then we'll see a few important points like I think it's not. Yeah, so current trends, what's happening, and then challenges, other important aspects, and what nurses we are doing it, and we can do it in current innovations. Will you please help me to next? Yeah, next please. Yeah. So first let's talk about why there is a need for innovations in mental health delivery system actually. So from day one, our DD mental health, he started about this mental health survey, NMHS survey 2016. From that, what we identified is, next please, around the prevalence of mental health disorders in India is around 13.7%, which means out of 130 crore means around 13.7 crore people are in need of mental health service. Please imagine, 13.7 crore people in India need mental health service. Whereas we have limited resources. From the last sessions we learned we have only 0.6 per nurses are available. So we need lots and lots of human resources to support this highly demanded service. Then next we have problem of treatment gap. So treatment gap in the sense, a person needs some treatment, I am getting the treatment. If you see, out of 100 people, 70 to 92% of people, they are not receiving the treatment what they are supposed to receive. So remember, 92 means what? Only 8% of the people are receiving treatment, mental treatment, what they are supposed to receive. Whereas 70 to 92% of people, they are not able to receive the treatment what they are supposed to receive. Then last and most important point is stigma. Even though we are mental health professionals, we are very difficult, we are having hardness to say that my family member is having some psychiatric problem. So stigma is another very, very big concern in reaching all the people in India to deliver the service, even though we have some amount of service available. So with this background, the innovations were started. Now we are going to focus mainly the 4 areas, that is the tele-neuropsychiatry, what's happening in the neuropsychiatry, and then tele-aftercare, then tele-extended clinic, tele-manas, and other areas. In these 4 areas, I'll talk about another 10 to 15 minutes. So if we talk about the next please, tele-neuropsychiatric consultation. So you know, neurologists are very highly demanded professions in India because they're very limited in number, but whereas services are required much more. So to overcome this problem, what we did, we made a neuropsychiatric service with the use of technology. So where we use the hub and spoke model, where the tertiary care hospital in South India was a hub. it was connected to, next please, next. It was connected to district hospital in the state. So the district hospital medical officer in the state can consult a neurologist, a neurophysician, neurosurgeon in the tertiary care hospital through technology, video conferencing facilities. So through this, next please, we are given consultation services, a live video consultation with the patient at the district anywhere in the particular state to a neuro specialist service so that they can get a consultation with 15 to 20 minutes consultation average. Then we provided the ongoing services, mainly follow-up services. And also we get able to provide the family and patient education through this teleservice. So which means a person who's suffering with neurological problem, they need not to travel to a higher center where they need some treatment. So they can be at the district level, so the service can be delivered at the district level itself. This is one innovation has happened, it's happening, it's going on. Second, if you see, the second innovation is prison. Next please. So neuropsychiatric consultant in the prisons. So what we try to do here is, we try to connect the central prisons in the state to our neuropsychiatric specialist. So the inmates in the prison were consulted. Here we use a model called CCC, this collaborative care model. The medical officer in the prison is in charge of these particular inmates, but he can take a collaborative decision in consultant with the specialist in the higher level, that is tertiary care hospitals. So through this technology, we could able to provide service in the prison itself. So where the prisoner need not to travel. You know, if you want to commute, if you want to transport a person from prison, we need a lot of escorts, we need a lot of manpower. So those things can be avoided. Through this, we could able to provide the service to the inmates of the prison. Not only that, next please. We could able to provide fitness to trial through this technology. So otherwise what happened, the person should come to a psychiatrist, a neurologist, or there they should provide a fitness certificates. But through this method, patients or inmates were in the prison, but we could able to provide the fitness certificates. This is second another innovation I would like to share. Third one is most important point is TAC clinic, we say, that is tele aftercare. That's what ma'am was discussing, and discussion was happening in the social media also, how to prevent the relapse. So as we know, relapse is the major concern and major issue in psychiatry. All of us we know. Even if you ask you to take 5 days antibiotics, so do we take 5 days? No, any 1 or 2 we miss. Am I right? So during the nature of illness, the person with psychiatric illness, they should have minimum 3 months, 6 months, 9 months duration of treatment. Once they're getting well, they try to stop medications and then they'll revert back to the same conditions. To overcome this technology was used that is called tele after clinic. So it's mainly used for, we started in the year 2016. It's mainly used for the non-emergency care patients as well as routine follow patients. So what we do at the time of discharge, we'll take consent from the patients and relatives and we'll get their contact details. So we usually ask for a 1-month follow-up. In this tele aftercare, we'll ask them, will you prefer to take this service? You can use your mobile phone or computer to connect with us. So once they give the consent, then our technology people, technical person in the center, they'll try to connect the person in the family and the patients at every month. So every month the follow-up is done through this technology. So the patient need not to travel to a place to want to see a same doctor again and again. So it can be done, and it is it's happening in India. That's why I want to tell you. Next please. Yeah, so through this consultation, what we do, not only provide consultation, we take a regular prescription, that is prescription will be scanned and sent to the patient, so they can get the medications in their own place. They need not to travel. And second, next please. Yeah, so because of this, what happened? Just this is one outcome of this TAC clinic. Because of this, we saved around 13.5 hours of travel of a patients and family members. So this study I would like to share here is 30% of the patients are from West Bengal. 30% of people, they used to travel from West Bengal to Nimans for treatment. Now they are not traveling. So we saved their 13.1 hours, average hours of travel, around 1,700 kilometers they used to travel. And second, what we saved is a travel expense around 5,000 to 50,000. Third, the patient can able to save the accommodation cost. And overall, if you see, an average around 20,000 to 30,000 of money is saved for the family and patients through this innovation, only through this tele-aftercare clinics. So this is the evidence from in NIMATS what we did. And then we asked, why are you preferring this service? So next slide, please. So once they said, because of financial constraints, and some people said it's because of lack of persons to accompany them. So they don't have people to accompany, so that I can be in online, so I can get the consultation. Third, they said mobility issues. I'm unable to move, so I can be at my home so that I can get consultation. And fourth, if you see severe symptoms, it's easy to access, and if you see 100% people said it's affordable, which means they need not to spend excess money. With the available costs and resources, they can able to get the service what they require. Second, if you see 100% people said it's very, very convenient. And we assume that in-person is most convenient, but this is most convenient for 100% of the population in the study. And third, if you see 100% people said that I want to meet the same doctor, so that that continuity of care will be maintained. So this is another outcome because of this tele-aftercare clinic. The next one, we have the tele-extended clinic, that is TEA, tele-extended assessments. So where what we do, as we know, the psychiatric assessment which takes long time. Am I right? So first we have an initial assessment, a person one-to-one, then we'll get their consent, can we do this assessment through online? And if they give consent, we'll fix these tele-extended assessment clinics. So the patient at their home, they can be there, a psychiatrist from our end, they can connect through this video technology, and we can do a detailed assessment for 1 to 1.5 hours. So they need not to travel. I'm talking about only travel, but there are a lot of things behind this technology, especially stigma. Especially stigma. Even I may be at home, I don't want to tell to anybody that I'm going to psychiatric hospital. What I can do, I can make an online appointment, I can get consultation. So that I can able to be in my room, in my home, in my town, I can get a consultation with a psychiatrist. So that at least people can come forward. Meaning is the next person may not know about what's the problem we are facing it. So stigma can be managed at this level. I'm not saying 100%, at least we have some service to overcome this stigma. This is tele-extended assessments. Next, not only this, as a tertiary care unit, we have a lot of responsibility to increase the manpower. So for that, we conduct a lot of training. Previously, it was completely in-person training. So we should train the medical officers, but now the training is made up of technology-based. So first set of training will be for the medical officers. I think Dr. Naveen is here. Last year we went to Bihar to train the Bihar medical officers. He was a part of our team. And during that training, we involve the nurses also. So it will be concurrent training where the doctors and nurses will be trained in primary care psychiatry. So not about the main psychiatry like MD psychiatry level, but primary care psychiatry will be trained at the medical officers level. So that the medical officers can screen the people, those who are coming to their PSCs and CSCs. Then they can give some basic consultation and a prescription. Not only that, if they have any doubt, they can immediately connect to a person, a psychiatrist in the tertiary care hospital. So it will be a kind of collaborative video consultation. We say it is CVC, collaborative video consultation. So he can make a video call and he can show the patient, and at the other end we have a psychiatrist. So both will do discussion, and then kind of collaboratively diagnosis will be made, prescription will be done. So this is a collaborative video care is possible through this technology. So a person from Bihar can get consultation from the NIMATS through this facility. So that way we are training medical officers, nurses, community health workers, ASHAs, and even rural medical assistants. So I think in legal, one of the things we discuss about the task shifting and sharing of tasks. So here nurses are the main key player in getting this mental health to the grassroots level. So as we discussed in the previous sessions, 1.6 lakh community wellness centers are going to happen or happen already, which is manned by mid-level healthcare providers, nothing but nurses. So if these nurses are trained in mental health care delivery in the basics level, definitely these are the ambassadors for us. Our students, I'm telling you, those who are teaching, our students, our nurses, I'm telling, our nurses, we are the ambassador for taking this mental health to the grassroots level. So they need some support and training that through this technology we could able to provide. So they need not to travel. Any doubt, they need not to hold it, just they can make a video consultation. So this is the way we are training. And next most important point is, I need your mobile phone now. Okay? So thanks for abstinence from mobile for last 5 to 10 minutes. So thank you. Now let's have discussion through this mobile. You take your mobile, please scan this QR code. Take your mobile phone. You can scan this QR code, or you can type in Google slido.com. You can scan or go to Google, type slido.com. You can type slido.com. If you are unable to scan, no problem. Please type in Google slido.com, S-L-I-D-O. Slido.com, and it will ask some number. You can press 144. So slido.com, join 144. Press number 144. Yeah. 44. No, if you scan, it will directly take you. If you scan, it will directly take you the quiz. Yes, yes. You can see, ISPN Kolkata. Yes, yes. So ISPN Kolkata is the title. So I think hope all of you have joined in this. Yes? Yeah. Slido.com and 144. Yeah. So just, you will get some question in your mobile. Just respond to this. Please respond. This is for practice, okay? Don't see the screen. You will get some question in your mobile. You can practice it. Around 65 members present already responded. Around 86 members responded already. Yeah, 93 responded. 96 responded. 97. Around 100 people, we reached 100. So 100 people responded, very good. Century, yes, century plus now. Yes. So 106. Yeah, so 109. Yeah. So 118. Yes, just let's going on. So that's the second question for you. So please type, I am from, where are you from? Just you can type there. Where are you from? Anything. No correct answers, okay? This is for us to be familiar with this. So Kolkata, West Bengal, Rajasthan. Yes, Assam, Uttarakhand, Gujarat, Punjab, Haryana, Jharkhand. India, somebody said India, okay, I'm very happy. So India, it's nice, yes. Rajasthan, Puducherry, Jammu, Maharashtra, Bangalore, and somebody from 144 also. Not room number, okay? Yes. Yeah, yeah. So next is most important question, okay? Most important question. Don't see screen, okay? Questions will come to your mobile. Yes. Did you experience stress? Not because of these classes, okay? In general, I'm asking. In general, I'm asking. Do you experience stress? I think, yes, some 7% said no also, very happy, okay? Stress-free person, yes? Yeah. Yes. I think this is the way we get the response. More than 90% of the people we are experiencing stress. Okay? Yeah. Can you go next? Yes. Next is for you. When you are in the time of stress, what will you do? Just type there. What will you do at the time of stress? Yes? I sleep, very good. Sleeping, now also I am sleeping, yes? So listen to music, take a nap. Yeah. So talk to wife. Yes? Next is question, whose wife, okay? Yeah. Another one is eat a lot. I eat a lot. Deep breathing, yes. Walking, take a break. Netflix, when some people try to overcome the stress. Yes. Write, walk, pray, prayer, exercise. Blabber, somebody blab, okay? Blabber, okay? Yes. Eat good food and sleep. So eat good food and sleep. Yes. Yeah, 144, yes. Yes. So from this, what we understand is, most of the people, the bigger the size, the more number of people. Which means most of the people are preferring to listen to music. It's very good. So one of the very good positive coping strategies so that we can use it. And somebody said, we'll talk to some of my friends and blabber with somebody. So those things are there. Next question, please. Next, please. Yes. Suppose if nothing is available to you, you want to listen to music, or there is no instrument to play music to you, something like this. In that case, do you have anything government is supporting to you to handle your stress? Do you know anything like this? Yes. So 14416, sleep. I'm asking government, okay? Please don't say government is sleeping, huh? Yes. So 14411 is another number has come. Manas has come. Yes. 14416. One more number has come. No idea. Telemanas. Yes. Sleep. Yes. Yeah. 77. Very good. Yes. Around 90 people said. And majority, you are saying some number is there that's called 14416. Yes? Yeah. Sati helpline. Yes. One more helpline. Sati helpline. Very good. Sati, I'm sorry. Mother's number, okay? I'm asking government's helpline number, okay? Yes. Very good. So we can stop. Just a second. Yeah. Yeah. Hope you enjoyed this. Yes. So basically what we are trying to say here is, we have to understand, accept this 90% all of us are having stress. We have to accept it. At the same time, we have something effective mechanisms to handle our stress. That's also true. But always it may not be possible. So government is providing some support for us to overcome the stress what we are experiencing. That's nothing but telemanas. Okay? That's nothing but telemanas. So telemanas stands for it's a part of National Digital Mental Health Program. It stands for Tele Mental Health Assistance and Networking across states. Yes, next. Yes, next please. So through this, what we're trying to do is, we're trying to provide 24/7 mental health support across India. So the number is 14416. 14416 is the national helpline number, where anybody in India can call anytime from anywhere. And these calls are completely free. It's a toll-free number, completely free. And it is available in 20 plus languages. It is available in 20 plus languages, 24/7, 365 days. 24/7, 365 days. I'm very happy to see here around 80% people know this number. So I'm very, very, very happy to listen to this, because we are trying to take this number to grassroots of Indian population, but you people are our ambassadors. So please share this number to people you know and person you meet and student you teach. Yeah, at least 50 members, as I said. So please, yes. Yes, so that we'll have a ripple effect. It will be multiplied by numbers so that we can reach the grassroots people of Indian country, so that they can get access through this, get the service of Telemanus. So what are you doing in this? So basically, a person calls to this number 14416. You will get a IVRS connection. Will be connected by a through a particular cell. In West Bengal, we have 2 cells are there. So it will be connected to a West Bengal cell. And there we have trained counselors available. They are the trained and accredited counselors. They will take a call and they will listen to your concerns. Please understand, Telemanus is not there for provide solutions. We are not providing solutions. But we are here to listen to your concerns. Listen to your concerns and help you to develop your own solutions. So that's the whole principle of Telemanus. So we believe that, I think all of us also, 80% of the concerns can be solved if you are listening. How many of you agree? Yes. Okay. The problem is not why it is not solved, because we don't have a person to listen to us. So Telemanus is the person. I'm telling you. At 2 o'clock, you feel you want to talk to somebody. Don't worry. Please call to 14416, and there will be somebody to listen patiently to you. So the person will be listening to you, and we believe 80% of the problems can be solved at this level. Suppose the Telemanus counselor feels this person needs some additional support. So next, please, it will be escalated to next level. So once you call, it will go to Telemanus counselors. Yes, wait. So it will go to the next level, where each Telemanus cells we have mental health professionals, which includes a psychiatrist, psychiatric nurse, psychiatric social worker, and clinical psychologist. The 4 mental professionals available within the cell. So if the counselor is feeling the person needs, the caller needs some support, this call will be escalated to the mental health professionals. So mental health professionals can deliver the mental health services. And we believe around 10 to 15 can be solved this method. So 80 and 90, 95 can be solved. Still, the psychiatrist in the cell feels the person needs some admission, and it will go to the next level. So where the call will be connected to the next tier, tier 2, where the call will be connected to DMHP staff. So the DMHP staff will be in touch with the caller. So that the DMHP, even the callers will be visited by DMHP staff. We have few success stories are there. One from north part of district, where we got a call where the person said, we are not allowed inside the village. And then when we deliberated, discussed in detail, we made few more calls to the person. Then we identified this caller needs some in-person support. So that caller was connected to the DMHP team. So DMHP team visited the person. Then we identified not only one person, their family members. 5 members are suffering with mental illness. So the 5 members were admitted and treated. And not only that, the social worker and the DMHP team talked to the village authorities. Then after the treatment, they could able to integrate the whole family into the system of village itself. So that's one of the way, the power of Telemanus, it can integrate the people like this also. And then we got few more success stories where we can support the people, those who are, as ma'am said, no, non-serious intentional self-injuries. So people used to call on the highway, I'm in my highway, I don't know, I'm going to end my life. Just I need to tell this to somebody. I don't know anybody, I'm calling this number. So it's happened in Maharashtra. So where we could able to support the people. So through the mental professionals, they successfully convinced the person and took around 45 minutes to 1 hour, talk to the person and supposed to convince the person and ask them to meet a consultant in the next day. So like this, we could able to deliver some kind of services. We can prevent and save the lots of life. And as I told you, 80% of the calls can be solved only by actively listening to the callers. So that's the main thing we are doing it. Again, I request all of you to, I think all of you know this number, please spread this number to the people whom you know, yes. And as on today, we have 49 cells are functional in India out of 51. And very soon, the 2 more cells will be starting. So our plan is to have 51 cells. Next, please. So as on today, we have received around 6.5 lakh calls, actually. So October 10th, 2022, we launched. As on today, it is 6.5 lakhs calls we received. And majority what we face, the challenges in this could be the coordination, not only about telemanas, entire the technology I'm trying to say. Coordination is the big challenge. Inadequate training and lack of skilled workforce. For example, in a district level, we want to train the person. There we need a skilled workforce so that they can support the medical officers to run these technical aspects. So that manpower support is required. Next is poor follow-up. Even though we have the service, the family member should come to the district hospital for the follow-up. And if they're not coming, again, it's a big concern for us. Then privacy and confidentiality, cross-cultural acceptance, and last one is technical difficulties. As we faced in the last session, day one, even though we are using the technology, is its own limitations also. Sometimes we face the technological issues. Example, in telemanas, if we take, the call may get cut abruptly. So we have to call back again because of the network issues. So these are a few concerns we faced. Next. And other things, other than this, I want to highlight 2 more things. One is called as e-manas. So e-manas is, as ma'am, first session, ma'am said about Mental Health Care Act. So Karnataka developed an online platform where the Mental Health Care Act, how it can be implemented digitally. So that platform is called as e-manas. So in e-manas, the mental health establishments and mental health professionals and patients and family members, everybody can enroll their detail in e-manas. And as an advanced directives can be uploaded in e-manas, nominated representative can upload it in the e-manas. So that's a system we are trying to develop. It's already developed in Karnataka. Similar thing can be duplicated in other states also. Next one is about the telenursing guidelines. It's already developed and released by NIMANS in the year 2020. It talks about telenursing guidelines, how telenursing can be implemented. And to talk more about the nurses' contribution in this technology innovations. So one thing we can say, so as a nurses, even though we are technical persons involving in this, nurses are crucial person to develop this relationship, a therapeutic relationship. Even though the caller may be in video call, the way we are communicating with the callers will maintain a therapeutic relationship. Then there are the people look like a mediator between the service provider, that is mainly medical officers, psychiatrists, and the patient and family members. Next is the prioritizing the patients. So we schedule some 10 patients in 1 hour. Out of 10 patients, if a person needs some kind of side effects, needs some immediate treatment, that triage can be done by the nurses when they are assigning the consultation place. And next could be the identifying red flags and side effects. This is the most important work of nurses because majority of the patients stop medication because of side effects. So when you're doing follow-up through them with the technology, video conferencing, we should be able to identify the side effects, and that can be titrated with the appropriate dose of and type of drugs. Next is the patient and family education. So whenever there's an opportunity, the nurses working in the team, they could be able to provide the patient and family educations. Yes. And last point I would like to add this, and we were discussing about nurses are not there in the policy making level, and I would like to say I got an opportunity to be a part of the National Apex Coordinating Center for Telemanas. So we are the team of 20 members, includes a psychiatrist and psychiatric nurse, and few more team members, psychology and clinical services. As a team, we are responsible for delivering, maintaining, and supervising the telemanas all over India. So I'm very proud to say that I'm part of this National Apex Coordinating Center Telemanas. So I'm telling you, nurses are being recognized in these levels also. So I'm the example for this, okay? Yes, yeah. Yes, I think I'm in time, I feel. And next most important point is questions.
The name of the psychiatric nurse from West Bengal in Telemanos, particularly in West Bengal.
Yeah, ma'am, really, I'm sorry, ma'am. I do not know about these specific details. Yeah, because we are covering all the 36 states and union territories. So I'll let you know who is the responsible person. And another point is, since health is a state concern, and the recruitment of the manpower is completely by state government. So state government only recruit the manpower, including counselors and mental health professionals. Once the state government recruit the manpower, from NIMANS we train them. So that is the way we are collaborating and networking all the states, ma'am. Yes. Yes, yes.
Assam, we have a psychiatric nurse in Telemanus. She is ours passed out, Kajusri.
You said something about DMHP, who is in district also. We should know because we are feeding our psychiatric nursing here in West Bengal, but we don't know the names who are involved in this.
Yes, definitely we'll get back to you, ma'am, with that detail. Yes.
So,
Yes, please.
thank you for this enlightening session, first of all. It was very interesting.
Yes.
I wanted to ask you if there are any trainings available for nurses who aspire to contribute to telenursing or like join your team.
Yes,
in
yes.
some way.
So it's a very, very good questions, ma'am, actually. As far as Telemanas is concerned, as I told you, the recruitment is completely by state government. Okay. So once state government notifies about the recruitment, once they recruited, it will be, and NIMANS will take the training. Okay. Other than that, in NIMANS Digital Academy is there. Okay. So there's something called NIMANS Digital Academy, where we have lots of training courses are available. Okay. So please visit NIMANS Digital Academy, and you can enroll any one of the digital driven courses. Then you can be, you can learn these aspects also.
Okay.
Yeah.
Thank you.
Thank you.
Deliver your teleservices. Suppose, like initially Dr. Jagdisha Tirthahalli, he wanted to help his patient. He didn't depend on anybody. He arranged the follow-up calls with them, and he assured. I give one example, one person from Hassan to Bangalore, it is 100 kilometers. So he initiated the follow-up OCT, the tele-OCT online this one, and the patient need not to come. He delivered the prescription itself. So individual effort make a big difference. So you can also do that. You can also.
Hello.
Nice, nice. Yeah, yes, please, sir.
Yeah. So for the training, I want to highlight here.
Yeah.
The Ministry of Health and Family Welfare has designed a special cell for the training in the digital health. Training in the digital health, any digital policy from the government of India, it includes all healthcare applications, including Telemanas. Any training you want from Ministry of Health, an agency has been established by the Ministry of Health in 2014. That is the NRC, National Resource Center. Okay, you can send your mail from your institution with the number of your participants. It's available free of cost by the Ministry of Health. Any digital initiative in the country, it will be freely trained to the all nurses, doctors, psychologists, any health professionals. Okay, I am a coordinator for that.
Sir,
and you can mail us nrc-help and yeah. Sure. Tomorrow my session is there. There I will be highlighting this. Okay? Thank you.
Sir, I work in IMHANS. So we have one of the nodal centers there in Institute of Mental Health and Neuroscience, Calicut, Kerala.
Yes.
I was in the scrutiny committee when ma'am was telling nurses should be included. They have advertised calling nurses, psychiatric nurses.
Please
social
maintain
workers.
silence.
Yes, ma'am. Attention, please.
And after sir's speech, we are going to announce that where the presentation will be in the next session. Please be patient.
See, Telemanas, they had advertised calling social workers, psychologists or nurses. Equal importance were given and no nurses applied. I was in the scrutiny committee when I was checking all social workers applied, psychologists applied, and I was included in the interview. We have selected a social worker. Seeing no nurses were applied, nurses are focusing to join institutions than this type of job. I don't know why they are not coming. When ma'am has, might be different in your situation, your states, but where I am working, I am in Kerala, work in Calicut, and this I have seen a lot of applicants, more than I think 200 applicants were there. We could, it was difficult to search. I couldn't find any single nurse applied. I don't know why. So, thank you so
Thank
much.
you. Immense Kolikot is one of the mentoring institute for Telemanas, so they are taking the responsibility. Yes. Any other questions? Your suggestions and contributions? So if no questions, I take this opportunity to thank the organizers, SNU, giving us an opportunity to share the experience what we have gained and to learn from each other. Thank you, and I think thank you all for all of your patience listening. Thank you.
Thank you, sir, for this wonderful interactive sessions. So now may I request? Yes, ma'am, you can conclude.
It is a nice presentation and that nice exercise. You have to gather that all the participants, and that it is very important for that. Telemanas is very important at telenursing. But now that days that people are not aware about that all those things. How can we help to our community peoples? Because most of the studies I found that 80% that doctors are or mental health professionals working in that are it's not working. It's working in that basically that urban area, but only that all the populations basically that residing in that urban rural area. So 20% people are get that mental health only care to that peoples. So now this opportunity is that mental health. We have to go to that community and that train the person to take care of that all the mental health. Because so many studies I found that all those things. So we people in that our in CIP full-fledged telemanas program is going on, and that but they regarding that Reena, she asked that about that so many applicants are coming for that nursing people for that consultation, but they are only they join that psychology and social workers, not that nursing people. Why it is that? So this is my question, is there in that NHM and that Ministry of Health and all those peoples. Because in CIP also so many nursing people, those who are completed MSc and PhD and that other courses, but they only take that only psychology people and social workers. But in that in societies, nursing are more effective person to take care of this things. So I not taking so much time regarding this. I thanks Mala Murugan is presented very well, and that people are more aware about the telemanas and all those things. So thank you so much.
May I request Sister Shubhra Shah, please kindly felicitate ma'am, and Miss Pooja Bokshi, kindly accompany her. Thank you, ma'am. Thank you, sir, so much. So
now we will take our lunch break. So before going to lunch break, I want to announce that after lunch, we will have our scientific paper presentation in in this hall, that is seminar hall. The students and the faculty member will present here, and also in the 4th floor, room number 407, there will be also a scientific paper presentation going on, and also there will be an workshop that is arranged in our boardroom, that is ground floor of this building. So simultaneously all the presentations will be going on, so you all are requested to attend after lunch by 2:30 p.m.
those who all are interested for workshops, so only around 30 pupils can join over there around 2:30 p.m. Yeah. Yes.
Sorry, the workshop is limited to only 30 to 40%, attendees. So it is, you can say, early child mental health interventions.
The workshop will be presented at the boardroom on impact of developmental disorder on mental health of children and role of primary healthcare nurses. Only 30 people can join over there. Other people can split for this seminar hall for the scientific paper presentations, and for the faculty and as well as the student, according to the list. You can follow the list which is in the board, okay? Notice board outside of this seminar hall. And for the students, paper presentation will be in the 4th floor 407 in our classroom. So you can join over there also. So list of the presenters you can see from the notice board. Thank you all. You can join after the lunch break, sharp at 2:30 p.m.
Hello? 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 Yes. Good afternoon to all. Hope you all have enjoyed our lunch. So we will start with our scientific paper presentation. Just be patient because there is some technical error. Hello. So the hall is quite empty. So those who are sitting at the back side, we are requesting you to come in the front. Those who are sitting in the back side, you all are requested to come in the front. Hello. So we are starting our scientific paper presentation. For that we have the esteemed faculty members and the students. They have come from the different parts of our country. So for this scientific paper presentation, we have as a evaluator Dr. Janarthanan, Faculty of Department of Psychiatric Nursing, College of Nursing, Jipmar, Puducherry, and Ms. Reena Sajid. So we are requesting Dr. Janarthanan and Reena Sajid to come on the stage. I request Ms. Madhurima. Okay. So for the next session, I am handing over the podium to Ms. Moushumi Rakshit to conduct the session. Thank you.
I am calling our first presenter, Dr. Reena Barai, Assistant Professor, Government College of Nursing, Raipur. Madam, please come on stage and present your paper. You have 7 minutes only. Best of luck, ma'am.
Good afternoon, each and everyone present here. I would like to thanks giving this opportunity to stand here and give my presentation. So my problem statement is effectiveness of gardening in reducing stress and increasing coping ability among the psychiatric patient attending in selected psychiatric hospital Raipur, Chhattisgarh, a mixed method study. First of all, introduction. Long-term stress increases the risk of mental health problems such as anxiety and depression, substance use problems, sleep problems, pain, and bodily complaints such as muscle tension. Gardening has a both immediate and long-term effect on the health for individual with mental health condition. Using gardening as a means to facilitate dialogue and the coping skills building and improving chronic and acute mental health conditions. People report feeling happier almost immediately when engaging in gardening. My objectives are to assess the level of stress and coping ability among psychiatric patients, to assess the effectiveness of gardening in reducing level of stress and increasing coping ability among the psychiatric patient, to find out correlation between the reducing level of stress and increasing coping ability among the psychiatric patient, and to explore their perceptions of feeling, interest, and mood to perform gardening work for reducing stress. Hypothesis: there is a significant difference between the reducing level of stress and increasing coping ability among the psychiatric patient admitted in the mental hospital, and there is a significant correlation between the reducing of stress and increasing coping ability among the psychiatric patient admitted in the selected hospital, mental hospital. Methods: the mixed method qualitative and quantitative study was conducted in the psychiatric hospital Raipur. In first session, a standardized tool, perceived stress scale and brief coping scale was used to explore of prevalence rate of the stress. After assessment, the investigator provide gardening activity regularly for 1 month, 2 times a day, morning and evening for 1 hour each. 40 psychiatric patient, non-probability purposive sampling. Technique was odd and even method. And in the second section, the self-structured depth interview guide was used to data collection, and thermic manual analysis was used to analyze the data on the Microsoft Excel. Research design: quasi-experimental research design, pre and post, control group, setting psychiatric hospital, then sample, non-probability purposive sampling technique by odd and even method, tool, standardized tool, perceived stress scale and brief coping scale, and death interview guideline. So this is my studies. In pre-test, I am using standardized tool and then given a intervention gardening, and after that post-test. The control group also I am given simply observed nature placebo therapy. Then limitations: I am taking 40 psychiatric patients only, and in that 20 in experimental and 20 in control group. The present study was limited to low, moderate and high level of stress psychiatric patient, poor, good, average and excellent coping skill psychiatric patient. Then present study was limited psychiatric patient, the age range of 18 to up to 45 years. The study was area was present studies limited to psychiatric hospital Raipur, and present study was limited to 2 groups. One group's intervention gardening and other group's placebo intervention. The result reveal: the first of all assess the level of stress and coping ability. In that I have seen the show the pre-test experimental group, 25% become under the level of stress, 55 were the moderate and 20% were severe. In the post-test experimental group, 65% low stress level and 35 moderate, and the 0% is severe stress level. The pre-test experimental group mean 8.485 and standard deviation 0.748. The post-test experimental group mean 17.210 and standard deviation 2.184. After that, in the stress level in the psychiatric patient, show the control group, 20% were low, 45% were moderate in the pre-test, and 35% severe. And after the post-test, 25% were low, 55% moderate, and 20% were severe. Pre-test control group mean 10.240 and standard deviation 0.978. Post-test control group mean 10.240 and standard deviation 0.978. Then come to the next, coping ability. In the experimental group, I have seen the pre-experimental group, 65% were poor level of coping, 30% were average, 5% were good, and 0% were the excellent. In the post-test, I have seen the 0% shows poor level of coping, 15% were average, and 60% were good, and 25% shows excellent coping ability. Pre-test experimental group mean 8.478 and standard deviation 0.952, and the post-test experimental group 18.451 and standard deviation 3.254. Now come to the among coping ability. Coping ability, I have shown the pre-test control group, 55% were poor coping skill, 35% were average, and 10% were good level of coping skill, where 0% are excellent. Then post-test control group, in 45% are poor coping skill, 50% were average, 5% were good. Pre-test control group mean 9.512 and standard deviation 0.789, and the post-test control group mean 8.978 and standard deviation 0.985. Now come to the effectiveness. I have seen effectiveness in that we have seen after giving a gardening, stress level are reducing and coping skill were increasing. So we have seen the reducing level of stress among the psychiatric patient admitted in selected mental health hospital in pre-experimental group, post-experimental group. Pre-experimental group mean 8.485 and standard deviation 0.748 and mean percentage 42.452, and post-test experimental mean 17.210 and standard deviation 2.184. The mean percentage 86.05, t-value 18.541, and degree of freedom in 19 with the 001 level of significance. Then again, the coping ability, we have seen effectiveness of coping ability. In that, we have seen pre-test experimental group and post-test experimental group. In the pre-test, 8.474 standard mean and standard deviation 0.952, mean percentage 49.935. Post-test experimental group, mean 18.451, standard deviation 3.254, and mean percentage 92.255. The t-value 21.124 and degree of freedom 19 with 001 level of significance. Okay. In the correlation, we have seen the correlation and coefficient. It is a highly significant. And second, again, the coping skill also highly significant. In depth interview, we have seen feeling, perception of feeling. 80% of feeling are good for doing gardening, 20% feeling satisfaction of that activity. Interest about 85%.
Kindly finish, your time is up. Kindly finish it.
Okay. So conclusion, gardening is a new concept of reducing stress and increasing coping ability. It improves the mental and physical functioning ability. Psychiatric patient with a mental health problem, the findings suggested that despite reducing level of stress and experimental and achieving healthy stress coping strategies, there is a great need to stress management activities like gardening to help fostering the psychiatric patient and coping skill. So thank you.
We have 3 minutes for discussion. Judges and participants may now ask their questions to our presenter.
Thank you, Presenter. Now the floor is open for discussion. If there are any queries, you may please ask. Any suggestion, any clarification from the side of participants?
Little bit of, I think you have to work out little bit on, shall I stand? I think you have to little bit work out on your methodology. You have mentioned that it is a mixed method, but it is not depicted in your, as a whole in the presentation. Mixed method means second part, either it should be second, but it is showing percentage and things like that. Understood. Like, what I would like to say, it should not come as a percentage and things like that in qualitative findings, so that you just find out, work out on this. And one more thing, on correlation, I don't know how you have used t-test. It was coming out, so that is what you have done between two means t-test. Then you have put in the, I don't know, maybe you may have to have some correction, so please do that correction. And in objectives also there are a few modification requests. I think if you go through, you will be knowing. So I think you have done it in very hurry, so it must have come like that. So there are some corrections are needed in many areas. Thank you. Otherwise, you have presented well.
Thank you. Anybody else from the group? Otherwise, like good that you have attempted doing a mixed method research. As ma'am rightly pointed out, I think the methodology has to be even more robust when you're doing it. Even I felt the same thing, because there is, I'm not very clear as to exactly when during your data collection process mixing of data has happened. And like which method of mixed method you have chosen here, which type of mixed method you have chosen here? No, like in mixed method, as you can see, we have some types, no? Embedded, concurrent, parallel, exploratory, explanatory, like that, which you have used? Can you just switch on the mic? She's. Yeah.
And reduction of their stress. I only interviewed for that.
We were asking what design you have used. There are a lot of designs under
explanatory, ma'am, only. They can explain how they're doing and how they feel.
So which area, like quantitative you have given importance, qualitative, which one does first, whether it was concurrent, embedded design, that was the question. Anyway, congrats for taking up the study, and you have done something to the patients to reduce stress. We are not overlooking that, it's done. But methodology part, I think more refinement is needed. You might have done, but when you are presenting and writing, it might have not come as the design asks you. Okay. Anything else you want to say? Or we'll
Anybody else?
Anybody else? Any experts? Sir?
This lady is telling like limitation. Yeah. So that will be limitation the last, I think you may be in the delimitation. Again, any reduction size may be calculated as it is an interventional study. Maybe did any reduction size something.
Those are what you have put, those are not your limitations.
I only that is delimitation can only take in this and this.
You have interviewed patients, right? Have you come across with any themes or sub-themes, something, and integrated these quantitative and qualitative?
Some part of questions I have, some part of questions.
You are presenting a part of your study.
Yeah.
You see, part of questions are
Yeah.
qualitative. For qualitative, you need to explore. So
that's why I'm taking a feeling of that. Na? So they only told them ki how they feel. They are feel good, not.
Actually, mixed method is a tedious process, and a lot of steps are there.
Okay.
So, okay, shall we wind up and call next person for the presentation? Since
Now I call our next presenter, Mr. Sanjay Sevak.
Just a second.
Okay.
Yeah, so first of all, very good afternoon to all. Anything you want to tell me? Yeah.
I think she has done well for patients, reduce the patient stress. But in one slide, first one, there was pre-test, post-test mean and standard deviation was same. By mistake, maybe it is there. Slides work is poor. You have to do better. In-depth questioning you have to do for mixed method. For qualitative, it is not there like that.
Thank you, ma'am, for your valuable inputs. And this out of this session, actually. First of all, I thank all of you for being a part of this, and we received around 30 plus scientific papers for this conference. So that is a great interest what the Ispn Indian Society Psychiatric members are having. And my urge to all the participants is take this as a learning platform, because I personally learned from this only, actually. So from 2006, when I was MS student, I presented a paper in Father Muller's. So from that time onwards, our experts in this field, they give, you can do this way, you can do that way, this you can add, this you can remove. So all these are inputs that we may not get it from textbooks. So our learned, experienced experts are here, and take this as a learning curve, so learning point, so that it will help you to improve your way we are conducting research and the way we are presenting our results also. So I request all of you, please take this as a learning platform. It is not about finding fault on anybody's hard work, because doing research is a hard work. And I appreciate all of you for doing this wonderful hard work and doing something and coming here and presenting. And one beauty of ISPN is everybody involved, actually. Even though we say we have only 2 judges here, all the members for effectively contribute. It's not because we want to find something, because we want all of our ISPN members to be confident enough in doing research, and then confident enough in presenting a good results also. So please take this in way as a learning curve. And one more important announcement I would like to make here. We have one award called Young Scientist Sarla Kapoor Award for those who are 40 years, less than 40 years. And last 2 to 3 years, we are not getting enough contestant. So minimum 5 people are required. 5 candidates are required for this award competition. So one criteria is up to 40 years. You should do an independent research work and without any collaboration with other people. So that research report you can submit for the award paper. This year we got only 2 papers only. We are unable to conduct that paper competition. So my humble request to all of you is, please learn from here, conduct independent research, to do one publications, valid publications, and apply it for Young Scientist Award. Then we will able to recognize your hard work in the name of best young scientist in ISPN. So that is one option is there. I like to share here, and thank ma'am for all of your valuable input for our ISPN members. This is the way I like the way ISPN is working. Everybody will be part of the system, not only the judges, not only the EC members. So we want to continue the same thing in future also. And thank you, and please over to you. Thank you.
Thank you, sir. Our next presenter, Mr. Sanjay Sevak, is being requested to come and present. Just to remind you, your presentation time is 7 minutes. Sanjay Sevak, our next presenter, College of Nursing, AIIMS, Jodhpur.
Very good afternoon to all and present here. Myself Sanjay Sevak, I am working in College of Nursing, AIIMS, Jodhpur, and also I am pursuing my PhD from National Consortium IMC. My topic for presentation is effect of nurse-led de-stressful skill intervention on stress, resilience, self-esteem, coping strategy, quality of life among patients with depression disorder. Introduction and background. Depression contributes to the significant disease burden at the national and global level. According to the Global Mortality and Burden of Disease report, depression disorder is predicted to be a second leading cause of global burden of disease by the end of 2030. Worldwide population living with depression disorder is 322 million, which is a 4.4% population. In India, the lifetime prevalence of depression disorder was 5.25%, and the treatment gap for depression disorder, that is a 79.8%, which is already discussed in the previous session also. Betro et al., the review study revealed that the direct cost, which include the hospitalization and drug, and indirect cost is a higher in the depression disorder, and it imposed the societal burden that is a larger than other chronic disorder, such as hypertension, rheumatoid arthritis, asthma, and osteoporosis. WHO also reported that depression can in turn and lead to more stress and dysfunction, affected person life situation, and different psychological treatment formats should be considered for the prevention and treatment of patient with depression disorder. Need of the study and justification. India is the second most populated country. In the recent review, now it is the most populated country in the world. And only 0.3% psychiatrists available for 1 lakh population. India faces the severe shortage of mental health professionals, include the psychologists as well as the psychiatric nurses. Nurses constitute the largest group of healthcare professionals who can care for the mental health care user. Can you go to the methodology? Okay, yes, sir. So, just statement and objective, I'll finish. Statement, effect of nurse-led de-stressful skill intervention on stress, resilience, self-esteem, coping strategy and quality of life among patients with depression disorder. Objective, first to assess the stress, resilience, self-esteem, coping strategy and quality of life among patients with depression disorder. Second, to evaluate the effectiveness of nurse-led de-stressful skill intervention by comparing the post-intervention stress, resilience, coping strategies, self-esteem and quality of life among patients with depression disorder. And last one is to identify the correlation among the outcome variables. Research methodology, first one, research approach, it's a quantitative research approach. Research design is a true experimental pre-test post-test control group design. Setting is a All India Institute of Medical Science, Jodhpur. Population is patient with depression disorder. Sample size, actually it is a 88 total sample size. I am conducting a pilot study finding, so that is a total 20 samples, 10 in each. That is a nurse-led de-stressful skill intervention group, NDSI, and second is a treatment as usual group. Sampling technique, a simple random sampling technique used, and computer randomization is used to randomize the sample, while the SNOWS technique is used for assign the patient in the NDSI as well as a treatment as usual group. Now this is about the brief snapshot about the intervention, where generally I use a total 7 sessions, in which 5 are face-to-face session and 2 are the telephonic intervention. So first, initially patients are randomized through the computer process. They are randomized in 2 groups, that is a NDSI as well as a treatment as usual group. Now NDSI actually 7 sessions which are conducted at the OPD setting, and post-intervention conducted at the first baseline and at the 4th week as well as the 8th week and 12th week. Now these are the inclusion criteria. Patient with depression diagnosed by the treating psychiatrist according to ICD criteria of any subtype. Patient age between 18 to 65 years. Patient with psychotropic medication for their clinical treatment. Patient who speak Hindi or English. Patient who have their own mobile connection for telephonic intervention, and participant available during the data collection period. There is a certain exclusion criteria also, that patient is having a severe depression where the depression score is more than 25. Patient have active suicidal ideation or active psychosis. Patient with other neurological conditions, and patient have other comorbidities like cancer, CCF, kidney disease, HIV and diabetes. Now research tools, so generally first demographical data, detail we'll discuss when we'll discuss about the analysis. So demographical data and also a clinical profile of the patient. There is a 5 standardized tool is also used. First, for assess the stress, there is a perceived stress is used, which have a 10 item and score range between the 0 to 40. Higher score indicate the higher stress level. Second is a brief resilience score scale, which have a 6 items, score range between 6 to 30, and high score indicate the high resilience. Third is a Rosenberg self-esteem scale, which have a 10 items, range between 0 to 30, and high score indicate the high self-esteem. Then brief COPE scale is used, which have a total 28 item, and last one is a quality of life scale is also used, which have a 14 item, score range between 14 to 70, where the high score indicate the high quality of life.
You have 2 minutes left.
Yes, ma'am. Okay, so ethical consideration, the permission is taken from AIIMS Jodhpur as well as a studies also registered in a CTRI. Now about the intervention, generally about the age, mean age for the NDSI group is 31, while in treatment as usual is a 46. Gender, generally in a male, 70% participant are belong to the male gender, while the 60% participant belong to the male in a gender section. Generally in the demographical profile as well as the clinical profile, there is no significant difference. Both are homogeneous, except age of the patient and age of the onset of depression, remaining all are a generally homogeneous group. Now second, about the pre-intervention comparison of outcome variables. So in the nurse-led de-stressful skill intervention as well as the treatment as usual, both group have a generally homogeneous, means there is no significant difference in the both group, which you can observe that P score is a less than 0.05 level of significance. It's a more than 0.05 level of significance. last about the intervention. So we can observe that in the time effect, the stress level, resilience, quality of life and self-esteem, we observe that there is an increase in mean score, and also p-value indicate that there is a significant difference, means the generally intervention group, which is NDSI, which have a higher value, which indicate that there is a significant difference in the both group. And last one about the correlation. So in correlation indicate that stress have a positive negative correlation with the resilience, self-esteem and quality of life. So when stress level is increase, actually resilience, self-esteem and quality of life is decrease, while stress have a positive correlation with the depression. So when stress level is increased, depression level is also increased. For resilience, they have a positive correlation with the self-esteem and quality of life. So when this one is increased, resilience, self-esteem and quality of life is also increased.
Time
but
up.
It have a negative correlation with the depression severity. Similar with the self-esteem and quality of life. Conclusion, the study finding collectively highlight the NDCI effectiveness in the fostering positive changes on stress reduction, resilience building and enhanced self-esteem. Moreover, this intervention are simple, safe and cost-effective and can be used in any outpatient setting. The study will be help the professional to blend the nurse-led stress, de-stressful skill intervention with the standard care for patient with depression and other mental health disorder for better outcome, and also plan and implement the independent nurse-led de-stressful skill intervention in a clinical setting in India. Thank you.
Thank you, Sanjay, for your good presentation, I think, which you have made. This is a part of your PhD work,
Yes,
is
sir.
it?
It's part.
Okay, like you have collected data in inpatient department or outpatient department?
Sir, it's outpatient department, and session are conducted, actually all the patient are coming generally 3 weeks to 4 weeks. So generally every 4 weeks when patient will come, it is a session are organized like that. When patient come for the first time, 2 sessions are taken, then 1 telephonic intervention, again next visit there is a 2 sessions are taken, then telephonic intervention, and last when patient will come, that is a post assessment is conducted. So it's a outpatient setting it is conducted, sir.
So both the groups are from the outpatient department?
Yes, sir, both are from outpatient department.
Like how did you try to avoid data, contamination?
Sir, we have a separate cabins actually. In psychiatry setting, we have a separate cabin. So whenever we collect the data, we call the patient and collect that in that separate cabin. So they generally, patient are not mingled generally.
Okay, and I think the scales, I think you had 5 scales, right?
Yes, sir.
Except COPE, I think all the other scales you have expressed in the form of categorical, the inferences were done categorically,
Yes,
like
sir,
high,
yes, sir.
low, like that.
Yes, sir.
But I think when you express the data, the results, it were all computed as mean and standard deviation.
Sir, so they have a
So
total
you've
scoring.
done-
Yes, sir, it's all on the ratio scale.
So you have not done anything categorically?
No,
Only
no,
you
no,
have
sir,
taken
it's
as
on
a
a
continuous
ratio
mean.
scale. So we can compare the mean score, sir.
Okay. Is there any challenge which you have faced during data collection? Because collecting data, giving intervention in the OPD is
Yes,
bit
sir.
difficult.
Sir,
Like
sir,
even I have few
certain issue
experiences
like in
that.
pilot study, so I can certain modification also. First one is that generally patient are discontinued. Initially I taken as a 10% dropout, but when I conduct pilot study, I increase the 20% because majority patient are discontinued after the 2 visit, and I require minimum 4 visits.
Okay.
Sir, second is what happens, sometime even the patient are not responding when I have a telephonic intervention. So now I make mandatory that patient, those who have their own cell phone, then only I will take in the study. As in inclusion criteria, it's a mandatory. Previously, even the family member also can carry on if they have a cell phone, so I can talk with the patient. And third also, I will develop the good IPR, because previously what happened, initial sample, just I take a brief history and I leave them. So generally there is a problem later on that they are not follow up or come for that one. So generally initially I will focus that they will interested in the participate in the study, then only I will recruit it in the study.
Okay. I think somewhere you mentioned that your sample size is 88 for the
Sir,
main
88.
study.
Yes, sir.
But pilot study you have taken 20.
20, yes, sir.
Like how did you arrive at the sample size? What kind of formula you used?
Sir,
for
I am using a power analysis for main study.
For main study.
Sir, main study there is a OpenEP software are there. So according to that I calculated.
So that you have done it.
Yes, sir.
Okay.
You have used all standardized tool
Yes,
for your
ma'am.
data collection.
Yes, ma'am.
Have you taken permission?
Yes,
or
ma'am,
it
I
was,
taken for all 5 permission.
Okay, you have got it. free
Yes,
of
yes, I got
cost.
permission, sir.
Now the floor is open for discussion. Any of the participants who are willing to ask questions or queries, you have somebody. Somebody.
I want to ask you how you motivated patient to come. After session, you have to Okay, you have to take 7 times you want.
Yes, ma'am.
How you motivated them? Any things you have given or something I want
Yes,
to?
ma'am. Actually, previously I generally intervention this one at the trial basis. So I identified that minimum patient will come 2 to 3 times only. Then majority patient around 50% are discontinue. So we have actually telephonic booster for them. We will call. We will take a follow up in between. Whether suppose if the patient have next week reminder, so again I have to call them and I have to say that you have to come next week. If you have any issue, then I will even, we have a OPD, means they have appointment also. So I will talk with the psychiatrist, and suppose if they have issue on Monday, so even we can arrange patient for Tuesday also. But still there is a 20% drop off is there, because in Rajasthan there is a single AIMS is there. If the patient are coming from very far area, suppose Bikaner and etc., that time we are really feeling a certain issue are there. But still, initially when we recruited, we said that these much session are there, and generally we take 3 times only. We'll take a 2 session on 1 visit and 2 telephonic intervention.
Okay, only communication is the mode.
Hi.
Means no benefits you have to provide it for the patient, for that patient can.
Sorry ma'am, please repeat.
So, incentives
No,
or something.
ma'am, actually.
Not incentive, means some benefits like that.
Yes ma'am, actually we are giving intervention is one kind of benefit, and also we can give a printout for the health education and etc. Even those who patient are coming for the study, suppose they have a issue in the appointment etc. Because in AIMS Jodhpur majority of treatment, majority if they are come under the particular scheme, it is a free of cost, but main issue they are not getting appointment. So suppose second time, third time they will not come, so they have actually healthcare professional numbers, so they can.
Common
Yes, ma'am.
people na,
Yes, ma'am.
they need something, that's why I am asking.
Yeah, maybe ma'am.
Means your handouts or leaflet, it is not, means it is, we know it is
Yes,
very means costly things, but for patient I want.
Yes,
Okay,
but
it's okay.
as a this one policy, we are not providing something money or something.
No,
Direct
not
benefit
not
we are not
money.
taking, but indirect in terms of whenever patient require any
Not-
additional help, such type of
Patient
facility are
requirement something.
Yes,
Can
ma'am.
we move not next monetary.
Thank you, sir.
Thank you.
Thank you for giving us opportunity.
I'm calling our next presenter, Dr. Aarti, Assistant Professor, Amity University, Gurugram, Haryana. Best of luck, madam.
Good afternoon to one and all present here, and thank you for giving me this opportunity to present my scientific paper presentation in ISBN. So I'm starting with the presentation. The title of my study is A Study to Assess the Effect of Psychoeducational Approach on Digital Game Addiction, Behavioral Problems, and Social Anxiety among Adolescents at Selected Schools of Haryana. Gaming disorder, often referred to as online pathological gambling, and which is characterized by problematic compulsive video game play that is over time considerably reduces the capacity of a person to carry out many life tasks. So this and related concepts have attracted the interest from the entertainment, medical, and scientific field, and are the focus of much investigation, discussion, and debate among the professionals from a wide range of fields. These diseases may be recognized when somebody prioritizing the playing video games above other activities or engaging themselves without thinking about the repercussions. The ICD-11 also states that the lack of self-control when playing video games is the only need for this condition. Objectives of the study is, the first one is to assess the level of digital game addiction among adolescents. The second one is to assess the prevalence of behavioral problems among adolescents. The third is assess the level of social anxiety among adolescents. So these 3 things I have taken. Fourth objective is to determine the effectiveness of psychoeducational approach on digital game addiction, to determine the effectiveness of my psychoeducational approach on behavioral problem, and the last one is to determine, to find out the association of pre-interventional level of game addiction and behavioral problems with selected socio-demographic variables of the adolescents. These are the hypotheses which I have formulated for my study. Coming on to the research methodology, research design was the pre-experimental, one group pre-test, post-test design I have taken. The research settings was the selected government senior secondary schools from the various selected areas of state Haryana. Target population was adolescents of selected schools. Accessible populations was the adolescents who were available at the time of data collection, both pre and post test. Sample was again the adolescents from the selected government senior secondary schools. And sampling technique was the non-probability convenient sampling technique. Sample size I have taken 200 adolescents. Tools for my study was socio-demographic variables, which I have taken exclusively after the empirical review of literature. Second is the standardized tool by Ahmed Kasigi for the digital game addiction. Second was the behavioral problem, and third was the social anxiety scale. Method of data collection which I have taken is pre-test for all the 200 adolescents. Then I had given my intervention, that is psychoeducational approach, and then I have taken post-test for all the adolescents. Then I have taken for the data analysis and interpretation, both descriptive and inferential statistics. Coming on to the analysis and presentation, section 1 comprises of the description of the sample characteristics of adolescents according to the age, according to the gender, or the other things which I have taken after ROL. Section 2 consists of the findings which is related to the level of digital game usage. Section 3 consists of the findings which is related to the prevalence of behavioral problems, and section 4 consisting of the level of social anxiety among adolescents. Section 5 related to the findings which is related to the effectiveness of educational approach on digital game addiction. Section 6 consists of the effectiveness of educational approach on behavioral problems, and section 7 consists of the association of pre-interventional level of game addiction with selected socio-demographic variables, and the last one is findings related to the association of pre-interventional level of behavioral problems related to behavioral problems with selected socio-demographic variables. So this is the section 1 which is depicting the sample characteristics according to the number of age, the classes in which they are studying, the type of family they belongs to, their father's education, mother's education, father's occupation, mother's occupation, time spent into the outdoor activities, time spent on mobile or internet. So these are the graphical presentation of my gender, this age, class of study, type of family, father's education. So this is all the graphical presentation which I have put onto this slide. Section 2 consisting of the findings which is related to the level of digital game addiction, both in the pre-test and post-test I was trying to depict on the same slide. So into the pre-test, low level of digital game addiction, average level of digital, and high level of digital game addiction. The frequency into the pre-test was 10, 41 and 49 respectively, and into the post-test it is getting changed, that is 43.5% of the adolescents were coming to the low level of digital game addiction, rest 45 and 11.5%, along with mean in pre-test was 70.61 and 58.86 in post-test, along with the standard deviation 13.15 and 10.66.
Ma'am, you have 2 minutes left.
Okay. Section 3 is the prevalence of behavioral problems, both in the pre-test and post-test. It is clearly showing that into the pre-test, the maximum of the adolescents, that is 72, 144 adolescents were having high level of behavioral problems. And into the post-test, after this psychoeducational approach, it is getting reduced. So the number has came to the low class, that is 63.5%. Section 3 related to social anxiety in pre-test and post-test, as it is showing maximum, that is 123 number of adolescents were coming to the severe social anxiety, and after this intervention, the number is getting in the upper class, that is 77.5% were coming into the mild social anxiety. Now, section 5 consisting of the educational approach, findings related to effectiveness with digital game addiction, along with mean and standard deviation and t-value. The same thing I have taken for this behavioral problem also for educational approach. Graphical representation, I am just skipping it out, and the effectiveness also correlation. So this slide we can say that all the socio-demographic variables which I have taken for my study was highly significant. It is directly or indirectly contributing to the digital game addictions, behavioral problems, and social anxiety among the adolescents. Analysis and findings demonstrate the level of digital game addiction, the frequency of behavioral issues, the degree of social anxiety among these adolescents, and the usefulness of a psychoeducational approach in treating the adolescents' addiction to video games. So the result further depicts that all the variables is associated with the digital game addiction level as well as the behavioral problems in adolescents. So to conclude my study, according to the extensive prior research, interest gaming disorder has become a very serious
Your time is
social
up.
issues. For just the depiction, recommendations, and certain future scope. Thank you so much.
Okay, now the floor is open for discussion. If any of the participants are having some queries, we can clarify it. Any suggestions from the group?
I want to put one suggestion in your tables. Kindly put all the N's. N in many table N are missing.
Okay.
And
Okay.
one more thing in your chi-square, I don't know whether you have clubbed or what, but whatever you have shown in depiction, it is coming all many places 0 cells are there. Have you noticed that?
Was
0, 2, like that. I don't know. Yeah,
It's
it is
editing
there.
issues, ma'am. It is typing and editing issues.
I don't know.
Yes, this is 0 you are talking. No, this is editing issues only, ma'am. So
no,
sorry.
No, not that 0. That chi-square cells, na? Their zeros are there. So I don't know whether you have done the corrections or you have clubbed it. You should.
Okay, okay, right, ma'am, right. Getting your point, ma'am.
Statistics, you get it done correct.
Okay.
Anybody else from the group? Okay. If no one is like, I just have a small query. Like,
Yes, sir.
How many schools? I mean, like, how did you choose the school for your study? Like,
Schools
you
I
said
have
that
chosen. Schools I have chosen as per the conveniency of me. Actually, Haryana state I have taken. So 4 districts I have taken. The schools, 4 schools I have taken. 1 I have taken for my pilot study, and 3 schools I have taken for my main study.
Okay, from the 3 schools, you have taken all 200 samples.
200 samples.
How did you divide this?
11 to 19 years I have taken, sir, for the adolescents.
No, my question is like in each school, how many samples you have taken? I mean, how many participants were there? And how did you decide about it?
So I have ensured the participants who will be available for my pre-test, who will be available for my...
See, my question is, like you said that 3 schools you have taken for your main data collection,
sir,
isn't
yes,
it?
sir.
And your sample size is 200.
Yes, sir.
My question is, like, how did you divide this 200 or how did you arrive at this 200 from these 3 schools?
Yes, actually, sir, the time when I was starting doing my data collection, the 10th and 11th standard students were on leaves, like exam leaves. So I was ensuring that at the time of my pre-test, at the time of my psychoeducational approach and post-test, those students who are giving consent, yes, madam, we will be available, then randomly I have taken. 243 samples, sir, I have taken in the starting, and 243, among 243, 43 I have just excluded out because they were not present at the interventional level. Some of them were absent. Post-test level also at the time that some of the students were absent. So I was in mind that 200 I have taken, but 243 samples I have taken altogether. But ultimately 200 I have taken for my main analysis, those who were present in all the stages.
Yeah.
Yes, ma'am.
Children were there?
No, it was more also.
That's what he's asking. How you arrived at a conclusion that you will be taking
Those who
200?
have given consent from 9th, 10th and 11th standard, those who have given consent for my study, I have taken, sir.
See, you should be very clear about your sample size well before your data collection begins. First question. Second
Yes,
question
sir.
is like I'm asking something about this multi-stage sampling which we do like when we go for schools like strata like that. Okay, that you're not much clear about it. My question is about it. Like how did you arrive at these 3 schools, and among these 3 schools, like have you taken one particular school, or is that like you've taken data from all the 3 schools?
No, sir, that's what I'm telling. As per the my convenience
Okay.
level, the place which I belongs to, that is one my Mica place, then my Sasural's place. Like, so I have approached many schools basically, but taking permission from the government school is generally not easy a process. I was not in a mind that 3 schools only I have taken. I have applied permission for taking higher schools, but only 3 I have gotten. 9th, 10th and 11th standard students I have decided that yes, these 3 classes I have taken.
Okay, fine. Is there anything else?
Okay, you have assessed a digital game addiction.
Yes, ma'am.
Which tool you have used, and is it a standardized tool or you
Yes,
have
ma'am. It is
developed?
standardized tool for digital game addiction, which is formulated by Ahmed Kasiki, sir.
So if you want to say that a student is addicted to game,
Yes.
What was your major criteria mentioned in that tool? How many hours or?
This I have taken from the socio-demographic variables, ma'am.
No, I'm asking about the tool. What was the main?
Tool comprises of 30 questions, 30 items, which include all the things related to their digital game addiction, like what type of platform they are using, the time they are using, and self-avoidance, the avoidance, absenteeisms from the school, how frequent they are getting absent from the school. So these are the things which is listed into the items of this scale, ma'am.
And
Yes.
you have told that people consented only you have taken for the study.
Yes, ma'am. Yes.
So why don't you think to make them in different strata, 9, 11, and all cluster or something? Why it was not there in your mind when you have selected? So
I could do this time, next time, ma'am.
When you are doing a study, when it is coming to the statistics,
yes, ma'am.
It should support your study, right?
Okay.
It should be supporting your study than criticizing your study, right? So you yourself have to come to the conclusion how you will select the sample or how you will categorize them. Different techniques were there, right?
Right.
So that was our question.
I'll take care, ma'am. I'll take care.
Okay.
Actually, ma'am, getting the samples data from the adolescents, the first thing they are little stubborn and related to digital game addiction and mobile phone they are using. मैडम क्या करने वाली हैं हमारे साथ, हमारा फ़ोन का कम बंद कर देंगी टाइम, मम्मा को कुछ बताएंगी, कुछ नोट, मतलब they were having that attitude or the perception related to that digital game addiction or phone uses. So to tell them, to make them understand that yes, this is my only research study, I'm not gonna do anything related to your phone or the timings which you are spending on the time. So that is also an issue which I have faced with these adolescents peoples, ma'am.
So you are.
Yes, ma'am. That's what I'm telling you. That's what जो जिसने informed consent which they have given, that samples only I have taken, ma'am.
Yes. Students were adolescents were which group? Which group?
11 to 18 I have taken for my sample groups, but when I have gone for the permission, all the principals were told, yes, this is the time that my 10th and 11th classes are going for the leaves for the exams.
Sometimes when we are taking permission from the principals, parents can protest. Parents can protest. So we have to take permission from parents. Parents important, then teacher or institution authority. It's otherwise informed consent.
New thing, ma'am. New thing for me.
So be careful when you have done study with a good intention. And see that loopholes are closed, otherwise it will stand against us.
Okay.
That's the problem.
Okay.
Okay, good.
मतलब whatever the study we are doing for the adolescents, we need to take consent from the parents as well. It's just, okay. It's a new thing for me. Thank you.
Then please read the ICMR guidelines
Right,
on
sir.
how to manage the ethical issues whenever we take up a study. They have given a very clear picture as to what kind of consent and what is assent, what is consent, everything they're very clearly given, risks, benefit, and whatever.
I'll go through, sir. Thank you. Okay. Right. Thank you. Thank you. Grateful, sir. Thank you so much.
Hello. I think proportionate sample size can be selected for selecting sample in different places. You have chosen 3 schools, no ma'am. So it is better to take a proportionate sample size.
Okay.
That is a good idea.
Okay.
Ma'am.
That sir have already
If you are-
given me this suggestion. Yes, I'll
yes.
take care, ma'am.
Okay.
Thank you. Thank you so much.
Our next presenter, Ms. Srijamol MG, Professor, Sri Narayana College of Nursing, Kochi. Madam, please come on stage.
Good afternoon to all. My study is impact of family-based intervention on quality of life of caregivers of patients with schizophrenia. It's a pilot study of my PhD, and I'm doing PhD in Amrita Vishwavidyapitham University. And my guide is Dr. Bindu Menon. Co-guides are Dr. Praveen Arathil, Dr. Arun K, Dr. Danya Chandran, Dr. Deepthi PT, Dr. Anup Vincent. And schizophrenia is a chronic and severe mental disorder affecting more than 21 million people worldwide. Schizophrenia is characterized by distortions in thinking, perception, emotions, language, sense of self and behavior. Treatment with medicine, psychosocial support, facilitation of assisted living, supported housing and supported employment are effective management strategies for people with schizophrenia. There is a beneficial role for educational intervention in reducing relapses and improving treatment adherence in schizophrenia. My study objectives, it is a multi-phase study, and phase 1 is preparation and standardization of family-based intervention and knowledge questionnaire. Primary objective of phase 1 is to prepare and standardize the family-based intervention and knowledge questionnaire for the caregivers of patients with schizophrenia. Study objectives of phase 2. Phase 2 is the assessment of impact of family-based intervention on quality of life of caregivers of patients with schizophrenia. And the objective is to evaluate the effectiveness of family-based intervention on knowledge by using knowledge questionnaire. Find the association between quality of life of caregivers of patients with schizophrenia and their selected demographic variables and clinical variables of the patients. Identify the difference of psychopathology of the control and experimental group by using PAN-SS scores. Definition of terms, impact, it refers to the outcome of family-based intervention on quality of life among the caregivers of patients with schizophrenia. Family-based intervention, it refers to an organized...
Ma'am, kindly go to the methodology as per the evaluator. Methodology side.
Okay. Research methodology. Research approach is quantitative research approach, and the design is a randomized controlled trial. It is a non-pharmacological study. Clinical trial. Research setting is selected psychiatric units Kochi. Population, target population is caregivers of patients diagnosed with schizophrenia. Accessible population, caregivers of patients diagnosed with schizophrenia. Attending in 3 hospitals Kochi. Sample and sampling technique. Sampling technique is random sampling by using random allocation table. And for this pilot study, I have selected 20 subjects, that is 10 control and 10 experimental from 3 different hospitals. And from one hospital I have taken Hospital A, that is 8, that is 4 plus 4, and Hospital B, 3 plus 3, and Hospital C, that is 3 plus 3, that is proportionate sample size was used for the calculation of this sample. Then sample selection criteria, inclusion criteria, caregivers of patients who met ICD criteria for schizophrenia and with illness duration of at least 6 months, both gender. Caregivers of patients between 18 to 60 years and had been taking care of the patient at least for last 6 months. Caregivers of patients with schizophrenia who are reportedly stable emotionally and intellectually and will be screened by using mini international neuropsychiatric interview screen. There should be the primary caregivers of patients and able to give informed consent. And exclusion criteria, caregivers with a psychiatric illness, mental retardation, physical disability, drug dependence, and comorbid psychiatric disorder which might interfere with the care of patients. Second one, caregivers of patients with schizophrenia who are health professionals. Tools for data collection, first one is ICD diagnostic criteria for research for diagnosis of schizophrenia. Then tool 2, and usually my guides were helping me for the using these tools, because as a nurse I cannot use certain tools. Mini international neuropsychiatric interview, that was used with the help of psychiatrists, and they have trained me to use the mini international neuropsychiatric interview. Then tool 3, that is mini international neuropsychiatric interview for using this for screening the caregivers. Then tool 3, positive and negative syndrome scale. Here also I have got training from the psychiatrist. After that I alone doing that positive and negative syndrome scale. Then tool 4 is demographic perform of the caregiver and the clinical details of the patient. That is prepared by the researcher. Then tool 5 is adult care quality of life questionnaire. That is a questionnaire, self-reported questionnaire for the caregivers of patients with schizophrenia. That's that score is from 0 to 120, and the higher scores indicate greater quality of life. Tool 6 is knowledge questionnaire for the caregivers of family-based intervention, and the tool content validity and reliability and was done. And the third step of standardization publication I have sent for the standardization. Then ethical consideration, ethical permission was
you have 2 minutes left.
Received from 2 institutions, and CTRI registration also done. Statistical analysis were done by using payer t-test, chi-square test, and student t-test, and the quality of life scores of patients shows there is an increase, that is the mean percentage is 48.5 in pre-test among the experimental group, and among the control group that was 44. There is a comparison, we can see 74 among the experimental group post-test score, and the post-test score of control group is 46.6. And the knowledge score here 12.7 is the mean of pre-test experiment among experimental group and the control group, that is 12.3, and there is an increase in mean of post-test scores, that is 24.3 to 24.3 among the post-test scores of experimental group, and among the control group that is 13.2 only. And the psychopathology also, there is some, there is not much significant in psychopathology. And the t-value and p-value, t-value in among the, t-value of experimental group, that is 8.908, that is significant. And among the two groups, that is 7.66, that is significant. Major findings of the study, study findings reveal that there is a statistically significant improvement in the knowledge scores and quality of life of experimental group only, and no statistical significant association was obtained between the demographic and clinical variables because I took only small sample. Thank you.
Thank you for your presentation, ma'am.
Thank you.
I just have a small clarification. You said that your sampling technique is random sampling technique.
Yes, sir.
Can you just explain to me about it? Like, what exactly? Is it like you have written about the sampling technique, or you are talking about the random allocation of subjects to each of
Random allocation of subjects also is there. Random sampling technique also I have used, sir. Actually, I have selected 3 hospitals, and for the 3 hospitals, conveniently I have selected that 3 hospitals. After that, actually I need to take 82 samples, 82 subjects for my main study, and for the pilot study I selected only 20. That is 10 from control and 10 from the experimental group. And from each hospital I have selected proportionate sample size by using proportionate sample size, sir. That is
okay, like allocation concealment, how did you take care of it? Actually, you have done it, or like, or the statistician has said?
Statistician has given one table, sir. Based on that table only, I have selected the subjects.
So that is how it has been taken care
yes,
of?
Sir.
Okay.
You were also telling about RCT.
Yeah, RCT she
Also, I think allocation also, I believe.
Allocation concealment.
Allocation also you have done, I think. You told RCT.
Yes, sir. Yes.
Whatever you have explained
there
now.
is no concealment. Allocation concealment I couldn't done because I need to interact with the patients and caregivers.
That is fine, but how you have allocated?
By using that random table, madam. Random table for each hospital she made, that statistician made one random table, and based on that random table, for example, I have taken 8 subjects from this one hospital A. That is from Amrita Institute of Medical Sciences. For that hospital, she has given one random table that is for 8 subjects.
That is for random sampling. There is difference between random sampling and randomization, especially when we do RCTs. I'm talking about, like, how did you do the randomization? Like, how did you allot this 20 as to 10 into experimental and 10 into control?
Yes, sir. Yeah, for that also she made, sir. That is, I have taken 8 subjects from one hospital.
Okay.
That time, she made 8 subjects, group A, group B, like that she mentioned.
Okay.
Group A means wherever she put A, as per my random table, 1 and 2 for control group, and 3 and 4 for group A. That is for 8 subjects she made like that. Okay. And for 3, no, sir. For one hospital I took 6, and one hospital I took 6. 6 plus 6, 12, plus 8 one hospital. And for each hospital she made small this type of table.
Okay, that's fine.
That only I used.
And one more thing, Panasis, why did you use? You were taking the caregivers, nothing to do with the patient, na? Schizophrenia
Patient, I just assess the this one, madam, psychopathology, but there is no significance in that. But anyway, doctors asked me to do that. But
no, doctors ask you to do, you should not.
But no,
You should
madam,
have
just
some
for is there
justification.
any difference like that they asked? But that is not influencing that psychopathology, madam. Because I am not giving any intervention for the patients directly. I am giving intervention only for the bystanders. That is primary caregiver.
For the caregiver, no, that's what here in your presentation, there nowhere it is reflected
Yeah.
why you have used this Panasis. the needs of PNSS was not reflected in your
Yeah, madam.
presentation.
Yeah.
So I think you should be little careful to make justification
Ah,
of
okay,
using
madam.
the particular tool.
I just for the, here I told, but there is no significance. I'm not giving intervention directly to patients, madam.
Okay, so I have another question. Why do you have 5 co-gates for your study?
Madam, as per Amrita Vishwavidyapitham University criteria, we need to have these many co-gates.
5 co-gates for a
Co-gates,
study.
two international co-gate. Actually, one international co-gate is must, but I am having 2. Like that, their criteria, madam.
You have done parametric tests for your statistics, right? You have 10 sample in one group.
Yeah, madam.
Why don't you think about any non-parametric technique or something? Was your sample normally distributed?
Yeah, madam. That is not only this much sample, no, madam. That is why I couldn't done that.
Actually, when sample
I
is
have
less-
tried, but this much sample only. That's why.
No, you should not. There is alternative.
Yes, madam.
You have options like, you know, if your sample size is small, it is not must that you have
Yeah.
to use parametric. You can use non-parametric.
Non-parametric Man Whitney also.
Yes, Man
I
Whitney.
asked them
Also
to do Man Whitney.
Okay, that was more because when you are doing major study,
Yeah. Madam, for
result
main
may
study, I am
change.
doing Man Whitney.
Result
I
may
have-
change because very less
Yeah.
number of sample
Okay,
and
ma'am.
see that normally it is distributed. Now the floor is open for discussion. Any of
You should not decide for main study I'll do Man Whitney or things like that. It will
Yes.
depend on your sample
Oh,
distribution.
okay.
After- after you collect, you
Normality
dis-
test. After normality test, if
after that you
that is
decide.
the sample is
Yes.
distribution is not normal, means I will use Man Whitney. Okay, madam.
and are you sure that for the final study you will get all the samples? You should have a
No,
sample.
madam, I have faced some problem
no.
while selecting the
No,
sample.
sample frame should be there to take sample as random sample.
Yeah,
right?
madam. Yes,
Are you
yes.
sure that you will be getting all samples together?
No, I am not
You
getting.
should have
madam.
their list. No? You can't
Ah,
take
yeah.
convenient for RCT.
Okay,
That is
madam.
my
Okay,
question.
madam.
It's not in a school or institution
Yeah.
where you are sure of this. These
Yeah,
many
madam.
will be there. That's what I'm asking.
And one more thing, madam. After pilot study, I identified one important problem that these caregivers, primary caregivers, actually I am giving 6 sessions of group therapy and followed by this teaching session. And they are asking me to do online sessions also because they are not ready to sit for a long time.
And you have mentioned in your study exclusion criteria, the caregiver should be free from any of the physical illness.
Yes,
Are you
madam.
screening them?
Yes, madam.
Including hypertension, diabetes, all physical illness?
No, madam,
Excluding-
not that. If that is interfering the care, that only. That I have mentioned.
Anybody
You
else?
have, I was just going to ask that you have only assessed the knowledge part, that's it.
Madam,
In this
Madam,
paper.
Once more, madam.
I said you have only assessed the knowledge as per your tables
Knowledge and quality of life also I have assessed, madam.
for the caregivers.
Yes, madam. Quality of life, knowledge and psychopathology of the patient I have assessed.
Did you show us the analysis?
Yes, madam.
Psychopathology का analysis किधर दिखाया? I didn't get that.
Knowledge,
Knowledge
psychopathology, quality of life.
So knowledge regarding the care you have
Can you
assessed.
please show the slide?
Can
Yes,
you go
quality
back
of
to
life
the
is there.
quality of life you have assessed on based on which scale?
Adult care quality of life questionnaire that is specifically for schizophrenic patients. Adult care quality of life questionnaire for schizophrenic patients caregivers.
Caregivers.
Yes, madam.
So what was the criteria of the caregivers you've taken?
18 to 1 minute, madam.
No, not only the age, anything else. Can you go back to your
Yeah, I will
criteria?
show. Madam, caregivers of patients who met ICD criteria for schizophrenia, that patient should be diagnosed as schizophrenia. Purely schizophrenic patients caregivers, then that primary caregiver should be there with the patient and there should be between the age group of 18 to 60 years. And they will be screened by using mini international neuropsychiatric interview.
Okay. So the length of the stay of the caregiver with the patient should have been at least 6 months. Only then you took their...
This mini international neuropsychiatric interview is using for screening the psychiatric patients' caregivers. That is for assessing the caregivers whether they have any illness.
Okay, fine.
Okay, ma'am. Thank you.
Okay, thank you. I think we'll move
I
on to
guess
the-
another question.
Question, yeah, ICD 10 or 11, please mention that.
Yes, madam.
ICD criteria you have written, na? It is ICD 10 or 11, you
Yes,
please
madam,
mention.
it is ICD 10 because my study was started during that time. My presentation was CTRI registration, everything
Okay,
was done.
please
during-
mention that. Please mention.
Yes, mentioned ICD 10 criteria.
No, not 10, it is not written.
ICD 10 criteria only. I am following ICD 10 criteria.
Okay.
Okay.
So mini you can use for anyone because of that is used for National Mental Health Survey. 2016 they used. Which today I used in my PG study when I was pursuing in
Sir, latest one. Sir, latest one we can't use.
No, no.
Latest version.
I got agreement with author, mini 7 I utilized. When my PG thesis was done with mini only. So I got agreement with author, that is David Segan. Who is
okay,
the
ma'am.
author? David Segan. I did with, made agreement with this man. Then I utilized. Even I got a query from IEC, we cleared. That questionnaire front page itself, it was given.
Yes, yes.
That will be administered within 15 to 20 minutes. Anyone can administer after
Ah.
the training.
Okay,
Because
sir.
which tool? It was
Sir-
submitted and
sir-
again it was utilized in National Mental Health Survey also. There is no need for only the doctors to assess with only the mini.
And no, sir. I
Okay.
got anyway. I have given the training by the
As a psychiatric
doctors.
person, anyone he can use.
Okay, sir. Thank you, sir.
Okay, thank you. I think we'll move on to the next presentation.
Thank you, sir.
Dr. Maya Sahu from AIMS Deoghar will be presenting now her scientific paper. A very good afternoon to all of you. So today I am going to present our work, that is non-pharmacological intervention for depression and anxiety in children and adolescents, a systematic review and meta-analysis of randomized controlled trials. So here is the outline of my presentation. In today's world, so anxiety and depression has been a growing concern for the adolescent and childhood also. So earlier it was considered to be the adult afflictions, but now it has put into consideration for the younger generation. So you can understand that these challenges, suppose digital age, social pressure, academic expectations and interpersonal relationship, so these affects them, and sometimes they are also understand that depression and anxiety comes to them. So the literature review has been found that pharmacological intervention, whatever are used for this diagnosis, has varied side effect and benefits only for the short term period. So the aims of our systematic review was to evaluate the effectiveness of non-pharmacological interventions on depression and anxiety among the children and adolescents compared with the control group. So according to the PRISMA guidelines, so this review was registered with Prospero 2023 and the registration number is this, and also the registered protocol is available here. So initially, after identifying the need and objectives of the study, the inclusion and exclusion criteria were identified, and based on that, different search strategies were used and various databases were also used for identifying the articles. And once the articles were identified, those are checked for clarity and content. So the inclusion criteria were that the studies, those have only RCT method as their research design, both for prevention and treatment part of anxiety and depression, either singly focused or combined, also targeted for the children and adolescent. And last 15 years we have taken into consideration, that is 2009 to 2023 till May month when we started the data analysis, and obviously published online and available in English language.
We have excluded the studies which were directly related with COVID-19 or suicide-related depression to prevent the heterogeneity, and also the interventions which were targeted the parents or maybe through internet or web-based. So particularly we focused on the face-to-face intervention. So the literature was obtained from PubMed, PsycInfo, Ovid, ProQuest, EBSCOhost and Cochrane. And these were the keywords that we have used. The terminology is related to non-pharmacological intervention. It could have been psychological or psychosocial intervention also, depression and anxiety, and among the children and adolescent. And randomized control trial or clinical control trial was used, and these were used with the Boolean operators and or not. And additional search was also done through Google and Google Scholar Advanced. Data extraction was done by the researcher, and these were tabulated with, this was the table. Okay, so generally the table includes 15 studies, and these details were further analyzed, and it has particularly the headings were that study design, country, number of participants, sample size estimation, mean and SD of the age, gender, intervention and control group, whatever they have received, and then outcome measurement. So this is my Prisma flow diagram that initially we have started with 3680 articles, and after screening and all the procedure, we concluded 15 studies. So this risk of bias assessment was done using the Cochrane review criteria list under these 6 domains, that is allocation concealment, random sequence generation, blinding of participants and blinding of personnel, blinding of outcome assessment and selective reporting. So this is the risk of bias assessment graph. Here you can see that most of the studies which are having this green colored, so those were lower risk, the red is higher risk, whereas the yellow color shows that unclear risk based on those areas evidence. And this is another bias of summary graph, so it shows that almost all the domains there were lower risk except the allocation concealment and blinding of participant and personnel. So in most of the studies either the data was not mentioned or they have not done. So the data analysis was done using Cochrane Rebman software, and heterogeneity test was used by Ispn statistical approach. Whenever there was p-value less than 0.05 and I-square was higher
You
than
have
50,
2 minutes left.
50%, so there was random effect model used, and SMD, that is standardized mean difference, was used for identifying the difference. So just to tell you brief that total study sample size was 8,000 and then 6,800, and out of that the intervention size was 3,700 and the other side was 3,100. So these are the varieties that interventions they have used: cognitive behavioral therapy, mindfulness based intervention, social skill intervention, and the interventions were spread over 1 week to 16 weeks, 6 to 20 in number, 45 minutes to 2 hours, and there was booster session for few studies. These were the outcome assessment scale used for depression and anxiety. There were also follow-up assessment. So the finding shows that, I will just show the forest plot here. So this is for combined children and adolescent depression group. So the p-value shows that it was significantly different between the groups. Here is for children and adolescent but anxiety. So this was also found to be significantly lower in different group. And subgroup analysis was also done for depression, anxiety, both adolescent and depression, and children. So only the findings we found that everywhere it was found to be significant except the depression among the children. Okay. And the publication bias was also detected through funnel plot. So both sides symmetry has shown that there was less likely to be biased, like publication bias is there. Okay. So this has given us the scope to review with other previous work if non-pharmacological interventions were effective, as we have found that it was not significant for the adolescent and children, but that may be due to the larger studies were not available, and we have found only 2
Your
studies.
time is up.
Just 1 minute, ma'am, please. So the heterogeneity in selected studies based on the types of
non-pharmacological intervention, those were there. So we recommended that large-scale and multicentric randomized control trial are to be done to reach to a specific conclusion. And definitely we know that multi-component interventions such as yoga, mindfulness, and acceptance and commitment therapy, so this could be additional to the actual pharmacological intervention which could be effective for both children and adolescents. Thank you.
Thank you, Maya, for I think that seems to be a kind of rigorous work which you have done. I just have 2-3 questions, like systematic review when you have done, like how many people are actually involved in doing it? Like, is that only you have done it or somebody else also were there?
Sir, it was me and Dr. Rajesh.
So only you both were involved in it?
Yes, sir.
Okay. And how did you import and export the data? I mean, like you must have done the what is that? EndNote library we get, no, with all the data, whatever you have derived. So how did you do the importing and exporting while you were compiling the data?
Sir, generally we did the individual search through individual databases, and then we used our RAN software actually.
Okay.
We use RAN software for using the maintaining the things. Okay. And then whenever we have done the like we have already done with any biases there, so other author can check, and then finally we'll come to conclusion that which one to keep and which one to delete. Okay. And final keeping the actual article, we will not take into consideration the other one.
Okay. You have taken the entire, you have downloaded the entire article, or it was only the title and abstract? You have downloaded the entire article?
So for example, if we do PubMed search, so we have a scope there that we can search that, like save that search history.
Okay.
So it shows that whatever available, if it is abstract or if it is full text, we can keep save as it is, and we can bring it to Mendeley also. There is one .ris format. So with that we can save that one, and later on we can go back and search. So initial scrutinize involves only the with title, abstract little bit, yes sir. So many of the things goes out at that period.
But finally, you have, I think whatever you have put here, the entire study, have you gone through for all the databases which you have taken here?
Yes sir. Like especially we got more from the PubMed, rest
PubMed.
others were very
But
few.
you have taken the entire study?
Yes sir.
You are able
we can
to
bring it to RAN actually.
Okay,
RAN software is very handy in that way.
Okay. How did you avoid duplication? Duplication of studies, like when you're writing the EndNote, no? Sometimes duplications might be there. Like how did you avoid it actually?
Again said there is one scope in RAN.
Okay.
That
So it
duplication
gets done.
deletion.
Okay,
Yes sir.
okay. Okay then. Thank you.
Thank you sir.
Now, is there any participants who wants to ask any clarification or any suggestions from your side?
Is there any clarification?
If there are no clarifications, can we move to next person? And presenters, please stick on to the methodology. Otherwise, it is taking a lot of time when you are speaking on introduction and definitions. So please present methodology, starting from your statement of the problem.
Okay, thank you.
Thank you ma'am. Thank you sir. And thank you the organizing team for the opportunity. Thank you.
The next scientific paper is going to be presented by Ms. Rintu Mol PR, Principal, Royal Institute of Nursing, Amritsar, Punjab. The presenters are being requested to please stick to the methodology only, as it's taking a long time. Thank you.
A very warm good afternoon to all of you. My problem statement is a quasi-experimental study to assess the effectiveness of progressive muscle relaxation therapy on anxiety among elderly in selected old age homes of Amritsar, Punjab.
Can you maintain silence, please?
Objectives: to assess pre-interventional anxiety of elderly people in experimental and control group, to assess post-interventional anxiety of elderly people in experimental and control group, to compare pre-interventional and post-interventional anxiety of elderly people in experimental and control group, to determine association of post-interventional anxiety of elderly people in experimental and control group with their selected demographic variables. Inclusion: elderly, those who are available in selected old age homes, those who are willing to participate, those who are able to understand English, Hindi and Punjabi. Exclusion, elderly, those who are deaf and dumb, sick at the time of data collection, diagnosed with mental disorders or physical problems, presently employed or parole. Hypothesis, there will be no significant difference between pre-interventional and post-interventional anxiety among elderly people measured at P 0.05 level of significance. Methodology, research approach, quantitative research approach, research design, pre-test, post-test with control group design having 2 observation points has been used. Population, elderly people residing in old age homes, study setting, Guru Ramdas Old Age Home, Amritsar, and All India Pingalwada Charitable Society, Amritsar. Sample size, 60 elderly people, 30 elderly people in each group, experimental and control group. Sampling technique, convenient sampling technique, variables under study, independent variable, progressive muscle relaxation therapy, dependent variable, anxiety among elderly. Tool 1 was socio-demographic profile. It included age, gender, marital status, duration of stay in old age home, prior occupation and number of children. And the second tool was Jung self-anxiety scale. It has 20 items on anxiety. Each has 4 options. That is a little of time, 1, some of the time, 2 score, good part of time, 3, and most of the time, 4. And item number 5, 9, 13, 17, and 19 are reverse scored. So the scores ranges from 20 to 80, and the criteria for measurement was normal range 20 to 44, mild to moderate level 45 to 59, severe anxiety 60 to 74, and extreme anxiety 75 to 80. Ethical consideration, ethical approval to conduct the study has been taken from old age home authorities in the respective area to collect the data. Apart from this, written informed consent and patient information sheet has been taken from each study subjects. Confidentiality and privacy of the study subjects has been taken care of. Pilot study was conducted from 26th of September to 10th October at All India Pingalwada Charitable Society control group and Guru Ramdas Old Age Home. Their experimental group has been taken from there, and 3 samples from each area selected for the study as per the criteria. And from 27th September to 10th October, that is for 2 weeks, PMR has been administered daily for 30 minutes to experimental group. On 10th October, post-test has been conducted. Results shown that in pre-test, moderate level of anxiety was found in both groups, and in post-test, experimental group had normal ranges, whereas in control group, anxiety level was same. The main study was conducted between 7th of December to 21st December at the same venue, Amritsar. That is Guru Ramdas Old Age Home and All India Pingalwada Charitable Society, Amritsar. 30 samples were selected for each group as per the inclusive criteria. Method of data collection. On day 1, interview method was used to assess pre-test level of anxiety by using Jung self-anxiety scale. It took nearly 10 to 15 minutes for each participant. Then PMRT was given to experimental group by demonstration method in a group of 4 to 5 candidates. A written demonstration was taken from each elderly, and training continued till the elderly learned this technique. Then intervention was continued for another 14 days, that is for 20 to 30 minutes once in a day under supervision in selected old age homes. Then on last day, interview method was used to assess post-test level of anxiety by using same scale to assess the effectiveness of PMRT on anxiety. Statistical analysis was performed through differential and inferential statistics using SPS 18, and the level of significance 0.05 was considered as the level of significance. Regarding the characteristics of demographic variables, most of the elderly was found in the age group of 61 to 70 years. Regarding the gender, most of the elderly fall under the category of female. Regarding the marital status, most of the elderly were in the age... Ma'am, you have 2 minutes left. 2 minutes left. So mean scores of pre-interventional anxiety of experimental and control group among elderly people shows that it was 61.83 of experimental group, which is slightly more than mean pre-interventional anxiety 61.70 of control group. The comparison between pre-interventional anxiety of elderly people in experimental and control group had a non-significant difference with unpaired t-value 0.217, degree of freedom 58 at p 0.05 level of significance. The mean post-interventional anxiety, 61.53 of control group, was slightly more than mean post-interventional anxiety, 59.43 of experimental group. The comparison between both the groups shows that there was significant difference with unpaired t-value 3.40, degree of freedom 58, at p-value 0.05 level of significance. Hence, it was concluded that PMR was effective in reducing anxiety among elderly people. So the hypothesis was rejected. Then regarding the association of post-interventional anxiety of elderly people in experimental and control group with their selected demographic variable, the ANOVA test was applied and data was analyzed, but the result found that there was no significant association found between the demographic variables and post-interventional anxiety among the elderly people. So the discussions, present study concluded that PMR proved to be effective in reducing anxiety among elderly people, which is the results were supported by Dr. S.K. Maheshwari et al., who conducted a quasi-experimental study on effectiveness of PMR on anxiety among elderly people in selected old age homes of Punjab, where PMRT showed significant results in lowering anxiety. And another study by Ajay Kumar et al. Conducted a pre-experimental study to assess effectiveness of PMRT on anxiety and depression among elderly people.
Your time is up. Your time is up.
Okay, thank you.
Some clarifications from my side. So you have written that you have done post-test on the last day of your intervention. You have done post-test on the last day of your intervention.
Yeah, madam.
How many days intervention you have given?
2 weeks, madam.
So the last day you have done post-test.
The first day pre-test and then continued the PMR for another 14 days and the last day conducted.
Is there any rule that we have to wait for some time after intervention to see that whether time is not having impact on our intervention? No.
Pardon, madam?
Usually we do post-test after 2 weeks minimum. We expect some changes due to, for example, if you have taken class now, if post-test is done, score will be high. After 1 week with the retaining of this is there, that you have done JPMR or any other?
No, Jacobson progressive muscle relaxation.
And one more thing, in your statistical analysis, you have written ANOVA, you have done to assess association of. Can I see that slide? If okay.
The slide it was not.
No, you have written there.
Written there.
Why you have chosen ANOVA to identify association?
Because in the beginning chi-square we used and there was no association found. So we thought like scores independently we will do with ANOVA, means maybe some significant association we can find out, but there was no association found afterwards.
But ANOVA is for analysis of.
Madam, for categorical means like so that time chi-square and another scores are there.
Yeah, that is chi-square is fine, but ANOVA is not in lieu of chi-square. ANOVA is a parametric thing, chi-square is non-parametric. You can use as a parametric also chi-square some cases, but here your non-parametric chi-square. But it is not in place of chi-square, you can go for ANOVA. No, this is statistically not correct.
Okay. So you are telling that you have done chi-square, there were no association. It's not must that you have to get the association. You just present the fact in research. Even though study is showing that there is no effectiveness or effect, it's not our business. You have to present it in that way.
Actually, madam, my statistician told we will go for the ANOVA, so maybe with the scores, means there can found.
ANOVA is to find out the difference between means more than 2 groups. That is not for.
For continuous variables, yeah.
2 group, experimental and control group.
Oh no, that is 2 groups only, na? More than 2.
Okay.
Okay. Yeah, I think that's fine. I think probably can go and have a relook into what you have done. I have just 2 questions here. Like this PMR you have given for 30 minutes, isn't it?
20 to 30 minutes, sir.
How many times in a day you have given? Is it only once or?
Only once only, sir.
But they say that it would be better if you give twice in a day for 2 weeks, progressive muscle relaxation. I think you probably can just look into it. And this 30 minutes every day you were demonstrating to the patient, or it's like one-time demonstration and you are just making them to do and supervising
no,
them?
sir. The day one I demonstrated it and I made them to show it. I read a written demonstration. So wherever they are getting difficulty, I re-demonstrated it. And the subsequent days, when in between anybody is not doing it properly, so then I used to assist them.
Okay, I think pilot study and your main study you have done in the same setting, same center.
Same center, but I excluded the that pilot study participants from the main study, sir.
Okay, you did not include them
No.
here. Okay. And were there any side effects? I mean, have they undergone any difficulty after doing this PMR?
Nobody has reported.
I mean, have you taken some efforts to find it out, or you were only concentrating on a data collection? Because progressive muscle relaxation, like you start from toes and then you go to the complex muscles, right? Sometimes for old age population, it might be a little bothersome. They might be having some side effects. In the sense, like they may be having some difficulties in doing it. Like, have you out of your way gone and taken some efforts to find out if they're having any issues because of it?
Whenever I am reaching the next day, I used to ask you people were comfortable whether you were having any problem or not. So they didn't reported anything like that.
So nothing like that. Okay. And you said that you have taken 30 participants, isn't it?
30 for experimental and 30 for the control group.
How did you arrive at this sample size? Like, why not 20 and why not 40? Why it is 30 specifically?
Sir, actually there was 74 participants, so in the beginning 30 I took, 3 I took for the pilot study. From one side, Guru Ramdas Old Age Home, there was 74 to 80 candidates were there during the pilot study. So, and another place it was 11.
So you can give justifications by having sample size calculation being done properly. I think probably can look into it. Is there any other comments or suggestions from the group?
Mild, moderate or severe, or everybody had anxiety, or the anxiety reduced with JPMR?
No, it was under the mild moderate anxiety level category only. That second category it was came, but the scores come down after the post test.
No, in your analysis, did you show us the mild, moderate, and what was the level of anxiety after your intervention?
I have given the mean, so there.
No, not the mean. But we would like to know that how much of level of anxiety has reduced, and who was giving instructions for JPMR?
Pardon?
Instructions kaun de raha tha for the JPMR?
Actually, I took training under a psychologist for 2 months, madam, before starting going for the intervention, and I got certificate also from that psychologist.
No, no. So you were giving instructions every day?
Every day I used to give.
For all the 30 interventions, you were there?
Daily I used to for the 2 weeks.
They were not doing on their own, but you were doing it for them?
No, few of them they were able to do it independently, but few people in between they were facing difficulties, so there I given assistance whenever they were having problems.
Mentioned the institution's name many times. Actually, why institutions are not giving permission to do study is because of that.
It is mentioned, Madam Guru Ramdas.
I am telling you have to maintain confidentiality actually.
Okay.
You don't have to mention because you are telling that people are there old age homes, they have anxiety, right? So one institution is running for the benefit of the people. We are thinking that they actually maintain confidentiality. Otherwise, we don't get permissions from most of the.
So in that area, we have to skip that.
Skip one of the principles of our research. We have to maintain.
Oh, okay, sure.
Just tell the setting, mental health, old age home. That's enough.
Okay. Thank you.
Can we move on to next?
Our next presenter, Mr. K. Jayakrishnan from AIMS Kalyani, West Bengal.
Good afternoon, one and all. So the current qualitative study was done by me, Jayakrishnan, and Dr. Arunjyoti Banam from Head of Psychiatric Nursing in LGP Regional Institute of Mental Health. Pankaj Kumar Doctor, who is a psychiatrist named Patna, and Saila Balamonti, who is a professor at Ideal Institute of Nursing, Kalyani. So the study being a phenomenological inquiry into the lived experience of depression. We are exploring illness, difficulties, treatment expectations, and ideal world perceptions. So depression, as we have understood, is a pervasive mental health condition, extends a profound impact on the lives of millions worldwide, and it is a complex interplay between emotions, thoughts, and behaviors, of course. And there is a huge statistics which we have been discussing for the last 2 days. So the idea is a phenomenological inquiry into the lived experience of people with depression. So objectives were to investigate the experiences of illness and perceptions of difficulties among the individuals with depression, while also examining their expectations and hopes for the treatment and exploring what is the visions of them of an ideal world. So the design used was a descriptive phenomenological design, purposive sampling, 10 samples were taken, and psychiatric of an IPD tertiary care setting was our setting, and socio-demographic tool as well as a semi-structured interview schedule was used for the study. The sampling criteria were clinical diagnosis of bipolar and unipolar depression for more than 6 months, Hamilton depression scale of more than 14, that is moderate, severe, and very severe depression, and an age more than 18 years who speak and understand English or Hindi and were admitted in IPD. Exclusion were primary diagnosis of neurotic organic substance related disorders, and who were unwilling were excluded from the study. These were the interview schedule questions for exploring difficulties. What does depression mean to you? For exploring illness, how was depression affected your health? What is your depression what is your experience going through depression? What is a day for you with depression? For treatment expectations, what do you expect while going through the treatment regimen? And ideal world expectation, what for you is living in a world with no diseases? So to ensure the trustworthiness, credibility was done through reflexivity, prolonged engagement, and peer debriefing. Dependability was done through internal inquiry, external audits, wherein which we used a nursing faculty who is a psychiatric nurse as well for the external audit. Conformability was set by the investigator triangulation, because two of us were sitting together through the narrative process. And for transferability, we checked for the saturation of the data, thick descriptions were set, and we have ensured good quality enhancement effort in the documentation. And authenticity was done similar to how credibility strategies were used from the beginning till the end to ensure the trustworthiness of the study. Age group between 18 to 28 were majority, and it was 60 and 40, 6 males and 4 females, as per to say. Majorly from a rural setting and majorly unmarried because of the young population, and who have graduated till high school. Occupation, majorly they were unemployed or housewife, and who were in between 6 months to 1 year, and number of hospitalization was 80. So through the explorations, we found that in exploring difficulties, major themes that has been reflected has been sleep disturbances and their impact on daily life. Majorly, many participants have told about how sleep has been disturbed, and then psychological distress and thoughts of negative cognitive patterns, where they told what the lot of unwanted thoughts are coming through the disorder, and I can do this or not, if I want to do or not, they were confused about that. Then they have talked about issues in relationship dynamics and how that is affecting their emotional well-being. And they also reported physical symptoms as manifestations of underlying mental health issues, and how they have been seeking help and navigating the journey of diagnosis and treatment, how they have tried to get help. So that's how they were going through the depression. In exploring illness, major symptoms that had come out were the psychological distress, that is, they have reported loneliness, isolation, suicidal thoughts and attempts, worthlessness, hopelessness, were certain sub-themes that we had found. And physical well-being, issues like weakness, headaches, gastric issues, muscle problems, certain side effects of medications were also reported. And in social dynamics, they projected lack of support and understanding, family issues, conflict and such. And through the process, they were also talking about recovery and treatment, that some of participants were also reporting being fully cured, or that they will be taking medicines lifelong and they have better sleep and such. And in treatment expectations, few themes that we have identified is the improvement in symptoms and mental state, where they feel that they were recovering.
Sir, you have 2 minutes left.
Yeah, thank you, madam. And concerns and worries about relapse or future episodes. They have also shown satisfaction with the treatment process and healthcare providers. And they have also told the perception of treatment availability and effectiveness. They have questioned in certain outliers as well, wherein which they feel that psychiatrists were not helpful, like a statement in which they said, I came and sat, the doctor called, and he said, if you come, you have to wait, but if you are in a private clinic, you can give money and you could see the doctor immediately, but it's not such in here. So certain ill perceptions were also projected. And then suggestions for improving healthcare services, like for exercise and workout, has also been told. In an ideal world perception, where we asked how it feels to be in a disease-free world, they have told that there is perception of disease-free world was not occurring to them. Certain participants also said that there will be, how can there be no suffering? Suffering will always be there. And they have addressed issues like individual autonomy, being free and being able to do things on their own can be a good situation, personal well-being and daily functioning, and as well as how they have coping from the past trauma and present circumstances, that they feel a day without disease would be somewhere where they feel they will have little tension, they don't have to think about the traumas they went through, they will feel good with the certain narrations that they have said. So these were the result findings that we had. And certain similar findings were studies where a qualitative study on adolescents with depression in adolescents were seen who were entering psychotherapy. And another study which was done as a meta-ethnography in women's experiences in depression in India were also found to have similar findings.
Your time is up.
So that will be all. Thank you very much.
Thank you, Jai Krishnan. I just have 1 or 2 questions here. I think it's an interview which you have conducted, isn't
Yes,
it?
yes.
And this sample size you said is 10.
Yes,
Is it predetermined or depending, after reaching the saturation, you have just stopped with only 10?
Yes, data saturation was thought.
So depending on that?
Yes.
Okay. What kind of phenomenological data analysis which you have done? It is a kind of narrative type or?
Yeah, it's a thematic analysis, narrative type.
Narrative type.
Yeah.
Okay.
The approach was, Georgie's approach was taken.
That you have adopted.
Yes.
Is there any difficulty which you personally felt while collecting, while doing interview with this group?
The idea behind is that it was a study, ongoing study, which I was doing on as a quasi-experimental study, which I was doing. Okay. In between that, certain patients who find good with their communication, who I felt comfortable talking, those were the people who I have purposely selected. Okay. So the interview process was not difficult in that sense.
Okay, taking into some example, can you just tell me how did you do the bracketing? When you start with the, I think that is the first very step which we do in the data. Can you just give one example so that it will be very clear?
Yeah, so for bracketing, majorly what we did is that we never did the analysis alone. What we did was we did peer engagement.
Right.
And so as that we were constantly trying to help each other show biases. So it was a very constructive process where the other investigator was pointing out that I think that is a bias that is coming from my side. Okay. So like that the peer engagement was the main process.
Okay, again when you were clustering the data, did you have any kind of pre-preparation or before that, or it has been done just like that when you were doing clustering?
Majorly, after we got the narrations, then we shifted them item wise, and we made according to the criteria that we had set for like exploring treatment expectations.
Five, which you have, I think.
Four, sir.
Four, yeah, okay.
Like that, we had categorized item wise. That was the first thing that we had done, and then with copies with each of the peers, we had done the narrations.
Okay, this is just a part of your PhD work, or it's
No, this is not a PhD work.
Okay.
I was going through the PhD work,
Okay.
and then with Dr. Arinjyoti madam had conceptualized that we can have a qualitative study so that we can better our interventions. That was the basic idea.
Okay.
So this is not in my PhD.
Okay. Thank you. Good work. Yeah.
In the result, Mr. Jayakrishnan, you have to put the how many person has narrated that particular statement, P1, P3, P9.
Which participant? Yes.
So that it should reflect, like, how many
True.
P1 that is missing, I
Yes.
think.
I did in my concept, but I didn't put it in the slide.
Did you use Kulavi method for this?
No, madam, George's method. George's method.
And did you take their verbatim in their local language?
Yeah, it was.
You took? Acha.
It was Hindi.
That you've not put it here because sometimes when you interpret in English, the concept or the whole thing changes.
Yes.
For that matter.
Yes.
Because if you put the translation in Google, it gives you something different.
No,
But
true.
when you do it otherwise and with your peer, as you said that you had another co-investigator with you.
Yes.
So then you will see that the verbatim's message is different.
Mostly when we do in Google, it gives a very ornamental kind of language, which is not possible in
That is not possible.
Yeah, we did.
Usually in the phenomenological studies, we usually give the verbatim in the local language
Yes,
plus translated in English.
Yes.
And so that we know that you did this because
Oh,
everyone
okay.
might not be English speaking. You
No.
did the translation and then you have
Yes,
put it here.
nobody
But you
spoken
should put
English.
both the languages so that we know.
Okay, understood. Yeah. Thank you, madam.
I have one. Why did you choose George's method for this when others are
No,
selected?
George's method, because I felt George's method is better for where peer engagement and external audit is involved in it. So I felt because we can bring more trustworthiness, that is why it was used.
Okay. Then why did you choose this study, this topic?
No, the topic being, for a long period of time, I have been collecting data from patients with depression, so I had a good communication with them. It took almost 1.5 years of data collection. So I had a very good communication. So I felt that it is good that we understand what is their treatment expectations, how they feel, because of many communications that I had. And primary objective being, I wanted to enhance the quality of my intervention.
Okay.
That was also an idea.
Then when recording the verbatim,
Yes,
did you write or record it?
Recorded.
Audio recording.
Recorded.
So you have taken consent for both?
Yes.
Recording
Every
and
time I showed them that I am going to record it.
Okay.
I selected patients who were comfortable with this.
Transcription?
Then I transcribed the whole narration, then translated, and then.
Transcription, you only have done it?
No.
You have given to somebody?
Yes. Means the other person knows better Hindi, so I felt that would be better.
So as Arinjyoti ma'am has told, I think you should have given us the data of how many the themes and the sub-themes. Usually there are themes, sub-themes and then the verbatim. But I think you hit the...
No, I have made codes first, madam, then sub-themes and themes for the
have them in one table also.
Yeah.
So that we know this is the theme, these are the sub-themes, and then one or two verbatims.
True. Yes,
And how many respondents responded to that particular thing should come in one table.
Okay. I basically tried to compress the slides. Yes, truly.
Have you developed any hypothesis or conceptual framework out of the study?
No, madam. No, I am.
You can, in the future, I think. Conceptual framework, it will be very clear for if you are giving publication or something. So if any participants are having any doubt, we can ask. Or since the methodology was clear.
You said you did the somebody from your team did the translation. So are they certified like based?
No, they are not certified.
But like you can't make sure na that Hindi and the colloquial language, the person who has done the translation, or either if you have done it yourself, you can get it certified by a Hindi teacher who is.
No, we did not go through that process.
That would be benefiting
Yeah.
for the
Yes.
your beverage.
I am not sure if it is required. Okay.
Actually,
To
if it
increase the
is,
credibility of the. Yeah.
Actually, certification as such is not required, but.
Usually, if it is a tool development or something, we need it.
Yes,
Otherwise,
narrations, I was not sure that we have to go through that.
And you're sure that the person was a person who is speaking, it was his native language.
Yes.
Who transcribed
Yes.
it.
How have you data? Means their Bharva team. How have you compiled those and
Compiled in the sense, madam?
means their Bharva team or responses or answers you have 10 persons was there, na?
I was using a recorder to record their narrations, and then I have transcribed the whole narrations in written format, and then translated. That
Means everybody is not answering like same. So
no, we are not expecting everybody to talk in the same way.
how you have compiled or together the data?
I guess a compilation in the sense we are expecting that they should be talking, they should be giving narrations which are wide and varied. So no particular compilation.
Where you have reached data redundancy, you understand that
Yes.
there are no more points to be.
come, then
So you have reached there, right?
Yes,
Then
yes.
only you have stopped with
Yes.
10 clients.
Yes.
Then why this question?
I don't compilation I have not understood, madam.
Compilation means everybody will not answer the same things, na?
Yes.
So how you have put there? These
That's
are the
fine, I
findings.
think. Like as they are giving information, it is getting recorded. I mean, like in whichever way they.
Compile those and put there. Theme
will be identified from each particular
Theme based. Theme based. Common theme based.
It is the process how we will do the analysis.
Okay, thank you.
Okay, thank you, thank
Yeah.
you.
Thank you.
We'll
Thank
move
you.
on to the next presentation.
Our next presentation will be done by Mr. Deepak K, Associate Professor, Monika Ka, Topawala Institute of Nursing, Gujarat.
I have one disclosure before my presentation. Actually, this presentation I did for Sarla Kapoor Award, Young Scientist Award. This is my independent study and below age 40 years. So nobody involved in this. This is a single project. Actually, I did it for the Sarla Kapoor Award, but fortunately, unfortunately, there is no minimum criteria met, that is no 5 papers. So I was allowed to present in this scientific paper presentation, and I thank the organizer for the same. So I'll move on to the topic. My intervention was very unique, that is emotional freedom technique. So till now we already, and especially I'm going to implement this emotional freedom technique on physiological and psychological parameters of students with stress and anxiety. It is a randomized control trial. So I'm not going for the statistics of the anxiety and stress, because since morning we have a lot of statistics which says that, there are anxiety and stress prevalent among the adolescents. And especially the first year students, the stress and anxiety level are very high, and as per the previous literature. So I would like to emphasize more on the intervention. See, right now to overcome the stress and anxiety, we are using a lot of interventions like yoga, meditations, pet therapy, garden therapy, so on. But a unique technique, emotional freedom technique, this is a blend of acupressure and acupuncture, emotional freedom technique. So this was least utilized by the nurses. So I utilized this study to know its effectiveness on some of the psychological and physiological parameters of stress and anxiety. So I have two objectives: to assess the level of anxiety and stress among students, and to assess the effect of EFT on psychological and physiological parameters of students with anxiety and stress. So related to I define only this technique. This is an unique technique. So we are having almost in other acupuncture we have more than 300 meridians, but this technique having only 12 meridians. So the top of the head and the beginning of the eyebrow, lateral eye, below the upper lip and the lower lip, at the chin, then clavicles, and on the each surfaces of our hands. So along with this tapping, we have to go for the positive affirmations. So the major principle of this intervention is to, it reduces the blocked energy. So when the block energy was released, we feel ease from the anxiety and stress. And also it helpful in treat post-traumatic stress disorder and even in depression also. So hypothesis, there was no significant difference between mean stress level and anxiety level score before and after intervention among the EFT group at significance of 0.05 level. So related to research methodology, I used the quantitative research approach, and it was a randomized control trial. So here I used an independent assessor to measure the outcome. So especially here, when we go to the study, we have the consort guidelines to report this trial. See, initially I approached all the first year students, 60 students. Then after screening for the inclusion and exclusion criteria, 11 students were excluded because 6 of them were declared and few 5 students are having health issue. Then out of those, 49 are eligible, but I recruited only 40 with the help of cheat method. So then allocation, for allocation, I already having the sampling frame of 40. So with the help of randomizer software, allocated them into control and the experimental group. In the experimental group, the students received 3 days intervention for 40 minutes. But control group, as if they have not received any intervention. Then post-test was conducted on the 3rd day. But what happened in the post-test, 5 participants discontinued because they couldn't able to take the interventions. So finally, I analyzed for the 15 students. But in the experimental students, 1 student couldn't able to give the post-test, so I could able to take only the 19 students. So based on that, the data was compiled. So here the study variable, independent variable will be emotional freedom technique, and the dependent variable will be change in the psychological and physiological parameters. They just kept the demographic variable age, gender, and religion, and the selected nursing colleges will be this my setting. The target population will be the nursing first year nursing students and who are accessible at the time of data collection, and have in the criteria the student should have the anxiety scores more than 22 and perceived stress score more than 14 were included in the study. And this is my study criteria. So first year students and who are aged 18 and above and who meets the anxiety level 22 according to BAI and 14 according to perceived stress scale. And in exclusion, I have students undergoing any psychological therapy, students who are not willing to give consent, and students having any sensory impairments and physically challenged, that is especially upper limb, and students who are undergoing treatment for stress, anxiety, or other psychiatric conditions. So far, I didn't get anybody in the exclusion criteria. So in terms of age, definitely above 18 years in both the group, and majorly I don't have any male students, so only the female students will be the part of my study. The majority in my study belongs to Hindu religion in both the group. So in terms of anxiety, in both the group, in the EFT group, I found the majority, that 70% belongs to moderate anxiety, and in control group, 65% belongs to moderate anxiety. And in EFT group, 30% belong to potentially concerning level of anxiety, and 35% belongs to potential and concerning level of anxiety in the control group.
So you have 2 minutes left.
Okay. So findings related to anxiety about EFT and control group. This is a post-test. In post-test, it was observed the majority in moderate level in both the group. So to know the effectiveness within the group, it was found that I have, as the data was skew, I have run the non-parametric test, that is Wilcoxon test, to know the effectiveness within the group. So obviously, it was found the EFT group, the mean post-test score was 23.56 in compared to the pre-test score, that is 32.40. So it was found that the EFT was effective in treating the anxiety level. Similarly, I observed in stress also. When you look at the post-test, the effectiveness, it was found, even EFT was found effective in treating even stress level also. Then in both the group, I have not found much physiological changes, especially the systolic blood pressure, before and after, but yes, I have found little variation, especially some significant changes in the heart rate in the EFT group because the anxiety is related with the heart rate. So in conclusion, it was observed that there is a significant improvements in the physiological as well as psychological parameters in EFT group in comparison with control group, hence the null hypothesis H0 which I stated was rejected. So these are some discussions. So no conflict of interest was found, and the IEC was obtained from our institutional ethical committee.
In your parameters, you have checked systolic and diastolic BP only. Anything else you have?
Heart rate also.
Heart rate also. So that was the physiological parameters,
Physiological
you have.
parameters, yes.
And you have mentioned psychological parameters in your statement, right?
Especially the psychological test what I used, Beck anxiety inventory as well as pursuit stress scale.
This
Is that emotion focus intervention, or what you call
emotional freedom technique?
Emotional freedom technique.
Yes.
Is that name has been given in the intervention?
It's an intervention, ma'am. It's a new intervention.
You have designed
No. I have not designed anything. It is already
there, and it is available with that particular name only. Okay.
Yeah. We have the institutes who will train for this EFT, and I have undergone the training for the same, for the certifications.
So you have given 3 days of intervention,
Yes,
isn't
sir.
it? 40 minutes per day.
Yes.
Only that much.
Sir, actually, no, as per the literature, even the single session EFT also very effective in treating the stress and anxiety. But still, however, I kept it for 3 days, even because some literature says 2 days also effective. So, but at least taking an average, I kept it for 3 days.
Okay, what were some of the confounders, I mean, as an investigator, you thought would have been there in your research?
So, sometimes what happens, some students are taking any other counseling or any other medications.
Was it there? I mean, like
No, it was not there, might be with the confounders.
Okay, you have taken ethical committee permission also for
Yes,
doing this
of course.
study.
Before doing any study, we have to clear our IEC.
Okay, this emotional freedom technique you have done on every student, or the students were asked to do it by themselves?
See, actually, I'll make them to practice.
Practice, yeah.
For 3 days, the intervention will be given because, when I keep on tapping, they will come out with some of the problems. They expressing. Based on those points, I just keep on tapping with the positive affirmations.
Okay, that's what, like, you were primarily involved in doing
I
that.
am primarily involved.
Okay.
I have to give this intervention to them. They cannot practice independently.
So, like every day you took 40 minutes for each student?
Yeah, for 3 days.
Which means
See, it's not independent, it can be given together only.
Group also?
Group.
Okay. Any other clarifications or suggestions?
Any literature which says that it is effective with the 3 days intervention only?
Yes, ma'am, I have.
You have some research studies to say that.
So, ma'am, actually, initially the same intervention I did it on depression in my PhD. But later on, I just extended it for stress and anxiety.
Okay.
In a single day, I have the literature. Even the single EFT
When
session.
did you take these first year students? When they just got admitted in nursing, or when they had completed their first year?
No, initially they joined in the period of 2 to 3 months.
2 to 3 months. And what is the technique of this therapy? We could know.
Yes, ma'am. See, especially, ma'am.
No, just little bit of it, so that
we have 12.
we have an idea.
Yeah, we have 12 meridians on the body. So the top of the head, beginning of the eyebrow, lateral eye, below the eye, below the. We have to tap it for 6 to 7 times. Okay, on these points. So it helps to relieve our blocked energy. Along with that, we have to do the positive affirmation also. So then it works well. And already, ma'am, more than 1,000 studies are there in this EFT. But in our profession, it was very less known. And it's the easy technique because yoga, meditation and all, what happens? They need some certain settings practice. But this can be practiced anywhere, even they're sitting on the bed, even they're in the washroom, anywhere it can be practiced. And I have wonder results from the students, especially first year students, who are having some sleeping. Actually, I worked for only anxiety and stress. But when they tried, they said that they good effect on the sleeping, they could able to sleep sound.
Very, very less, 20, only 20.
Ma'am, actually it's a pilot study because in the group of 60, I could able to do on a small scale, but still I have going to explore it on, the main study on the more samples.
Is there any studies undertaken on patients using this therapy?
Sorry?
This therapy has been implemented on patients. I mean, have you gone through any studies
Yes,
like
sir.
that?
Actually, I myself did on depression patients in the mental hospital, government mental hospitals, and I found a wonder results with this.
Okay.
And even there are so many other people also presented, but not from the nursing domain, but other domain they have published the paper on this. Even stress, anxiety, depression, and lots on. And especially for the craving, addictions.
Okay. Who has given you training for this? Like who?
Sir, actually we have Vitality College, Mumbai.
Are they?
AMT, yeah, they are the certified, internationally certified.
Okay. This comes as a part of acupressure or?
Sir,
or it
actually
is
in the
like under
modified
which
version
stream?
of acupressure and acupuncture.
Okay.
The Gary Cray, he was the founder of this EFT. Even had the publication in this Ispn journal, a concept paper to just enlighten the people regarding this intervention.
Okay.
And really this is a wonder intervention and I think everybody can practice it.
All right. Okay. We will move on to the next presentation. Thank you.
Our next presenter is Ms. Bhashwati Das, PhD scholar, LGBRIMH, Tezpur.
Participants are requested to present only the problem statement and the methodology.
Very good afternoon to one and all present over here. So today my study title is Knowledge of Primary School Teachers Regarding Childhood Anxiety and Depression at Selected Schools in Bengaluru. Introduction. Childhood period is crucial for children as in this period a child grows into a healthy adult. Insufficient care during childhood can lead to lifelong challenges as this critical period is essential for acquiring vital skills such as emotional regulation, building relationship, cognitive, motor and language abilities. One study from the India has reported that the incidence of depression to be 1.6%.
Kindly stick to the problem statement and the methodology as per the evaluator.
So the objectives of the studies are to assess the demographic profile of primary school teachers, to assess the level of knowledge of primary school teachers regarding childhood anxiety, to assess the level of knowledge of primary school teachers regarding childhood depression. So research methodology, approach was quantitative, design was cross-sectional descriptive design, settings was selected schools in Bengaluru, study variables was research variable, knowledge of primary school teachers regarding childhood anxiety, knowledge of primary school teachers regarding childhood depression. Demographic variables were age, sex, education, marital status, teaching experience, attended to children with anxiety in the classroom, attended to children with depression in the classroom, read childhood anxiety related literature in the magazines, textbooks or pamphlets, read childhood depression related literature in the magazine, textbooks and pamphlets. Sample, primary school teachers at selected schools in Bengaluru, sample size was 30, sampling techniques was convenient sampling techniques it was used for choosing the schools, then purposively the teachers were selected. Tools for data collection, baseline performa, then knowledge assessment questionnaires on childhood anxiety, 21 item self-report questionnaire, knowledge assessment questionnaire on childhood anxiety. It was developed by the researcher which was validated by experts in different fields. Reliability was found on 0.81. Knowledge assessment questionnaire on childhood depression, 19 item knowledge assessment questionnaire on childhood depression was developed by the researcher which was again validated by the experts from different fields and reliability was found 0.80. Data was obtained via electronic mode. Results, median age of primary school teachers was found 36.5 with the interquartile range of 32 and 41.75. The median years of teaching experience was 8.5 and with the interquartile range of 6 and 12. Majority of the primary school teachers were female, that is 76.7%. 50% of the primary school teachers were educated up to graduation level. Majority of the study subjects were married, that is 73.3%. Most of them did not attend to children with anxiety disorder in the classroom, that is 53.3%. Most of them attended to children with depression in the classroom, that is 66.7%. And most of the teachers read literature, read childhood anxiety related literature in the magazine, textbook and pamphlets, that is 73.3%, and most of them read the childhood depression related literatures, that is 73.3%. Most of the subjects were felt that need for the sensitization regarding childhood anxiety and depression to be provided to the teachers by the expert, and knowledge of primary school teachers regarding childhood anxiety and depression. So median score in childhood anxiety, it was found 15, and with the interquartile range of 13 and 17. Knowledge scores regarding childhood depression, the median score was found 14, and the interquartile range 11 and 15. Conclusion, the results of the study provides a significant addition to the limited research in this area. This study found that knowledge scores among teachers regarding childhood anxiety was 15 with the interquartile range of 13 and 17. Knowledge scores among teachers regarding childhood depression, it was found 14 with the interquartile range of 11 and 15. Most of the teachers read childhood anxiety and depression related literature in the magazine, textbook and pamphlet, but most of them felt the need for sensitization regarding childhood anxiety and depression to be provided to the teachers by experts. There is a need to conduct training programs for school teachers to increase their awareness and recognition regarding the childhood anxiety and depression with regard to the present and future well-being of the children and manage them in the classroom accordingly. Research, one study has found that teachers training programs are in a position to recognize and change not only the teacher's attitude towards the students with
You have 2 minutes left.
mental health symptoms. Okay, understood, ma'am. But also the interdisciplinary pre-service and in-service levels to increase the effective strategies based on the evidence-based practices. So these are the references which I used. Thank you.
Now the floor is open for discussion. Is there any clarifications from the participants? Since we are running short of time, we ask only one participant. Is it a part of your PhD study?
No, ma'am, this was a part of my MSc study.
Okay. What do you expect from the teachers after undergoing this study? Why did you do this?
Actually, ma'am, I have done an interventional study, so I have just reported the descriptive part of it. So after assessing the knowledge, I have given the intervention to the teachers.
That's what I am asking. What is your expectation from the teachers after undergoing your study?
Ma'am, to understand whether they have a knowledge regarding the childhood anxiety and depression or not, and how they are managing the children in the classroom, those who are suffering from the anxiety and depression, and how they have, what's their attitude on that.
Do you expect them to refer the child to
Yes,
treatment
yes,
center?
I have
Those
given
are childhood depression and
yes, yes, ma'am. I have helped them to I have given the information to refer to the in NIMHANS.
Okay, how did you select the school for the study?
It was with the according to the convenience, the schools were selected. Then purposively the teachers, those who have given the informed consent. So I have selected all the teachers from the school.
You have taken all the teachers?
Yes, sir.
How many schools actually were chosen initially for the study?
4 schools, sir.
And then finally you landed on only one school, or from all the 4 schools you have taken samples?
All the 4 schools, only the primary school teachers, sir.
From all the 4 schools? Okay. Okay, we'll move on to the next presentation.
Thank you.
Our next presenter is Mr. Dhamdas Ratre. He is pursuing MSc Nursing at Nursing College, AIMS, Bhopal.
Good evening to all. The title of the study to assess the caregiver burden, social support, family well-being among caregiver of common mental disorder patient at selected tertiary care hospital in Bhopal. This is the background and significance of the study. Then purpose of the study to generate evidence on the need of social support and family well-being for caregiver of CMD patient, so as help to decision maker in the region to devise appropriate social strategy. The objective of the study, the first one, to assess caregiver burden, social support and family well-being among caregiver of patient with CMD. The second is to find the relationship between caregiver burden, social support and family well-being. The third is to find the association of patient age, gender and diagnosis with caregiver burden, social support and family well-being. The methodology, quantitative research approach using cross-sectional survey, and the research setting is Government Hospital, Madhya Pradesh. The population of caregiver of CMD patient in Central India. The total 236 sample using formula as per the previous study. The convenience sampling technique was used. The inclusion criteria of the study is caregiver age 18 years and above, providing care to the patient for more than 1 month, available during period of data collection and willing to participate in the study, and able to respond in Hindi and English language. Exclusion criteria is caregiver who report mentally ill. The tool of the study is English, using the Hindi language, background performer. The part 1 is demographic performer of patient, then part 2 demographic performer of caregiver. The second tool is Jared Burden interview scale, is a 5-point Likert scale. The Cronbach alpha value is 0.82. Then third one is multidimensional scale of perceived social support, is a 7-point Likert scale. The Cronbach alpha value is 0.92. The fourth one is family health scale, is a 5-point Likert scale. The Cronbach alpha value is 0.8%. Ethical consideration was approved, the consent to use the tool for author and permission from medical superintendent to conduct the study, then informed consent from voluntary participant and confidentiality of data is assured. The pilot study is done on 25 samples and found is feasible. Then data collection from September to November through interview of caregiver in separate room. The data analysis was done using software SPSS version 20. The result table first shows the frequency and percentage distribution of patient characteristic. The majority of the caregivers are male 14 to 29 year of age, and 47.5% were anxiety and fear related disorder. The most of caregivers are 20 to 39 year male, then marital status and residence in urban and rural area 50%. The most of caregivers are clerical shop owner and formal, whose monthly income is 18,229. The majority of caregivers are graduate, belong to Hindu religious family, and about 97.9% caregivers have not attend any training program for caring of mentally ill patient. For the objective first, caregiver burden, social support and family well-being among caregiver of patient with social CMD. Caregiver burden 53%, mild to moderate burden, then 75.8% caregiver perceived moderate support, then 48.3% caregiver perceived moderate family health, and 45.8% poor family health. For the objective second, relationship between caregiver burden, social support and family well-being among caregiver of patient with CMD. The table clearly shows the negative moderate correlation between the perceived social support and family well-being. This is so that we accept null, we reject the null hypothesis, and the interpretate is the caregiver burden increase, the social support and family well-being decrease. Then perceived social support and caregiver burden positive moderate correlation between perceived social support and family well-being. Thus, if perceived social support increase, family well-being improve. For the association of patient caregiver and patient caregiver characteristics with caregiver burden, perceived social support and family well-being, this table clearly shows the all p-value is above 0.05%. So that we accept the null hypothesis. There is no association of patient age with caregiver burden, perceived social support and family well-being. This table also shows that there is no association with patient gender with caregiver burden, social support and family well-being. The p-value is above the 0.05. Among these table also we previously see there is no association of patient diagnosis with caregiver burden, perceived social support and family well-being. The p-value is above 0.05%. For the discussion in supporting of the study in Kerala, 57.3% had moderate caregiver burden and 26.7% had severe burden. Study found by Robbie et al. In 2021. In Imphal, 52.2% moderate burden, 6% had severe burden and 41.8% had mild burden. Study found by Chote in 2023. Caregiver burden almost similar in Central and South India. In the context of social support, for the similar study found in Egypt, 50% had moderate social support and 1/3 of study participants were low social support. A study found by Muhammad et al. In 2021. Social support to caregiver is comparatively better in India as compared to Egypt. For the concept of family well-being, in supporting of the study in South India, majority of caregiver had moderate family well-being, but 23 to 25% had low family well-being. Study found by Nalini et al. In Chennai and Nirmala in Hyderabad, the family well-being slightly better in South as compared to Central India. In the context of relationship between caregiver burden, social support and family well-being, there is negative moderate correlation between caregiver burden, social support and family well-being, and positive moderate correlation between perceived social support and family well-being at the level of 0.055%. Similar study found in Indore by Sharma in 2029. In similar study found by also in Hyderabad, finding reported by Nirmala in 2021. Implication in the practice area: assess the caregiver burden, social support and family health in hospital or community. The nurse must address caregiver burden. For the limitation of the study, convenience sampling using a rating scale may be a social desirability bias. For the recommendation of the studies using MIS method design may be undertaken, and caregiver training program may be intervention may be developed, and its effectiveness can be assessed. For the conclusion, caregiver burden give moderate, then there is need to enhance social support and family well-being of caregiver of CMD patient in India. These are the references. Thank you Ispn for the opportunity to present the research institution for permission to conduct a study, and my guide and co-guide, author of standardized tool and expert to tool validation, and participate in the study. These are the screening tools. These are the Hindi validation certificate, and we are also the item analysis. These are the other thing. Thank you.
All right, thank you. I think you've organized your content and presented well. I have one or two questions. Like you've in the inclusion criteria, you mentioned that the caregiver should have given at least minimum of 1 month of care.
Yes, sir.
Why is it like that? I mean, like, how did you decide that only 1 month? Was it based on any previous literature or?
Yes, sir, it is based on previous literature, and one thing is, if caregiver is below 1 month, या फिर caregiver mostly care to below 1 month, lower caregiver burden is slightly lower, so we cannot understand the how burden. So I'll take above 1 month.
That's what I was expecting. 1 month is.
Yes, ma'am. 2 less the time to perceive caregiver burden.
Minimum 3, and sometimes even we go up to maximum of 6 months, more than 6 months, 3 to 6 months. Yeah, that is one point. And my second question is, you spoke about family well-being, right?
Yes.
You have the copy of that scale, I mean the instrument which you have used, because in the results you have told about family health, poor family health, good family health,
Yes.
like that. I just wanted to know, like, what kind of questions were asked there, because you use your primary area of interest is to assess caregiver's burden, and caregiver is just a part of family, and then suddenly you're trying to correlate that with the entire family's health. So, like, what kind of questions were being asked actually?
Sir, question is based on family and overall family system, and already it's including doctor's perception and how their family income criteria and all the other things is included in this scale.
All right. And somewhere you mentioned about the demographic details of the patients also.
Yes, sir.
Why was it required?
Sir, is it required to understand the family is also already overtaking the result? अगर उनका कुछ पर्सन ऐसे रहते सर कि हम जो रूरल एरिया के हो गए या फिर जिसका फैमिली इनकम कम है, तो वो क्या करते हैं, उसको मोर बर्डन होने का चांस रहता है। इस वजह से हम उसके सोशियो डेमोग्राफिक परफॉर्मेंस चेक करते हैं।
Anyway, all right, thank you.
Okay, I have a question. What is CMD? It's
Ma'am,
not a one thing, it is not a standardized, term used in psychiatry. But what do you mean by CMD that you have used in your study?
Ma'am, CMD is a common mental disorder. We
No,
all
which
other
are common? Which are common?
like depression, anxiety, and fear-related disorder, somatoform disorder, and OCD also.
So which is left? You have taken all. Actually, you know what, if you have used this new term, CMD,
Yes.
then you should operationally define that which all disease conditions have you taken,
Ma'am, it's
or which have you missed.
like
है ना? Because there is no criteria as such if we say common mental disorders.
Yes,
Or
ma'am.
else, okay, you have taken schizophrenics, you've taken MDPs, you've taken anxiety neurosis, or you've taken all. Which all patients have you taken? We didn't see that in the table anywhere. कि कौन सा CMD, majority of the patients had which illness that you have taken?
Ma'am, we mostly take for diagnosis. First is stress and anxiety disorder, and depression, OCD, or post-traumatic.
Stress is not a diagnosis, it is a symptom.
Yes, sir.
हाँ, आपने OCD लिया और क्या लिया?
Post-traumatic stress disorder,
PTSD, okay
PTSD, and depression.
So you left the schizophrenics. That is
Yes,
also
ma'am.
one of the common mental disorders.
Ma'am, schizophrenic is also come under the severe mental disorder, so we left.
अच्छा, severe नहीं लिया, common mental disorders
ma'am,
लिया. I
common
didn't
mental.
understand the concept. Because the caregivers will have more stress. You know,
Ma'am,
staying
or
with schizophrenics.
If, ma'am, we take the severe mental disorder, we already know this is a severity, then already had some amount of burden. No, लेकिन if हम common mental disorder ले रहे हैं तो उसमें burden का chance कम है, तो हम वो देखना चाहते हैं कि common mental disorder है, उसमें care के burden कितना है और उनको कितने support मिल पा रहे हैं.
Okay. But somewhere you should define which all illnesses you have taken.
Yes, ma'am.
है ना? That's very important.
Yes, thank you, ma'am.
Just to add on to the discussion here, ma'am, just we are handling the primary care doctors training. So there we are trying, not focusing on the ICD-10 classification. So there we have a, we say trans diagnosis. So there we try to cluster the disease into CMD, SMD, SUD. Common mental disorder, severe mental disorder, substance use disorder. This is mainly for the, it's not a standard classification. This classification is mainly for primary care doctors so that they can treat appropriately. So we have something called trans diagnostic management also. We teach that common drugs used for the CMD. We are not saying treat separate drug for anxiety, for depression. Go with only risperidone or whatever things, things like this we are trying to fluoxetine for this common mental disorder. Yeah, I'm telling not this out of this study. So I would like to share this information. These classifications, as I'm telling you from the institution, we are trying to do this not as a standard classification, mainly for the purpose of reaching the primary care healthcare providers. And second thing about caregiver training, as you mentioned, no, as rightly ma'am said, caregiver burden will be very, very high in SMDs, severe mental disorders, than CMDs, because CMDs people, one classification is they have insight. So CMDs, those who are diagnosed with CMDs, generally they will have insights, whereas SMDs, they will not have their insights. So the caregiver's role is very high in SMDs than CMDs. This is to add on, let's add on to your presentations. But in future, if you refer some literature from demands, definitely you come up with these terms from CMD, SMD, SUD. These things comes. Yeah, thank you.
Ma'am. Thank you.
I think you are an MSc student, right? Congratulations for coming and presenting, being an MSc student. So you are the only MSc student presenting. So let it be a stepping stone. Okay.
Presenting our next participant, Ms. Sagarika Chetia, PhD scholar, LGB RIMH, Tezpur.
Good evening, everyone. So title of my study is Insight and Internalized Stigma Among Patients with Depression Attending a Tertiary Mental Health Care Setting. And this study was carried out under the guidance of Dr. Arunjyoti Borua, HOD, Department of Psychiatric Nursing, LGB RIMH. Introduction. Life is about going through many ups and downs. Every person have his or her own way of living and unique way to cope with changes occurs in life. Persons with depression has predominant low mood which can dramatically affect usual habits as well as hamper his or her day-to-day activities. Okay. Objectives of the study were to describe the socio-demographic and clinical profile of the patients diagnosed with depression, to assess the level of insight among patients with depression, and to assess the level of internalized stigma among patients with depression. Operational definitions. Here in the study, researcher considered insight is the ability of patients diagnosed with depression to recognize about his or her illness and concern regarding treatment as measured by mood disorder insight scale. And internalized stigma, here it indicates the same and feelings of discrimination from others which prevent the patient with depression to share their problems and hesitate to seek medical help as measured by internalized stigma mental illness inventory. So methodology of the study, here quantitative non-experimental research approach was adopted and research design was descriptive research design. Tertiary mental health care setting in Assam, then population was persons diagnosed with depression by psychiatrists of the tertiary mental health care setting as per ICD-10 diagnostic criteria. And sample were person diagnosed with depression attending the tertiary mental health care setting during data collection period and fulfills the sample selection criteria. Sampling technique was purposive sampling technique and sample size was 30. Sample selection criteria. In inclusion criteria, patients diagnosed with depression based on ICD-10 criteria by psychiatrists, then patients aged 18 to 60 years, and patients who can read and understand Assamese. Exclusion criteria, patient with psychotic symptoms along with depression, and patients diagnosed with chronic physical illness. Here, three tools are used. One is the self-structured socio-demographic performer, which consists of 17 items, and another one is the mood disorder insight scale to assess the insight, which was developed by Dr. Betts Powell, and total item was 8. Here, 3 subscales were there. These are awareness of illness, attribution of symptoms, and awareness of the need for treatment. Then another scale was internalized stigma on mental illness inventory that was developed by Dr. Jennifer Boyd. Total item was 29, and it has 5 subscales, that is alienation, then social withdrawal, stereotype endorsement, discrimination, and stigma resistance. And the interpretation of the tools, that internalized stigma of mental illness inventory scores, if the patient scored 1 to 2, then the minimal to no stigma, 2.0 to 2.01 to 2.5, that is mild internalized stigma, then moderate internalized stigma, and severe internalized stigma. And mood disorder insight scale also here, if the participant scored more than 2, then the insight was considered as intake insight. So data collection procedure here, the first approval taken from the scientific advisory committee, then ethical clearance also obtained from the institutional ethics committee, and formal permission obtained from the concerned authorities of the tertiary mental health care setting. Samples were selected purposively as per sample selection criteria. Informed consent was taken from the participants, and tools were applied, and data collection was done. Here results, the first table showing the description of the socio-demographic variables. Here majority of the participants, that is 76.3% were female, majority of the participants, that is 53.3% were belong to the Islam religion, then the majority of the participants, that is 40%, they studied up to middle school, and type of the family, that is 56.7% majority that were from joint family. And another table showing the description of the socio-demographic variables here is between the 18 to 50 years and mean 38.11 with a standard deviation 10.29, and monthly income 5,000 to 28,000 and mean was 16,500. Then table 2 is showing the description of the clinical variables. Here history of hospitalization, the majority of the patient, that is 93.3% patient with depression had no history of hospitalization. Then medication status, that 50% of the patient was on regular medication. Then there was no suicidal attempt in a majority of the participants. And total duration of the depressive episode in majority of the participants had 3 to 6 months. And this figure showing the percentage distribution of the overall internalized stigma towards depression, that is 36% of the participants are overall internalized stigma towards depression. That is the moderate internalized stigma. Then description of the subscales of internalized stigma, as already I have mentioned that there were 5 subscales, and in the alienation subscale, where the participant, there were some questions like, I feel out of the place in the world, that like they are considered them as the, they are not like the normal people. Here they scored, majority of the participants scored low. It means
you have 2 minutes left.
Then stereotype endorsement, here the participants had high stereotype endorsement. And in the discrimination experience also, they have the high discrimination experience. And in social withdrawal, the majority of the participant had the low social withdrawal. And in the stigma resistance, the 50% have the high stigma resistance, and also the 50% had the low stigma resistance. Next table is showing the description of insight of the participant with depression. Here, awareness of illness, this subscale, majority of the participants showed intake insight, and in all the subscale, actually, majority of the participants had overall intake insight. Now, discussion of the selected socio-demographic variables, as majority were female and married. So here, one study conducted by the Un et al. Showed that majority of the participants were female respondent and were married. And in occupational status, the number of female participants were more than the male participant. So this may be one reason that majority of the participants were homemaker. And monthly income of the participant was, that is 16,500 with standard deviation 6,320 rupees. Because the majority of participants were homemaker, so their source of income is earned only by one individual, which may be the reason for the low monthly income in the families. And in case of internalized stigma, here the current study showed that the overall internalized stigma is moderate. With one study conducted by the Sahu et al. Also showed that high internalized stigma is there in the stereotype endorsement, which is similar to my study. And in the overall intake insight, the contradictory finding was found that in the subscale, that is awareness of illness, had impaired insight into attribution of symptoms, where I found that all the participants had intake insight in all the subscales. So these are the recommendations. This same study can be replicated in similar and the different settings with larger sample size, and interventional studies can be conducted to identify the effectiveness of psychoeducation program to increase the to reduce the internalized stigma related to depression. And comparative study can be conducted. So these are my references. Thank you, everyone.
Just a few clarifications. You have told 30 patients you have taken.
Yes, ma'am.
Out of them, 5 have attempted suicide.
Ma'am, past history of suicide.
Yeah, they have tried for that. That means a high-risk group.
Ma'am, but they are taking the treatment from the tertiary mental health care setting. Now they are that period of time means they were continuously taking the treatment. So their treatment adherence was there. That's why I took that participants also.
Okay, it's an indication. So have you done anything for them or referred them somewhere?
Ma'am,
They are in the risk. Have you done anything for any intervention for this group or
Ma'am,
referred them?
psychoeducation I have provided to their family members regarding that suicide attempts, previous suicide attempts.
Usually when we find this type of data, you have to do some intervention
Yes,
out of our study. Like if they are high-risk group, participate in your study. When you are asking them regarding the questions, right?
Yes,
already they have attempted. There is a chance for next attempt also.
Yes.
So better to, and you have to mention your study. I have found 5 patients like this, and I have guided them to the psychiatrist, or you have to ensure that your treatment is being taken. That is out of the ethical aspects of your study. Otherwise, when you are studying about depression, sometimes it happens.
Yes. Thank you for your suggestion.
Could you clarify what is internalized stigma?
Sir, internalized stigma means the stigma which the patient is having related to many other factors like social stigma. Social stigma is there in our society that other people, they stigmatize the patient who is having any kind of mental illness. So sometimes the patient himself, they think like it's perceived thing, that they thinks that I am mentally ill, now I should avoid some social gatherings because I am mentally ill, I am not healthy, that's why other persons they can discriminate me. So this type of things here considered as internalized stigma.
All right. See, in medication status you mentioned as regular and irregular. Is
Yes.
it the correct term which we use actually? Is it, I mean, like, are you talking about compliance of medications, or what does it regular and irregular means here?
Yes, sir, that should be compliance. It's supposed to be compliance
That's
medication.
what I feel. All right, and you have taken 30 patients, right?
Yes, sir, because during the data collection period, COVID-19 was there. So during that time, actually, it was planned was to 80 sample, but previous year record, from the previous year record, it found that only 108 patients visited to our tertiary mental health care setting. So data collection period was only 3 months. So based on that, decided that we have to take only 30 samples.
All right, and the scales which you have used are standardized scales?
Yes, sir, standardized.
And have you taken permission?
Yes, sir, I took permission from the authors,
okay, all right.
developers.
Any other clarifications from the group? Okay, nothing. We'll move on to the next.
Thank you.
Ms. Pinky Chetia is our next presenter. She is PhD scholar, Department of Psychiatric Nursing, LGB RIMH, Tezpur.
A very good evening to everyone present here. So I am Ms. Pinky Chetia, PhD scholar, Department of Psychiatric Nursing. So my PhD work is on parent-mediated intervention in children with autism spectrum disorder. So as a part of my thesis, not as a part of my thesis, so this as a part of my research work, I am presenting a concept paper on this topic. So these are the contents of my presentation. So autism spectrum disorder is a neurodevelopmental disability that is associated with impairments in social reciprocity, communications, and behavior, and has an estimated global prevalence of 0.5 to 1%. It has severe effect on the social development of children into adulthood with substantial economic consequences in terms of services and family-related costs. The prevalence of ASD in India is between 0.4 to 1.2%, which roughly translates into approximately 1.7 million individuals with ASD in the country. The two main key barriers to treatment are the access to lack of evidence for intervention that has been adapted and assessed for feasibility in low-income countries and shortage of specialist person into delivery of this intervention to larger population. So in 2013, the NICE guidelines has stated that social communication intervention were the only options recommended for the treatment of core symptoms in the children's. So research has shown that early intervention is the key in improving the lives. So many early interventions, including parents and caregivers as a key component of implementation to increase the child's exposure to intervention strategies. The families of children diagnosed with ASD in India face significant barrier to care, including a dearth of trained resource, lack of government or state fundings, which creates financial barriers in seeking this intervention. So in such a scenario, the need for the parent-mediated intervention program is amplified. Recent pediatric guidelines in India mention that parent training is used as a useful adjunct to the ongoing therapy. Unfortunately, the treatment gap in low-income countries is nearly 100%. So hence, parent-mediated intervention in ASD is not an optional extra or adjunct, but an imperative, vital, and very likely the mainstay of therapy for innumerable families with minimal or no access to these resources. So stating the need for parent-mediated interventions, usually parents and parent-mediated interventions form a vital role. The inclusion of parents in therapies delivered early behavioral interventions was found to have positive effects in increasing parent fidelity to treatment, reducing the child's behavior problems and parental distress. PMI has also been found to lead to better generalization and maintenance of skills than the therapies implemented interventions, and it is very cost-effective and valid way to boost the amount of interventions in a generalized setting. So professionals as consultant and parents as therapists mode can bridge this current lack. So stating the current scenario of parent-mediated interventions in India, a very few models have been tested and evidence-based practices in this field. So these are some of the study that has been done in India, but very few studies has been done in India. Now coming to what is parent-mediated intervention. So parent-mediated interventions are technique-focused where the parent is the agent of change and child is the direct beneficiary of the treatment. Focus is on the treatment featuring the core features of ASD as well as the maladaptive behaviors. It involves the parents as the mediator of intervention, focusing on joint attention skills, imitations, turn-taking, etc. So this intervention delivery can be done in a natural setting within everyday play activities or routine-based activities using parents as the main medium and you also using some of the behavioral principles as well. So when we compare the different types of parent-mediated interventions, they are different as evidence says that the primary PMI for the core symptoms as well as the complementary PMI. So maximum of the evidences says that this parent-mediated interventions is done for 12 to 48 months, which involves the therapist-led treatment. includes 20 hours per week sessions in the treatment process. So the early start Denver model is one of the evidence-based practice that has been stated. Parent-mediated interventions has been delivered by a variety of professionals, including special educators, speech pathologists, psychologists, and behavioral analysts, but there is no evidence of any psychiatric nursing carrying out such interventions in India. Some of the evidence-based models, such as the Early Start Denver model, the pivotal response training, the Project Impact, and JASPER, these are some of the evidence-based practices that has been tested in the foreign countries. Different types of outcome has been stated, such as child's communication and social development, adaptive behaviors, child's problematic behaviors.
You have 2 minutes left.
Yes, ma'am. Developmental as well as intellectual gains, and also it has parental outcomes such as parents' level of stress, efficacy, and coping. How the intervention works, so parents are the main medium and the therapist acts as a mediator in training the parents in these interventions. The different target areas includes here the communication skills, the pre-linguistic skills, social skills, play, cognitive performances, as well as the maladaptive behaviors. It can be done in individual as well as in group format. Training locations can be at school, at home, and community as well. Different modes of delivery of interventions has been tested effective, such as didactic instruction, video analysis, modeling, feedback, and role-playing methods. Now coming to reducing the intervention burden, online and telehealth delivery strategies has been developed. Co-parent support using the other family members as well in the interventions, as well as providing a flexible appointment sessions which can be easily accessible to the parents, which is very easy for the parents to access, as well as the other parental support. Future research implication states that newer programs can be tested, co-concomitant need for dissemination based on the interventions, and the challenge for the field is to build the evidence base in order to match the child with empirically supported interventions. Future directions also can be done in case of technology-assisted models. So in summary, caregivers has become an integral part
Time is up.
Intervention for infants. So integration vary in complexity, mode of delivery, time. While caregivers should not be the sole source, it can also include the other family members as well. So research can be done in this field, and physicians can consider the family resource, availability of motivation, and level of stress in the developing of this intervention. These are my references. Thank you.
Thank you for your presentation. Thank you.
Thank you.
I'm calling our last presenter for the day, Mr. Bishal Patanjia, MSc Psychology, HRDM Department of Psychology, School of Social Sciences, Christ University, Bangalore.
Hello everyone and good evening. My name is Bishal Patanjia, as mentioned by the anchors. And I am doing this study on dual challenges of musculoskeletal discomfort and well-being of tribal nurses in Northeast India, a mixed method study co-authored by Dr. Priyadarshini from Christ University and Dr. Michelle Chanley from Massey University, New Zealand. So moving ahead to give a brief introduction about MSK Health. So overall, in a global perspective, MSK has been affecting around 1.71 billion working population, with a major factor leading to work absenteeism, which is a recent WHO 2022 data. To shorten it, focusing on nursing practitioners, the work-related MSK disorder report around 80% among nursing practitioners. Now, moving ahead to what are the possible gaps in the current research is the existence that in the existing literature, the focus is primarily towards physical health, whereas psychological and social factors are not being addressed more. And qualitative evidence are although been found in Western studies. However, in the Indian context, no such studies have touched on how the nurses experience with regards to musculoskeletal and or psychophysiological health in general. So with this study, the intention is to holistically examine the multi-dimensional factor that impact MSK health and well-being of the nurses in Northeast India, with a critical factor looking into the coping mechanism and what are the possible institutional support they can provide to the nursing practitioners. So I have utilized the biopsychosocial framework, which allows me to explore all the three significant factors that influence the health of nurses. With the support of the literature review and the theoretical model, I have kept quality for the quantitative exploration being that I want to see the higher prevalence of upper body and lower body MSK disorder among nurses in any India, then MSK discomfort negatively associating well-being of nurses in any India, with qualitative objective being to explore the psychosocial factor that tend to impact, leads to MSK health. To explore the working experiences of nurses and to explore the need for interventions on psychophysiological health of nurses in India, in any India. So this is the framework in a pictorial format. Moving ahead is the research design. So I have used a concurrent triangulation risk mixed method approach, keep doing both the quali and quanti together simultaneously. Then I have used stratified, wherein I have used separately created stratas of that is public and private, and I have collected data from around 11 institutions, wherein who all have given clarification or to collect data from them. Then the procedure is I have got, the study got ethical clearance from the IRB team of Christ University. With an again additional approval was there, and participant completed a survey book which was circulated in an offline mode. Then the interview was conducted in person based on their discretionaries, and telephonic was also done based on the availability of them in the hospital. So for the quantitative, I have used the extended Nordic musculoskeletal questionnaire developed by Confid and Dawson, and with a cron alpha value of 0.8, which was of the studied population. Same goes with mental health well-being. I have used WHO 5-item well-being scale with a Cronbach alpha of the studied value being 8.8. And a semi-structured interview was developed validated by around 4 experts within the field, and a total participant I had was around 216 nurses, comprising of 185 female and 31 males. Age ranged from age were 3 groups: 21 to 35, 35 to 45, and 45 to 60. With regards to seniority, junior, mid-level, and senior, and sector divided was private and public. So these were my findings, where with regards to upper body, 5 factors were considered as far the Nordic MSK scale. Neck with an onset of 29.98 age and 20.45% being the prevalence, with shoulder 30.31, upper body 31.53, elbow 35, and waist and hand 32, with the prevalence in the other side. Same goes with lower body, lower back being 32.38
You
as
have
the
2
onset
minutes left.
age. Then hips, then knees and ankle, where around, with regards to upper body, 19.45% had the prevalence, with lower body being the highest of 28.06%. Now again, with regards to correlation, musculoskeletal had a negative bidirectional correlation with well-being. Then moving ahead to the qualitative factor, I have, the global theme for the same is being the factor impacting nurses' health, with an organizing theme of physical, psychological, and social environmental. Then individual and institutional level intervention includes individual level intervention taken by the nurses itself, and institutional measures versus received versus anticipated. So biopsychosocial factors, we had, biological or physiological factor, we had 4 basic themes, of which prolonged standing one of the major, followed by lifting heavy items, long night shift, and poor dietary pattern. Then with regards to social environmental, we had exposure to death and dying, lack of appreciation, and fear of making mistake. Then with regards to social environmental, lack of support, relationship and with colleagues and supervisor, communication issues, and violence from patients. Now, with regards to measures that were taken by the nurses itself, is talking to someone you trust was one of the core or the major measures that were taken personally towards them. Then listen to your body was another one, by either through exercise or through physical activities. Another is practicing spirituality and relaxation techniques, where while I was collecting the data, I did identify that most of the nurses were reading scriptures. They were trying to, console themselves through some form of, God or sort of thing that helped them to cope up with the entire factor. Now the entire next is staying hydrated. Now coming to
your time is up. Kindly finish it.
Now coming to the institution level measures taken and anticipated, yoga and meditation were given by the hospital. However, they expect them to take those measures in a more frequent manner. With regards to certified nursing assistant programs were also being catered. However, again, the nurses expect the quality of the program should be more enhanced. Now, with again, the nurses had a mix feeling for voluntary versus compulsory health checkup, followed by sick leave policies and nursing patient ratio being one of the major factors, as nurses tend to have, work more compared to the demand or the expectation they need from the hospital. Now, implications, self-care strategies like hydration and mindfulness practice could help them with managing their physical health as well as managing stress in a demanding work environment, encouraging open communication and support network, then implementing regular yoga and meditation sessions, and enhancing relevance and quality of professional development programs such as the CNA programs for better awareness, and then additional institutional policies regarding health checkups and sick leaves. So here are certain limitations with regards to qualitative limited sample size. Self-report data possible could report bias. Again, cross-sectional data could be developed towards a longitudinal study, and specific focus on Northeast community, so it could be generalized or replicated in larger population. Further, with lack of detailed examination of organization factors, could be taken further with regards. So these are certain references I have utilized in the PPT, and yeah, thank you.
Okay, you have done study on musculoskeletal discomfort.
Yes.
I think in first year itself, body mechanics is one of the topics for nurses in their foundations. If they practice, they will be less affected. But I have some clarifications, like you have taken male and female.
Yeah,
there will be difference in their musculoskeletal abilities, right?
With regards to gender, my criteria was to see the overall prevalence. So when I went through the data, like around 214, so I did see a difference on an overall, not regards to just gender. So I took differences on senior. I took data on demographic data on age, gender, and seniority. So with regards to that, there were no such difference. So the difference were not significant. And overall, when I checked the difference, the significance as a whole, the significance was much stronger compared to the overall, or like,
so why I ask this question is when comparing men and women, and your age group is up to 60, right?
Yeah, 60.
60. The women are going through various hormonal changes, and it can affect their musculoskeletal, their calcium deficiency, menopause. When some homogeneity we have to maintain between male and female, right?
Yes,
so starting from the body weight, it's
sure,
a question.
I'll incorporate this feedback. It's very
That's
good
what
for
I
me
asked.
to
The study is okay, and this area we are not much focused. Musculoskeletal, it's a real pain that nurses experience. A lot of lifting one patient, they have back pain, majority are, and they have to maintain their well-being. That's your question.
Yes.
But comparing with the physiological features and their aspects, like I have told you, hormonal changes, everything, there will be a disparity.
Yeah. All right, thank you so much for the feedback.
Anybody else want to ask any questions? Or, sir?
Okay, first of all, thank you so much for having interest on doing a study on nurses. I think you're having a psychology background, and you chose to really work on nurses and come and present in a nursing forum. Congratulations, thank you so much for that. And I just have 2 or 3 clarifications, and can you just tell me about the strata which you have chosen.
Yeah.
Strata.
So
You said 11 hospitals.
So initially I have chosen around 20 hospitals. So based on their clearance and approval from the authority, I have got around 11 hospitals who had approved me to collect data both physically as well as virtually. So with that, I have created stratas, as in mostly 10 private and 10 public. So that's how I have created 2 stratas of public and private. And with that, I have used snowballing, where from that particular stratus, I have used snowballing to scatter and get data from each of the stratas.
Okay. And this study you've done on nurses working in tribal areas, or,
No,
or
both public and private.
you have mentioned it as tribal nurses. Tribal nurses.
Yeah, tribal nurses.
Means like only nurses who are working in tribal regions you've taken.
The population is tribe, not people who were in the tribal community. It's more of like, for instance, the Bodo community. They were working in the hospital.
Nurses belonging to tribal group, or nurses who are working in tribal hospitals, in tribal areas?
The other way around, the first
other way.
front.
Okay, I think it is not very clearly mentioned there. That's fine. And you have done your interview through in-person as well as through telephonic means also,
Yeah,
yes?
in-person.
Both.
In-person and telephonic.
How many telephonic interviews?
Telephonic, 1 or 2, ma'am.
1 or 2.
And the others were all
In-person interviews. Like, was there any distinction between these two, like when you were doing an analysis, data analysis? Like,
I think yes, because when I was collecting
because
data.
sometimes non-verbal clues are also playing a major role when you're deriving.
Yes. So, what difference I have observed while I was collecting data with regards to interview is that when the in-person interviews were most, I think there might be some form of hesitancies while they were sharing some information. While with regards to telephonic, they were more open, they were more clear. Could be those are certain things that might have influenced
probably in telephonic interview you didn't have much hesitation. They were very much open in sharing their
they were very
experience.
much opening when it comes to telephonic interviews.
And somewhere in seniority you mentioned as junior, mid-level,
Yeah.
senior, like that.
Yes.
Like how did you categorize that?
So-
I mean, like based on what actually?
So I have also used a demographic checklist along. So while I have sent the booklet includes 3 tools. The first one being the demographic checklist, which include the following demographics with seniority factors as junior, mid-level, and again with the, you might be asking how is it defined?
Based on what?
Yeah. So with regards to juniors, it's 1 year to 5 years of experience in the hospital. 5 to 10 plus year, 11 plus year is mid-level, and seniority is plus 11 years.
Now, is this something which you have arbitrarily decided as an investigator, or some references?
Yeah, the same tool has been used in other studies as well.
Okay. All right. Thank you. Is there any other clarifications?
Other musculoskeletal issues, or you just took the ones who just had the aches and pains?
Yeah, so with the tool which I use, the Nordic Musculoskeletal Discomfort Questionnaire, I use an extended version which allows me to collect, it has around 90 items. So each, and also divided into sections like per week, within 4 weeks, 6 months and 12 months. Right. So that makes that nurses should have at least 1 year of experience. So in the hospital as a working professional. Right. So with that, they assess for each particular sections, such as from the head till the toe. It gives you dimensions, and based on that you define whether the person have on this particular dimension they're having more, or and that helps me to.
So did you take up varicose veins because of long standing, or the nurses working in operation theaters and all, or you just took musculoskeletal issues?
So only the musculoskeletal overall, with the dimension telling me to, like, even the dimensions, the higher dimension prevalence also was one of my criteria to identify interview participants as well. So based on that criteria only I have utilized that. Yeah.
So in the strategies, I think you said that self-care strategies, you advise them to for hydration.
Yeah, because.
And for what else?
Hydration was there, and meditation was one of the key factor. Yoga and meditation was one of the factor which almost all the interview participants recommended that they want, or should have been in the
I think
institution?
brisk walking and if you talk about active and passive exercises, usually nurses will neglect
Yeah.
looking after themselves. So that is also equally important. Of course, yoga is also there.
Thank you so much, ma'am.
Thank
Thank you.
Here we culminate today's scientific paper presentation. Thank you, judges, for minutely evaluating our participants. Thank you all delegates present here for their valuable opinions. And biggest thanks to our participants. So enthusiastically they presented their research papers. Now before the dispersal, kindly have some tea outside. See you tomorrow. Thank you.